To all our esteemed national faculty for taking part in this session. And this is day 2 of our Stemi Council CSI National Conference. And I'm very proud to say that we have a very eminent faculty throughout the day. And we would like to start our first session, which is a very clinical session on STEMI management difficult decisions. And we have, I would request our chairpersons, Dr. Ajay Kumar Sinha, Dr. Anil Kumar Behrani, Dr. P.J. Nathani, Dr. Sadanand Shetty, and Dr. Shashi Mohan Sharma to start the session. I would request everybody to please stick to that allotted time, because we would like to have discussions at the end also. There's 2 minutes allotted for discussion at the end. So I will request the honorable chairpersons to begin the session. Thank you, sir.
Thank you, Dr. Naik. I'm Dr. Bharani, and it's a great pleasure. And my sincere thanks to Nitish for this opportunity and organizing such a wonderful meeting. I attended it yesterday. It was today we begin with this session on STEMI management, the difficult decisions. And my co-chairs have already been told by Dr. Naik, and the first talk will be by Dr. S.N. Rautrai on low-dose intra-coronary thrombolysis. Should I ever be considering it? And this addresses actually the microvascular resistance that we encounter and how to handle that. I request Dr. Rautrai to please present his slides.
Just a small correction to Dr. Rautrai is busy with his brother who's a little sick, and Dr. Deepak Ranjan Das will be presenting.
Dr. Deepak Ranjan Das, please present the slides.
Yes. I think my screen is visible now.
Yes, we can see your screen.
A very warm good afternoon to one and all. In fact, this topic was essentially expected to be presented by my teacher and my professor, Dr. Satyanarayan Rautrai. He is indisposed due to some acute family problems, so I'll be presenting on his behalf. The context is low-dose intra-coronary thrombolysis. Should I ever consider this? Now, what is the need of such therapy? The primary PCI is currently the gold standard of treatment for ST-elevated myocardial infarction. But presence of massive intra-coronary thrombus is a challenging scenario during primary PCI. This leads to unfavorable outcome due to slow flow, no reflow, failed aspiration, stent thrombosis, and different other complications. The different modalities to address this issue, like thrombus aspiration, thrombectomy, distal protection device, could not prove their superiority in multiple randomized control trials. With these existing evidence, exploring alternative methods which can dissolve the thrombus and improve the epicardial blood flow, this novel modality was assigned. Now, this modality is basically an amalgamation of past into future, because we know that intra-coronary thrombolysis was used in many centers of the world before stents became a routine, and primary PCI showed good outcomes in randomized clinical trials. The discouraging results from intracoronary thrombolysis during that time could be because of two things. One is the drugs, and second is the dose. The commonest drug which were used during those time were either streptokinase or urokinase. And there is no standardized dose, unlike systemic thrombolysis, where you know exactly what amount of streptokinase needs to be given or what amount of urokinase needs to be given. But there is a resurgence of interest in intra-coronary thrombolysis during last 5 years, following the seminal article by Dr. Kelly et al. In Catheter Cardiovascular Intervention, which got published in 2005. And the article was titled Safety of Adjunctive Intra-Coronary Thrombolytic Therapy During Complex PCI, Initial Experience with Intra-Coronary Tenecteplase. The most important points are the concept of adjunctive intracoronary thrombolytic therapy, and second is intracoronary tenecteplase. Here, what we find is the drug is a new drug as compared to the days when intracoronary thrombolysis was tried. And here, it is not exclusively the thrombolytic therapy, but it is an adjunctive intracoronary thrombolytic therapy. What is the concept behind this treatment modality? The large thrombus burden in Stemi is the single most important predictor of distal embolization during primary PCI. And this occurs primarily at the time of either wire crossing or balloon dilatation or thrombus aspiration or stent implantation. And large multicentric randomized studies like TEST, which utilized thrombus aspiration, or TOTAL, which utilized thrombectomy, could not prove the utility of these procedures due to the ultimate negative outcomes of these trials. So the pre-procedural embolization leads to obstruction of microcirculation at the distal ends, which produces unsatisfactory recovery of myocardial blast, consequently less improvement of LV function compared to the improvement in epicardial coronary blood flow. So this novel modality tries to restore the blood flow in the epicardial as well as microcirculation without going for the standard PCI with its own limitations in selected subset of patients, that is young patients and patients of Stemi who have a relatively early presentation with a cath lab capable center after the chest pain. The inherent complications of stent implantation in a primary PCI with a high thrombotic milieu can be avoided with this modality. What are the procedural details? Usually the access can be made either through radial or femoral route. You could use either 5F or 6F angioplasty guiding catheter. Intracoronally, presently the drugs which are used are either altiplase or tenecteplase, and the intracoronary dose is usually 1/3 to 1/5 of the calculated total systemic dose that have been tried in different case reports and case series. And subsequently, the 2/3 to 4/5 of the doses are given through the intravenous route. And then heparin infusion is maintained for 24 hours to keep an APTT 1.5 to 2 times upper limits of normal. And these protocols are not followed by all the centers or all the people who have come out with their publication in different international journals. Everybody has made his own modulations as per his own convenience, because there is no standardized guidelines by any of the international societies about how exactly to go about it. And then you can do a check angio after 4 hours. If you have put a femoral sheath and gone for a femoral access, usually you can remove the sheath after 12 hours, or if you have put a radial sheath, you can do after a check angiogram. How do you assess the successful reperfusion? Usually, you can do ECG, and if you have ST resolution greater than 50% of the baseline, this is a very useful surrogate indicator of both macro and microvascular perfusion. Different imaging modalities like IVUS or OCT or CMR or SPECT can be excellent adjuncts to establish the efficacy of treatment modality conclusively. However, the most authentic data have come from evaluation of cardiac magnetic resonance imaging in subsequent stages. So, what are the resurgences of this intracoronary thrombolysis? What are the real evidences? in 2009, Caesar et al., they have demonstrated a trend towards benefit utilizing this as an adjunct to primary PCI on long-term infarct size, volume, and function. But the drug which they used was streptokinase. Subsequently came a randomized trial which got published in American Heart Journal, the dissolution trial done by Greco et al., and they have included 102 patients, but they could find some usefulness of urokinase before actually doing thrombectomy in patients undergoing primary PCI. The drug he used here was urokinase. And after that, in 2019, we had a publication in JAMA from the T-time group by Dr. McCartney et al., where they have done a randomized trial. They have taken 440 patients, but the patients were unselected STEMI patient, and they had used altiplage. This did not reduce the microvascular obstruction, but the assessment parameters were contrast MRI. So it was definitely an objective assessment parameter. What are the important case series published from India? It got published in 2018 Indian Heart Journal by Dr. P.B. Jagopal et al. From Kerala. They reported 9 patients, aged between 27 to 55 years, 8 male and 1 female. All the patients were CLIP class 2 or class 3. Successful recanalization was in 8 patients, with myocardial blast grade achieved 2 to 3. ST resolution greater than 50% in all patients. There is no in-hospital mortality or stroke or major bleed. 3 patients had ventricular fibrillation, mostly due to reperfusion, occurred between 30 minutes to 1 hour, but all of them were cardioverted successfully. 1 patient had urethral bleed, which was managed conservatively. The short-term outcome, that is 1 month post-discharge, was satisfactory in their series. But the real data is going to come from a trial which is known as RESTORE-MI, and this trial might prove to be game changer in the context of low dose intracoronary fibrinolysis. The University of Sydney is the sponsor of this trial. It will be a multi-center, randomized, double-blind, placebo-controlled trial, typical of evidence level A. And approximate STEMI patients who are going to be enrolled will be around 500. The measurement of damage to the microcirculation will be done by calculating IMR, that is Index of Microcirculatory Resistance. That will be assessed by a pressure-tipped guide wire put into the infarct-related artery. And the IMR level greater than 32 will be the criteria for inclusion of people into this trial, indicating high microcirculatory obstruction. After they are enrolled, they will be divided into 3 arms. 1 arm will be given 1/3 the dose of calculated dose of tenecteplase. They will be called as low dose. Then there will be ultra low dose where the tenecteplase amount will be 1/6 the standard dose calculated, and the 3rd arm will be given placebo, which will be sterile water. So besides the standard parameters of assessment, cardiac enzymes at baseline and discharge, along with cardiac MRI at discharge, means 3 to 7 days after primary PCI, and at 6 months PCI will be done. So the quantification of infarct size will be exact and objective. The enrollment is likely to end on 31st of 2022, and estimated study completion date is 31st December 24. So that will really throw some conclusive idea about what will be the real utility. But the final key take-home message will be, it should not be advocated as a routine use. Proper selection of STEMI patients is vital. That means STEMI patients in which situations, after doing an angiogram, you find a thrombus grade 4 or grade 5 thrombus, because with lower thrombus burden, we don't expect it to provide really definite benefit. And appropriate dose of the fibrinolytic agent may be crucial for ultimately the risk-benefit outcome, because if the dose is high, the patient may land up with a intracerebral bleed or a major bleed. And assessing that the conventional techniques are not going to establish optimal microvascular flow in the patient, and in such a patient, delivering this modality of therapy is the cornerstone. And ultimately what we can suggest is it can prove as an useful adjunct to primary PCI in complicated situations with high thrombus burden. Thank you for your patient hearing.
Thank you, Dr. Deepak Ranjan Das. You did a very nice presentation. And we now have Dr. Satyavan Sharma, Dr. Satyen Tiwari ji, who will talk about routine stage PCI post-STEMI. Is this pathway the best strategy? Dr. Satyavan Sharma, Dr. Satyen Tiwari ji.
Good afternoon, everybody, all the chairpersons. Thank you, Dr. Nitish, for giving me this opportunity to speak on a very important topic, and which has a concern. And the topic is the routine stage PCI post-STEMI. Is this always the best strategy, or what's the exact strategy as decided by the experienced operator? So, as we all know that approximately 50% of the patient with acute MI, including the ST segment elevation myocardial infarction and non-ST elevation MI, have multivessel coronary artery disease.
Satyendra, you can make this slide show, big.
Okay.
Yeah.
Just a minute.
Yeah.
Slideshow. Just a minute.
Yeah. Yeah. Okay. Correct.
Okay, can you see now?
Yeah. Correct, Satyendra. You can carry on.
Should we, so the question is, should we complete the revascularization in patient presenting with the STEMI elevation with multivessel disease? The current ESC guidelines assigned a class 2 level A recommendation to complete the revascularization in patient with STEMI with multivessel disease. So the question is whether the complete revascularization during the index procedures versus the stage multivessel PCI, which has a better choice. So most of the studies supports the concept of complete revascularization in patient with acute myocardial infarction. But there is a dilemma on the optimal timing of multivessel revascularization, whether it should be done with the index primary procedure or as a stage procedure. So the potential advantages of doing the immediate multivessel primary PCI is one is the prevention of recurrent ischemia and infarction, which is the most important. Second is the improvement in myocardial function in the early phase after acute MI. Third, the lower risk for bleeding and vascular complications, and also the favorable effect on healthcare cost may be the additional benefit. So a pre-specified subgroup analysis of the CVL trial showed that the infarct size following the complete revascularization, if you are doing in the same sitting, in the same stage in STEMI, patient which has a assist by cardiac MRI was significantly smaller in a multi-vessel primary PCI as compared to when you do a stage multi-vessel PCI group, and it was statistically significant. But at the same time, there is a downside as well. There is an immediate if you do a stage immediate, what's the harm? What's the potential harm? One is the poor assessment of the lesion severity in a non-culprit patient, because that lesion may be a chronic total occlusion. Secondly, the prothrombotic and the inflammatory milieu by additional stenting can be lead to a slow flow or prolonged. And thirdly, the prolonged procedure time in the catheter lab may also lead to acute kidney injury due to increased contrast volume and also have the high chances of complication rate. So whether one should go ahead with the immediate multivessel PCI or a stage multivessel PCI, the good point in doing the immediate is that there is a potential prevention of the recurrent ischemia and the infarction. There is a decreased hospital length of the stay. But at the same time, the prolonged procedure time and increased contrast volume may lead to the acute kidney injury, as well as there is a poor can be a poor assessment of the non-culprit dominant vessel. If one are going to a stage multi-vessel PCI, then the benefit is that you have a time to assess the benefit versus risk of the PCI for a non-culprit vessel, and there is a potential use of the non-invasive testings. But the downside is there is additional risk of PCI excess, the procedure cost, further stay in the hospital, and then late stage PCI may not be beneficial. So what are the factors affecting the timing of the non-culprit dominant PCI? The factors which favors the multi-vessel PCI during the index procedure. One is that if there is an ongoing chest pain or arrhythmia is going on, there is a potentially hemodynamically unstable patient, unstable non-culprit lesion, plaque with large area of myocardial at risk. Infarct artery required little time and contrast. The anticipated simple PCI of the non-infarct vessel is there, a type A lesion, one can go and do it at the same sitting. And the patient and catheterization layer preference is also there. So what are the factors which favors the stage multi-vessel PCI? One is the patient get stable. There is a chronic kidney disease. You have already have a prolonged procedure time in the one sitting of doing the culprit vessel. There is a complex lesion in a non-infect vessel, whether patient have a chronic total occlusion. And then patient and cath lab preference is also very important. So there have been only few small randomized controlled trial in the setting of Stemi who compare stage versus the primary multivessel PCI. The Politi et al. Reported a randomized controlled trial of around 214 patients with Stemi and with multivessel involvement. And they have three strategies. One doing a simple culprit vessel only, or they do a multi-vessel primary PCI, or do a multi-vessel stage PCI. So the Mays ratio was least in a person who you are doing a multi-vessel primary PCI. But the limitation in this randomized control trial was that it was a single center study. There was a small sample size around 214 patients, and their low rate of drug-eluting stent use was less than 10%. The role of intra-coronary imaging has been recently assessed in the complete OCT sub-study where 93 patients randomized to a non-culprit dominant PCI were included with the aim to determine the prevalence of thin cap fibroathoma by the OCT in a severe lesion and to see whether is it a vulnerable plaque or not. So a severe lesion more than 70% more commonly contain vulnerable plaque as compared to a around non-obstructive lesion, and with about half of the patient having at least one obstructive non-culprit lesion has a thin cap of fibroathoma. And these findings highlight the increased frequency of vulnerable plaque in patients with Stemi and hint at the future need to use intracoronary imaging in such subsets of patients to decide whether in a non-culprit lesion one should go ahead with doing in the same sitting or do in a stage procedure. So other important question is the Stemi with a concurrent chronic total occlusions. We see up to 15% of the patient presenting with a Stemi have a concurrent chronic total occlusion, and usually been excluded from various randomized clinical trial or as in the complete trial. The Explorer trial is the only study so far evaluated the impact of CTO PCI of a non-infarct related artery after primary PCI of around 300 patients. They randomized to early PCI of the chronic total occlusion, that is doing within a week, or a conservative treatment. The procedure success rate was around 75%. The Explorer trial at the 4-month follow-up, there was no difference were found between the group of outcome, means the left ventricular ejection fraction or left ventricular end diastolic volume. It was equal in whether you are doing a CTO PCI arm or a non-CTO PCI arm. All the patients who underwent a PCI of LAD CTO had significantly higher ejection fraction compared with those patients who are treated with the medical therapy. So if you have a LAD CTO, one should go ahead and do it. The third important subset of patients who are in cardiogenic shock. So among patients with acute MI, 5 to 10% of these patients, they present with a cardiogenic shock and have a high hospital mortality as far as 50%, in spite that you do a primary successful PCI. So a strategy to treat non-culprit lesion present in up to 80% of the patient with cardiogenic shock has been subject to controversy during the past years. The culprit shock trial of around 700 randomized patients of acute MI and cardiogenic shock, the culprit only PCI were compared with the immediate multi-vessel PCI, including one of those is a CTO. So patient allocated to the culprit lesion only PCI group showed lower rate of primary endpoints at 30 days. At 1 year follow-up, all-cause death still tend to be higher in the immediate multi-vessel PCI group. So with no mortality difference between 30 days to 1 year. So the rate of rehospitalization for a heart failure and repeat revascularization were certainly lower in the immediate multi-vessel PCI than the culprit only PCI group. So according to these results, in 2018, ECIF guidelines a little more updated these guidelines of the routine revascularization of the non-culprit vessel in MI with cardiogenic shock and during PCI as class 3. So one should be very careful in doing a non-culprit PCI in a cardiogenic shock patient. So the operator should judiciously use his experience, and more than 50 of these persons underwent resuscitation before the PCI. So death in the immediate multi-vessel PCI group was mostly due to the brain injury, and the CTO success was around 80%. So the revascularization of a chronic total occlusion in the non-culprit vessel during the index procedure would likely not to be routinely intervened in clinical settings, number one. Thus, whether anticipated simple PCI of a non-culprit vessel during index procedure is beneficial or harmful is still unclear, especially in a non-resuscitated patient. So this is the summary of the whole concept that patient of acute MI mostly have a Stemi or non-Stemi, half of them have multi-vessel. If they are a cardiogenic shock, then do a culprit vessel only PCI. Or the culprit shock showed that you can do a stage multiple PCI as well. So if they are not in a cardiogenic shock, then PCI of the culprit vessels, immediate multi-vessel PCI is as shown by all these 4 trials. But at the same time, the stage multi-vessel PCI can be done by these 2 trials. So to conclude, the complete revascularization in patient with acute MI and a multi-vessel coronary artery disease should be considered during the index PCI or at a stage procedure when feasible and applicable. So optimal timing of the non-culprit revascularization, the artery is non-culprit, then appropriate lesion assessment in a non-culprit vessels and the best treatment strategy for patient with cardiogenic shock remains uncertain. So if you have a complex lesion of LAD, then one should go ahead and do it. But a non-culprit is a RC or some circumflex, then the operator experience is more important. Thank you very much.
Dr. Sarath Chandra, next topic, yeah. late presenter Stemi. What is the best strategy?
Good afternoon, everybody.
Yeah, yeah.
Yeah. So my slides are visible now?
Not yet, not yet.
Yet?
No, not yet. I don't know. We are not able to see.
Not able to see the slides.
No, no.
So yeah, it's okay. So it's visible
Yeah.
now?
Yeah, yeah, yeah.
Okay,
Carry on,
you.
yeah. Slideshow.
So my topic is the late presenter STMI. What is the best strategy? So what are the late presenters? When the symptoms duration is more than 12 hours, they are called as late presenters. And around 10 to 40% of ST elevation MI are late presenters worldwide. So the data, this is old data, it is the 2009 data, but recent data showed it is around 10 to 15%. And around 30% of ST elevation patients are late presenters in India. And these late presenters carry a high risk for morbidity and mortality later on. So what are the factors related to no reperfusion therapy? The common factors are age, when the age is more than 75 years, prior CHF, MI, CFG, female gender, diabetes, pulmonary edema, systolic pressure of less than 100, and contraindication of thrombolysis, and spontaneous reperfusion. So these are the factors related to the no reperfusion therapy. So why there is 12-hour limit? Because there is no mortality benefit seen with fibrinosis beyond 12 hours, and sometimes it can lead to harm also. And such, so that's why there is limit of 12 hours. And these late presenters are not included in the trial showing superiority of primary PCI over fibrinosis. So if the late presenter is symptomatic or unstable, then, and if the patient is in cardiogenic shock, severe angina, then PCI is class 1 recognition for the such group. But if late presenters are asymptomatic, stable, so there are no clear-cut guidelines. Guidelines vary and approach is tricky. So if we see this American guidelines, delayed PCI of significant stenosis in a patient in a patent infarct artery greater than 24 hours after stable MI in a stable patient, it is a class 2B indication. And similarly, delayed PCI of totally occluded artery more than 24 hours asymptomatic patient, it is class 3 indication in ACC AHA guidelines. If we see that ESC guidelines, reperfusion therapy with primary PCI should be considered in patient presenting late 12 to 40 hours after symptoms onset. This is class 2A indications. So coming to some important trials of late presenter MI. This is BRAVE trial. Here, mechanical reperfusion in patients with acute myocardial infarction presenting more than 12 hours from the symptom onset. Here, 365 patients from 12 to 48 hours of symptom onset without persistent symptoms were randomized to PCI arm and medical therapy. And here, the trial concluded that NV infarction size in PCI was less as in comparison to medical arm. Similarly, the percentage area of LV salvage by PCI was much better than the medical arm. So, and their 4-year mortality is reduced by 45% in this invasive arm. And another important trial, the PLACS trial, this is a Polish registry, real world ACS patient. Here, more than 2,000 patients between 12 to 24 hours of symptom onset were randomized to PCI arm and medical arm. And here, the total 12-month mortality in all patients decreased significantly in the invasive arm. And similarly, 12-month match mortality also decreased significantly in the invasive arm. So this is the landmark trial, the OAT trial published in NEGM 2006. Here, more than 2,000 patients between 3 to 20 days after symptom onset with LV ejection fraction less than 50% or proximal large vessel were enrolled. So this was a primary negative trial. It showed no mortality benefit by PCI over optimal medical therapy. And angina and repeat respiration was significantly less at 7 years. So, but OAT is not the dead end for the road of occluded artery. It has major criticism that it has a long exclusion list. Like OAT is not representative of real life ACS population like left main patient, TVD patient, severe angina, heart failure, unstable arrhythmia patient, renal dysfunction. These patients were not enrolled in OAT. And median time to revascularization was 8 days post MI. It is too late. Maybe some earlier time is better. And cardiac, as we know, the cardiac mortality gradually increased. LVF ejection decreased below 40%. And OAT population had only 20% population had LV ejection less than 40%. and infarct related artery was RCA in around 49%. So more of the dead end for all the occluded arteries. So here comes again important trial by Martin Buss published in European Heart Journal. Here the infarct size and myocardial salvage after primary angioplasty in patient presenting with symptoms for less than 12 hours versus 12 to 17 hours were compared. Here 396 patients within 30 minutes to 72 hours after symptom onset were enrolled, and SPECT MPI was performed acutely before PCI and after 30 days. And they concluded that final infarct size is larger in late presenters than early presenters after primary angioplasty for STMI. However, substantial myocardial salvage can be obtained beyond the 12-hour limit, even if the artery is totally occluded. So here you can see the benefit of PCI in up to 48 hours. So this 12-hour limit is arbitrary for primary PCI. So this is the RCT published in JACC 2008. Here you can see that death is significantly less in the primary in the PCI arm as compared to the medical therapy, and similarly change in ejection fraction from baseline to follow-up favors PCI. And this is again important trial, Swiss 2 trial. It had 201 patients with recent MIs and silent myocardial ischemia verified by stress imaging, and with 1 and 2 vessels were enrolled. And they concluded that PCI compared with anti-ischemic drug therapy reduced the long-term risk of major cardiac events in this trial. And this is the trial published in Circulation Cardiovascular Intervention 2018 by Naper, Christian and et al. So they showed that here the 865 STMI patients with signs of ongoing ischemia presenting up to 12 to 70 hours of symptom onset, they are compared with the STMI patient presenting less than 12 hours. And they underwent cardiac magnetic resonance cardiac MRI just after index PCI and 3 months later. And they concluded that STMI patient with signs of ongoing ischemia treated with primary PCI from 12 to 78 hours after the symptom onset had less myocardial salvage and developed larger infarcts also. However, a large proportion of patients achieved substantial myocardial salvage, indicating a benefit of primary PCI in the late presenting subsets. So to conclude, I would say that practical approach is when there is unstable patient, such patient should go for revascularization. And when the patients are stable patient but presenting in less than 72 hours, then these patients should go for angiography with intent for revascularization. If there is significant lesion, we should revascularize. If it is 100%, then it is also revascularized, because less than 72-hour patients were excluded from the O trial. So, but again, if the patient is stable, but they are presenting more than 72 hours, then such patient should go for stress testing. If stress test is positive, even if the artery is 100%, they should go for revascularization. And if stress test is negative, then they should be on medical therapy. Thank you. Thank you very much.
Thank you, Dr. Sharat Chand, for your wonderful presentation. Now we have Dr. Pratap Kumar will talk on minimal contrast primary PCI.
They should allow me to take the screen share, please. I don't know, not allowing. Now I can share?
Yeah,
yes, yeah. Please. Even my face, they are not allowing me to show. Oh, what to tell? Okay.
No. Some technically.
No problem. It's okay.
We would like to see you. Yeah.
I don't know. Can you see me?
Not yet, but it's okay. I think on. You start presenting.
Not as yet.
Okay.
Now?
Yeah, very good.
Very good. Thank you.
Thank you.
So the impact of the contrast-induced acute kidney injury is increased hospital stay, cost, as well as dialysis and death. How to reduce the mortality? Prevention is the key. So reduce the contrast volume is the ultimate aim of to avoid any zero contrast PCI. There are two important things. One is actually, there are some studies published with the people with the contrast volume should be less than EGFR, then there is no contrast-induced kidney injury. So my aim is to produce absolute zero contrast in patients. The indication of zero contrast PCI in my organization is eGFR less than 30 or the creatinine less than more than 1.5 or eGFR less than 45. In a patient is more than 75 years, LV ejection fraction less than 50%, and in the MI patients. We have done 43 cases and 66 vessels. We have done 2 non-culprit vessels in Stemi and 1 culprit in Stemi. So our complication so far is 0. So this is actually a patient with a clinical background of 61 years, female, acute inferior wall MI with LV failure. Patient had a PCI in stenting to circumflex in 2011. Now severe LV systolic dysfunction, CKD stage 4, ECG showing ST elevation in 2-3 AVF and ST depression 1 AVLV 5V6. Echo shows a global hypokinesia VEF of 30%, and we know it is inferior MI, but this is the angiogram. The angiogram is taken, which is actually taken one shot for the RCA, one shot for the left system. We can see both the vessels are included. The problem here is actually LMCA normal, LAD diffuse disease with the no flow limiting lesions. Circumflex stent is patent, OM2 95% lesion, RCA proximal to mid lesion of 95%. So you can see a primary PCI problems. What is a culprit vessel? We don't know. Severe LV systolic dysfunction, high creatinine of 3.53 and hemoglobin of 9.51. So what we did is actually we took a 7 French EBU, which keeping the angiogram in the other side. We took one wire to the circumflex, one wire to the OM. So after that, we took a 1.5 into 15 Maverick balloon and then an IVUS to the OM. We did not do any angiogram after that. This is the angiogram, IVUS. IVUS was taken from the OM to the circumflex. What we identified in the IVUS is actually the first run. We can see there is a significant disease of MLA of 1.3 in the OM part. We can see a distal landing zone of 2.25 vessel, and there is a 360-degree calcium in the mid, that is a junction between circumflex and OM. We could see a wire in the branch and the proximal landing zone. So what we did is actually we identified there is a 30 millimeter vessel. So we took a 2.5 into 32 stent, keeping the proximal stent as the marker. We will take a clear stent and identify that part. It is a 2.532 by seeing the distal vessel landing on the distal edge is 2.5. We dilated. After that, we took a 3 into 12. You can see that I have removed the wire from the circumflex and taken a rewiring into that. And then we took a 3 into 12 millimeter proximal, exactly proximal to the stent. Then we did a final IVUS. This is actually the IVUS show. What we can see from the IVUS is actually L6 to the OM. You can see we have not, because of the time not permits. Distal edge actually reference, we got 3.5. The MSA of 3.02, that is actually the maximum edge, actually 3.02. An adequate expansion at the calcified region, we got a 4 millimeter square, and the proximal edge is 4.52. We avoided multiple runs and multiple post dilatation only because it is a STEMI situation. So we went into the RCA in the same patient because we don't know the culprit vessel. This is actually the background. So with this, you can see there are 2 lesions. One is in the proximal as well as in the distal RCA. We have to cover these lesions. What we did is actually, we have taken the same projection. You can see the background injection, which is the angiogram projection. We take a wire. The first wire, you can see the proximal, the extreme left-hand side, you can see the angiogram. But we take actually, by understanding this projection, we take a blindly the wire into the RCA, that is a distal RCA. The second wire we take into the acute marginal or the RV branch. After that, we take a balloon dilatation of 1.5 and we do a first IVUS run. But IVUS run actually, you can see the IVUS is not going down. So we took a balloon dilatation of 2.512. After that, we do an IVUS run. This is actually the run 3, a pre-PCI IVUS run. What we could identify, you can see this is the thing we can identify. The distal landing zone of 3 millimeter vessel in the distal landing zone. There is a nearly a 360-degree calcium, but we can break the calcium by the balloon dilatation. A marker wire at the acute marginal branch, which we can identify this is a marker wire here. And we have the proximal landing zone almost 2 millimeters away from the ostium, which is a 4 millimeter sus. So there is a 4 millimeter proximal, distal is 3 millimeter. We have to take a 3.5 into 44 and a 3 into 44 because we got a measurement of nearly 75 millimeter length of the vessel. So we took a what we did is actually we have taken the acute marginal wire into the coronary sinus and keep 2 millimeters away from the ostium. So we took a 3.5 into 44, keep the wire in the coronary sinus. After that, we take one more stent, keeping the proximal wire. You can see that actually that is we take a clear stent. And then there is a 44 stent. After that, we do a balloon dilatation, the proximal part by 4 millimeter balloon, because we know that the proximal vessel is 4 millimeter. Up to the junction between the first and two stents, we take a 4 millimeter and post dilate. Then we do an IVUS again. This is a total IVUS from the ostium to that. So we got a 8.68 is the proximal part. We got only 4.88 in the mid part. We did not do a post dilatation because of this an acute MI. We did a mirror RCA MSC of 5.27. Distal RCA is 4.5, and a distal stent is actually no dissection, and it is 4.78. This is a second case. That was the culprit vessel STEMI. This is a non-culprit. This patient was admitted with a chest pain at 10 a.m. on 18/5 in a peripheral hospital. Patient was in complete heart block and reduced urine output. Planned for a primary PC, and they could not cannulate the culprit vessel. Referred to our hospital with a temporary pacemaker lead and on IV fluids. Patient was in oliguria and creatinine admission was 1.9. On the same day, the angioplasty was done with 15 ml of contrast in our hospital with my colleague without doing any shot in the left system. Output improved, but the creatinine increased to 3.4. So on day 5, we have to take the patient for it. This was the angiogram. You can see the angiogram looking like a patient was actually in a almost like a no reflow situation, and the patient was in actually complete heart block. You can see the heart rates not at all moving. These are the angiogram shots of the peripheral hospital. What we saw that actually the patient came to our hospital. What by my colleague actually, it was an anomalous RCA, that is why they could not cannulate. You can see that my colleague with one small, luckily the wire went inside. You can see the wire is going inside. This is an anomalous coronary artery at the high origin. He could pass the wire down. After passing that, the temporary lead is also kept from the outside. So what we did is actually, he did a 1.25 millimeter balloon dilatation. He thought it would be very big. After that, he took a shot. And then he took a 3.5 into 26 resolute tonic stent. This is actually, because it is an angulator way, he wanted to have a trackable stent. He dilated. This was the final result. So the total contrast used by him is 15 ml. So this is an angiogram of after primary PCI to the RCA. Angioplasty was done by my colleague on 18/5 after failing to cannulate RCA from another hospital and taken off 15 ml of contrast. Creatinine on arrival was 1.9. It is raised to 3.4. Next plan was a zero contrast PCI to left system with the minimum. Our plan was to LAD. You can see these are the only shots available, which is actually taken from outside. This we are taking a catheter here, keeping this branch vessel. This is an angiogram. It is an RIO caudal. The same projection I cannulate without taking an injection. What I did is actually, you can see the wire. I have a projection showing that I wanted to pass the wire into the ramus intermedius, not into the LAD. So my aim is to take the wire into the ramus intermedius with only this projection there. I don't take an injection. You can actually watch. I'm actually taking the wire down. This is the wire is taken. Once the wire is taken, we should see that the wire is actually, you can make a bend and take the wire down. I'll be seeing that this is the wire taken. Again, in the same projection, I just wanted to show you how the wire is taken. This wire is taken. See, you can see a bend created and the bend is going down. So it will not create any damage to the vessel. But we should be sure that what I've gone is exactly into the ramus. What I do is actually, I have taken an epicranial, which is another shot. So I can see this is the wire is actually in the ramus intermedius. So the next wire I have to take to the LAD. What I'm doing is actually, this is a wire again. There is a troublesome, it goes into the septal artery. Then I understood that I am in the proper place and the wire has gone down. Now the next is actually the third wire. This is the third wire entry. You can see the wire is coming down. This wire I wanted to take into the diagonal. So this is actually the two marker wires and one LAD wire. This is the way. You can see that the wire is going down. The wire is going down. Wire should go into the same angle as this one. This is angle. So the three wires taken. After that, what I did is 3 guide wires. One is in the LED, one is in the ramus, one is in the diagonal. So why we do an IVUS to the ramus to the LED, LMCA, because we saw there is a significant disease in the ramus ostium. So whether to do a complex intervention or not. We understood the proximal most ramus. That means the osteoproximal part is 9.85. There is no, this is actually LMCA part. This is 4.57. There is no significant disease. You can understand this is coming from there. There is a plaque there. You can see there is a plaque. I can show you the plaque. You can see the plaque is coming from here. There is a plaque here. And that plaque, you can see the wire here. This is the LED wire. And the osteoproximal part of the part is almost having a 4.57. So now that we do an IVUS to the LED. What we see is actually there is a 28 millimeter up to the diagonal. This is up to the diagonal. And there is a 27 millimeter post to that. So what we saw, the proximal part of the LMCA part is nearly 4 millimeter vessel. Distally, we can see there is a 2.98, that is a 3 millimeter vessel. This is a diagonal part. There is actually a significant disease across the diagonal. And you have seen a ramus across also, there is a significant disease. So there is a disease across the ramus, across the diagonal. So what we do is a 2.75 into 12 millimeter balloon across the diagonal and as well as the ramus. So what we did a 4 into 28 science expedition stent from LMCA to LED, and we have a Fibrillation wire into the ramus to the. What we do is actually we take the wire from the coronary, that is a ramus, and keep this was actually in the coronary sinus. So once we are in the coronary sinus, we know that you can have a 4 millimeter space away from the ostium. So we keep the wire like that. And then we dilate exactly up to the ostium of the LED, which is measured as 28 millimeters. So after that, we take another stent, which is actually a 2.75 stent, 3 millimeter stent, because the distal vessel is 3 millimeter. And we can actually dilate that. We remove the wire. You can see that actually the same wire, which is taken out of the diagonal, is coming back again. You can see the wire is coming back. And this wire is actually going into the LED through the stent stud, again without any injections. After that, we dilate exactly at the junction 3.5 into 12 at the junction of 2 wires. And the same filter wire we take out of that. This is actually an important step. I take the wire from the diagonal to the ramus because I wanted to understand that the ramus is actually pinched after that. So we do a 4 into 12 millimeter balloon, post dilatation at high pressure everywhere. Then a 4.5 exactly proximal to the ramus, and then we do an IVUS. After the IVUS to the LMCA to LED, this is the post run. We get a reasonably good result in this case. We can see LMCA is actually 11.6. We got 7.51. This is actually after stenting. And you can see there is an underexpansion in the 5.48 in the distal part, but the distal edge is actually having no dissection. What we did is actually a multiple dilatation of 3.5 in the distal part, and there is a 4 millimeter balloon at the proximal part. Then after keeping that, we do one most aggressive post dilatation in the IVUS. Then we got an area of 12.05 in the LMC, 11.4842 across the ramus, 11.414 in the ostial LED. We got nearly 6.002 and 6.5 in the distal LED. And we got a very good result. We are not stopping here. We will do one more IVUS to the ramus. And this ramus actually showing that there is no plaque shift is created. So after that, we just finish the case. So this is actually then take the wire. Zero contrast PCI in acute MI is safe and feasible. It can be attempted in both culprit and non-culprit. It will avoid dialysis in patients with acute MI. It requires skill, reasonable knowledge of sound is required. Thank you.
Thank you, Pratap. I think the last one now, Dr. Ullas Pandurangi on wearable or subcutaneous ICD. Dr. Ullas, are you there? Or?
Yes.
Yeah.
Let me be allowed to have my screen shared.
Yeah.
All right, Dr. Sadananda Shetty, it's such a pleasure to see you. And Dr. Nitish Naik, thank you so very much. You have put up such a wonderful show. Having heard the stalwarts of coronary interventions, I look very small here in this group because this is the electrical aspect of the heart. But it's a pleasure to be talking to all of you here. And I'm going to be talking about
electrical is first, Ullas. Electrical is first. If there is no electrical activity, then nothing. Heart is going to stop. Okay.
Yeah, Sadananda Shetty. Yeah, all right. So now I'm here today to discuss about two types of defibrillators, which are very rarely used, not only in India, across the globe. Specifically, wearable defibrillators and subcutaneous implantable defibrillators. And I'm going to be limiting this discussion to a specific clinical situation, and that is the post-myocardial infarction in the Stemi India conclave. Sorry. We all know the defibrillators, implantable or even the automatic external defibrillators, have been shown to prevent sudden death. Specifically with respect to the implantable defibrillators, when you identify a population at risk for life-threatening sustained VTVF, and if you are implanted at the right time, they have been considered to be the most superior interventions with respect to any one of the interventions when it comes to reviving the patient when he suffers the malignant ventricular arrhythmia. However, the ICD implantation decision is not simple. It's dependent on defining the ventricular substrate, what is the etiology, how bad is the substrate, and considering other factors to evaluate the future risk of sudden cardiac death. And most importantly, what is the overall survival of the patient when considering the comorbidities. The decision is not very simple because the risk stratification is not yet very well defined. There exist vulnerable periods in certain population, and for example, for example, post-MI less than 45 days is an important period where the vulnerability is so very dynamic. We cannot just label a particular patient in post-MI, early post-MI period, that this is the person who is going to be having at a risk, because everything is evolving. Whatever the factors we consider would be the reasons for ventricular arrhythmias. Among the patients who have an MI, and if you look at the time frame, one can make some three distinct time periods with respect to the evaluation for the risk of the sudden cardiac death. Early, that means from the onset of the symptoms of coronary syndrome to 40 days, which could include admission or outside, and followed by longer periods of the follow-up, which could be up to 6 months, and another period is more than 6 months. These have been defined based on the observations or the registries where the mortality rates and the events of the cardiac arrhythmias have been evaluated. And then this is quite empirical, this kind of a time frame. But many people follow this, and most of the guidelines advise us to follow the patients in these time frames. If you look at the early period, that's from the onset of the symptoms with or without admission, with or without any kind of a therapy, up to 40 days, it has been shown that the ICD implantation does not serve a purpose when it is something to do with the revival from the sudden cardiac arrest. However, we know that there could be another way of treating these ventricular arrhythmias, either automatic external defibrillators or the wearable defibrillators. So that is where the interest now is. Now, when you look at the further period of observation, which is beyond 40 days to 6 months and 6 months to many years, well, when according to the guidelines, if the person fits into lower than 35% ejection fraction, ischemic or non-ischemic cardiomyopathy, it is considered that the ICD is the standard therapy for the primary prevention. Even in secondary prevention, an ICD is indicated even after certain interventions like drug therapy or RFA. In the recent time, this particular situation, that is post 40 days of post-MI, subcutaneous ICDs are gaining role, definitely in the primary prevention of sudden cardiac death, but they have been also considered to be competitive to the implantable cardiac defibrillator system, which is considered as the standard care. Sudden cardiac death early after MI, what I'm going to be showing is a data registry which included more than 10,000 patients who have been followed up from the time of the onset up to almost like 4 years. What they have seen is the highest of the mortality due to sudden cardiac death due to malignant ventricular arrhythmia. The definition had been extremely rigid in this case. More than 10,000 patients who have been followed in this particular registry, which was published 2 years back. What is important is that there is a significant patients are needed to be protected from sudden cardiac death, but we do not have any particular intervention, typically the implantable defibrillator. For example, what you see in this graph, within 1 month, there is what is the maximum deaths due to malignant arrhythmias. For example, 2.25 to 2.5% per month of the patients within 1 month, if the ejection fraction is less than 30%, they may die of sudden cardiac death due to ventricular arrhythmia. We do not have a tool. Implantable cardioverter defibrillator, considered in this period of time, they have not improved the survival, either the cardiac arrhythmia deaths or deaths due to some other reasons. What does it simply mean? That the implantable cardioverter defibrillator may actually convert the ventricular arrhythmias into sinus rhythm at that point in time. However, post a sinus rhythm restoration, they may not do well. So it simply means the way the implantable defibrillators are treating is actually bad. Not that the therapy will not convert the VF into sinus. We require better tools to convert these ventricular arrhythmias into sinus rhythm and not by shock. Implantable defibrillators have consistently failed in many of the trials. One of the largest of the trials, for example, the MUST, which included not necessarily the immediate post-MI period, but a longer period of the follow-up. Almost like 16% of the patients in the MUST, a large trial, were included in the early, included patients in the early post-MI period. And there are some modes, for example, Dynamic, Best ICD, IRIS, and the Westmed series. Consistently, they showed that the implantation of a defibrillator endovenous systems early after the MI do not really work. They may reduce the arrhythmic death, but that will be blurred by non-arrhythmic deaths. So essentially, it means that the implantable defibrillator is not good in the early post-MI period. So we needed a solution. So what could be the solution? This is what the solution the people considered. Over a period of 15 years, there had been a significant advancement in the miniaturization of automatic external defibrillator. A wearable defibrillator is a miniaturized and a very advanced defibrillator system, unlike an automatic external defibrillator, which is kept in a public place. Now, there's this system which could be worn. For example, a vest is designed. For example, this is the garment, looks like a vest, which the patient may wear, which has the following components. There are adhesive electrodes, there's a gelling defibrillator electrode, and it can give a shock of 150 joule biphasic shock. It can store the EGM, and there are responses to the alerts. For example, in a sequence, the typical sequence of a variable defibrillator is this. A variable defibrillator is sensitive enough to recognize within milliseconds of the occurrence of a ventricular arrhythmia, and within 30 seconds there are so many sequences take place. The arrhythmia continues to be identified. The moment the arrhythmia is identified, it sets off an alarm which the patient might feel, and if he doesn't feel, there is going to be a siren which he only could hear. And after that, if there is no response from the patient with respect to the allowing of the therapy or disallowing of the therapy, there will be a loud siren and enough loudness to warn the bystander, and then there's the gel release and the shock delivery. When it comes to this sequence of events with response to the ventricular arrhythmia, it has been tested in more than 1,000 of patients. sequence works very well, but the utility has remained a question mark. For example, in the year 2013, when the large data was published, it's called a West defibrillator post-MI, not necessarily within 40 days. It included over a period of 1 year post-MI. It was a large observation of patients, included patients were more than 8,000. And there was an indication that a select group of patients who are not necessarily who are not necessarily candidates for the implantable defibrillators, especially when you look at the first 30 days following the hospital discharge, the authors considered that there may be benefit. And this led to the adoption of this particular observation by the ESC in 2015. And then they put in their guidelines that it could be considered as a class 2B indication, which was further agreed upon by the ACC that, again, the level of acceptability remains 2B. Whoever is having ejection fraction less than 35% post-MI within 40 days, the wearable defibrillators could be considered an alternative to the implantable defibrillator. However, a recent trial, which is again not as large as that, but more scientifically conducted, and there were certain more parameters were included, and it was published in 2018, more than 2,300 patient observation, and it raised really a big question mark on the utility of the wearable cardioverters. So the wearable defibrillator, the authors mentioned that it did not lead to significantly lower rate of primary outcome, including the arrhythmic death. And that is why the West trial, this particular trial, has made wearable defibrillators really as a not really a great option. Switching to another new, rarely used defibrillator system.
Excuse me, sir, because we're running short of time.
Recording stopped.
Can we just bring the talk to an end?
Yeah, so the subcutaneous ICDs have been considered to be preferred
Recording in progress.
prevention. So, for example,
Recording stop. Recording in progress.
am I audible?
Yes, sir, you're audible, but we have exceeded the time.
Maybe another couple of minutes, Ullas, couple of minutes.
Yeah, so I wanted to conclude here that the sudden cardiac risk early after MI, it is for real and it cannot be overlooked. Guidelines still fall short. So there's a need and an urgent upgrade to let us know how do we deal with them. Wearable defibrillators are a real and a feasible option, but we need to have a proper selection of the cases process. Subcutaneous ICDs are no less than transvenous ICDs. That is what is the data that is being gathered. And we should be making the patients compliant with the wearable defibrillators if at all they have been advised. So thank you very much. And I'm sorry that I exceeded the time limit.
I think we have no time for discussion. I think because we must thank all the speakers. It was an outstanding session. You can stop stop share screen, Ullas, if you are.
Yes.
And it was an excellent session. We had a great talk by starting with Dr. Das, Dr. Sarat Chandra, Dr. Satyendra Tiwari, Dr. Pratap Kumar, and finally Dr. Ullas. I think it's beyond, I think already 8 minutes past. Nitish, any time for one question or we have to go to the next session?
I think we will have to move on to the next session.
Okay. Thanks once again, organizer Nitish Naik and Suman Bhandari and Rakesh Yadav for giving.
Thanks, Dr. Shetty and my other co-chairpersons for such a nice, wonderful session.
Okay.
Thank you.
Thank you, everyone. With this, we bring to an end the first session for today, and we move on to the next session, which is case-based STEMI care. For this, I would like to invite the chairpersons for this session, Dr. Aditya Kapoor, Dr. Harshvardhan, Dr. Mohit Gupta, Dr. Rajiv Agarwal, Dr. Ramakrishnan, Dr. Shanmuga Sundaram, and Dr. Trivedi. I'd like to invite Dr. Harshvardhan to kindly begin this session.
It is going to be a very interesting session, and we are going to have discussion on 4 case-based studies. And for the first case, I'll invite Dr. Sumitra Rai to discuss a case of a 45-year-old male with anterior STEMI with window period of 16 hours and no chest at present. And the ECG is still showing 1.5 millimeter ST segment elevation and is a known case of CKD. What will be my approach? May I invite Dr. Sumitra Ray to discuss this case? Dr. Sumitra Ray, please.
Hello, good evening. Thanks, respected chairman and the delegates. Today, my presentation is a 45-year-old male with anterior STEMI with pain 16 hours ago, with no chest pain at the moment. ECG still showing 1.5 millimeter ST elevation, and he is a known case of CKD. What should I do, or rather, what should we do? Now, let's see. This is the ECG. Now it is settled almost from V1 to V4. You might see 1.5 millimeter ST elevation. Otherwise, the ECG is quiet. So it is a heart attack of some duration. Now, what should we go is the 2017 ESC guideline. That is the latest I can gather. And where it is shown that unless there is hypoxia of SpO2 below 90, you should not give oxygen. And our patient is stable, so oxygen is actually contraindicated, because if the saturation is not below 90, you should not give oxygen. Now, again, the patient there is no pain, so there is no role of opioid. Rather, we can give a mild tranquilizer. Now, this is the most important thing, the time frame of revascularization. And now, by definition, my patient is in the evolved STEMI, that is 12 hours to 48 hours. Now, you see, if this patient has got symptoms or hemodynamic instability or arrhythmia, then primary PCI, still the term used, mind it, it's primary PCI, is class 1 indication. But my patient is asymptomatic and stable. So again, primary PCI is indicated, but the indication is class 2A here. Now, even from the Cardiological Society of India, we published our recommendation in the same year, 2017. I was part of that. And here also we said 12 to 24 hours, not 48 hours here, 12 to 24 hours, and the patient is not thrombolized. Then if the PCI is feasible, cath lab transfer for the PCI, if clinical and or ECG sign of ongoing ischemia. We really did not mention what we should do if the patient is absolutely stable, but our intention was to reassess the patient and to look for ongoing ischemia by further test. If not, we can wait. If there is further ongoing ischemia, then we should go ahead with the coronary angiogram. Now, angiogram can be like this, which is a very bad LED disease, maybe total occlusion with other vessels normal, or you can have a nasty surprise on the table, getting this kind of angiogram with severe triple vessel disease and almost non-doable angiogram, non-doable for angioplasty. If it is doable, the idea should be a primary PCI to the infarct-related artery. No doubt about it, class 1A indication. But the second para is very interesting. New coronary angiography with PCI, if indicated, is recommended in patients with symptoms or signs of recurrent or remaining ischemia after primary PCI. So if it is a 2-vessel or 3-vessel disease, and if you think this can create problem or is creating problem, we should go ahead with further angioplasty. Stenting is of course recommended, just PTCI is obsolete now, and DES is obviously there, you don't get BMS even if you try. And radial access is recommended over femoral access if performed by an experienced radial operator. Nowadays, I think almost everybody is trained in radial, so radial is the standard approach. Now, IRA technique, routine use of thrombus aspiration is contraindicated, not routine, it's only bailout. And routine use of deferred stenting is also not recommended. After the deferred trial, it was rejected. Now, very interesting is the non-IRA strategy. Routine revascularization of non-IRA lesion should be considered in STEMI patient with multivessel disease before hospital discharge. That is a class 2A, and see the word routine revascularization. Not the patient is having further ischemia, ongoing ischemia, etc. It is a routine revascularization of non-IRA lesion. But again, note that before hospital discharge, not on the same setting, not on the same day of the primary angioplasty, but before hospitalization. We don't call it deferred. It is a routine. Non-IRA PCI during index procedure should be considered in patient with shock. Only in shock case, you do it on the same setting. Otherwise, you do it before hospital discharge. Now, if you see this multivessel revascularization or complete revascularization versus culprit lesion only PCI, you see all the trials actually favored the complete revascularization, which was summed up by Dr. Debabrata Mukherjee in 2020 by a meta-analysis that among patients presenting with STEMI, a strategy of multivessel PCI was associated with a 31% lower risk of reinfarction with no significant difference in all-cause mortality. And if you think, well, we'll do it only by after FFR, only those vessels which are FFR positive, again, you see, actually there is no difference, which has been summed up last year again, that there was no differential association with treatment between FFR and angiography guided strategies on major CV outcome. So you need not complicate your procedure by FFR, just by eyeballing. If it is more than 50 or 70% lesion, you go ahead before hospital discharge. What are the other antecedent treatment? Antiplatelet therapy is by choice, prasugrel or ticagrelor. Clopidogrel is a second choice. Aspirin is always class 1 indication, even IV if the patient cannot tolerate it orally. But GP2B3A is not really class 1, it is class 2A and only for bailout. And Cangleror, as you know, has recently been launched in India. It is only for P2Y12 naive patients and who cannot tolerate it orally, and maybe in some urgent cases to give intravenous to work within 2-3 minutes. Anticoagulation is recommended for all patients in addition to antiplatelet, and we usually use unfractionated heparin, that is class 1. But if there is heparin-induced thrombocytopenia, then bivalirudin is class 1 indication. Routine use of enoxaparin intravenous, some people use, but in class 2A. Routine use of bivalirudin, some centers use class 2A, but never use fondaparinux, that is contraindicated. The dose of aspirin is usually 300 and clopidogrel 600. For ticagrelor, it is 180 milligram loading followed by 90 milligram twice. And for maintenance, it is aspirin. This is very interesting, a slide. Not reperfused patients. Say my patient, I got the second kind of angiogram, which we cannot go ahead with angioplasty straight away. Patient is stable. Of course, you will be sent to surgery, but the surgeons, you know, usually will take up after the troponin I is negative, once the patient is stable, and generally after 2 weeks. They say the heart is not stable before 2 weeks. So what to do for these 2 weeks? You give aspirin 300 followed by 75 daily and clopidogrel 300 followed by 75. You see here, there is still no role of ticagrelor, prasugrel or cangleror and unfractionated heparin as in fibrinolytic therapy. Now, imaging. We should do an echocardiogram immediately if the patient is in cardiogenic shock, but you see routine echocardiogram that delays emergency angiography is not recommended. That is class 3. Of course, you will do it after the patient is out from cath lab. You can do a routine test to see the ejection fraction, to see the heart's ballooning and mitral regurgitation, etc. And coronary CT angiogram is never recommended in a STEMI setup. Now, other therapies, beta blocker, yes, sometimes we give it routinely for at least 2 years, but it must be given if there is heart failure or ejection below 40%, and you know the standard beta blockers. Lipid lowering has to be started immediately, the highest dose of statin that is tolerated, and your LDL goal is below 55. Then in a time-bound fashion, you add ezetimibe and evolocumab. But some of my colleagues have started giving evolocumab irrespective of the LDL level, even during the ICCU stay. There are merits and demerits of that. I don't go into argument into that. ACE inhibitors are recommended starting within the first 24 hours of STEMI, particularly in heart failure, LV systolic dysfunction, diabetes, or anterior infarct. My patient has got anterior infarct, so we need to give ACE inhibitor. You know that Paradise MI trial had showed that sacubitril valsartan is no better than ramipril. Now, my patient has got CKD. Now, what to do with CKD? You see, above 30 ml of EGFR, you just give the standard doses of everything. But if it is below 15 to 30, again, very surprisingly, you don't need to adjust any of the aspirin, clopidogrel, ticagrelor, or prasugrel, or heparin. Even it is below 15, the EGFR, you need not adjust your aspirin or heparin, but clopidogrel we do not know, and ticagrelor or prasugrel are contraindicated. So, ladies and gentlemen, STEMI and CKD, renal dysfunction carries on worse prognosis because of sometimes delayed diagnosis, because of less frequent presentation of chest pain and fewer ECG changes. Frequently excess dosing of antithrombotic the patient receives with concurrent bleeding. We need to reassure adequate hydration. Dose of contrast must be kept minimum. We might stage the procedure for multivessel disease. Preferentially low osmolality contrast agent to be used. Role of N-acetylcysteine is not well established, and radial approach is always preferred because femoral can attract more bleeding. You see, the Malaysian National Registry showed 3 times more vascular complication in CKD patient compared to non-CKD, 3 times more MACE, and 10 times more death during in-hospital procedural complication. And lastly, no talk is complete nowadays without COVID, which we published again last year from Cardiological Society of India, how to handle acute MI during COVID-19. If you see the red box, say my patient is COVID positive. And reperfusion eligibility, no, not within 12 hours. And then you see the no box in the middle, ongoing symptom, hemodynamic compromise, and malignant arrhythmia, no. Then what to do? Continue therapy in designated ICU and CCU, call back the patient after he is COVID negative, and then go ahead with angiogram. But of course, that scenario is changing, and we are doing the standard protocol nowadays. So, ladies and gentlemen, my take-home message over here with my patient is delayed presentation after STEMI is common in India. CKD contributes to delayed presentation. Treatment approach depends on type of hospital at presentation and patient's clinical status. Presentation after 12 to 48 hours of chest pain merits angioplasty as class 1 indication if the patient is symptomatic or unstable, but the indication becomes class 2A if the patient is stable and asymptomatic. Thrombolysis is still feasible up to 24 hours if the patient is symptomatic and facility for PCI is not available, but benefit is of course limited. IRA revascularization approach is the standard approach, but before hospital discharge, complete revascularization should be seriously considered. CKD merits special attention to drug selection. A nephroprotective behavior, maybe consultation of a nephrologist is highly recommended. An answer over here. Thank you.
I think we go on to the next talk now.
Do we have a question?
Yeah, question and answers can be discussed in the end, I think so.
In the end, okay.
Yeah.
Great case, Dr. Ray. So
thank you.
We will take questions at the end. If Dr. Rajiv, what do you think?
Actually, I'm out. I have 2 minutes, 1 minute. If you have 1 or 2 quick questions for me, kindly.
Okay. You had been very precise on the whole presentation, but I just remind you, only last week, I think there was a publication in JAC which justifies your approach. And the title is, "It is never too late to be right."
Yes.
And the window has been spreaded to 48 hours with benefit in 30-day and 1-year mortality. So what you showed, probably you did before the presentation. So yes. I congratulate you. And I think we should all go ahead, even if the patient is asymptomatic, with intervention up to 48 hours, because
French, that's the French registry first MI trial published.
And they showed 30% less mortality
even if you do asymptomatic patients within 48 hours. And they are
Yes,
still
but-
unsure between 48 and 72 hours. They
Yeah,
are looking into that also.
Yes.
Thank you, sir.
Thank
Thanks
you.
for bringing that up.
Yeah. 35% relative risk to
Yeah.
be
Yes. Fantastic.
So
Thank you.
this is a valid approach, I think, and we should encourage ourselves to do the intervention up to 48 hours.
True. Thank you, sir. Thank you.
Thank you, Sumitra. It was a wonderful presentation.
Thank you, sir.
Now we have Dr. Neeraj Pandit. He'll be speaking on case-based STEMI care, 70-year-old male with hypertension, obstructive sleep apnea with STEMI undergoes primary PCI to LCX, develops recurrent episodes of atrial fibrillation in hospital stay. So what would be the management strategies? Welcome, sir, for your talk.
Am I audible?
Yes.
Yes, sir. Very good.
And is my screen visible?
Yes.
Yes.
Okay. Good afternoon, chairpersons. It's good to see my friends and colleagues, Dr. Harshvardhan, Dr. Rajiv Agrawal, and Aditya.
Sorry to interrupt, all of us are junior to you, all of us.
But as always, sir is very magnanimous and generous.
So today I have been asked to speak on a clinical scenario where a 70-year-old male having comorbidities of hypertension and obstructive sleep apnea presents with STEMI, and he undergoes primary PCI with drug-eluting stent to left circumflex. And he's having recurrent episodes of atrial fibrillation during hospital stay. How would I think that I should manage this patient? The question is that does atrial fibrillation affect prognosis in STEMI? As per the literature, AF complicates AMI in 6 to 21% cases. It has an adverse impact on in-hospital as well as long-term morbidity and mortality. Predictors of developing AF are advanced age, heart failure, and increased heart rate on admission, and the risk of ischemic stroke, serious ventricular arrhythmias, and sudden cardiac death, it increases with the presence of atrial fibrillation. Also, AF may be a surrogate for a cardiac failure, and it's more common in patients who are having severe LV dysfunction along with acute MI. These are some of the studies which, in the era of thrombolysis primarily, which have shown that the incidence of new onset of atrial fibrillation, which is seen in the last column, varies from 6 to 20%. And it has become a little less in the era of thrombolysis, in primary PCI, and also the role of ACE inhibitors and ARBs, and also statins. One of the interesting features, especially in relevance to my case, is the atrial infarction as a causative factor of AF. Perfusion of SC node artery occurs from RCA in 57% and LCX in the remaining. Atria are perfused by coronary branches from right and the left in 98% cases. Occlusion of atrial branch of LCX causing atrial infarction and ischemia of LA leads to conduction delay, LA remodeling, atrial dysfunction, and AF. And if there is a presence of non-ischemic MR, it may also get exacerbated. One interesting thing is that acute accidental atrial branch occlusion may also occur during stenting to the proximal right coronary or left circumflex artery. It was in the trial as reported by Alvarez in Circulation, it was around 15% that the atrial branch of LCX or RCA got occluded and led to atrial infarct, which was missed and led to recurrent atrial fibrillation. So what are the management issues? What should be a peri-procedural management during primary PCI? Achieve balance between the risk of stroke versus risk of bleeding. What should be the choice of deaths? Post-procedure anti-thrombotic management. What should be the duration? How to manage associated conditions like atrial fibrillation and comorbidities like OSA and hypertension. So if we think of pre-procedural consideration, we should define the appropriateness. In this particular case, he was in the window period and STEMI and a primary was indicated. Also, we have to see the ischemic thrombotic versus the bleeding risk. Also, we should, by choice, the access route should be radial and the stent selection should be newer generation DES. Aspirin should be used during the peri-PCI period and inpatient stay until time of discharge. The choice of DES, before that, I will have to tell you about how to will in my patient we balance between the risk of stroke versus the risk of bleeding. As we know that there are risk scores, many risk scores, but commonly used is the CHADVAS score. In my patient, he's hypertensive and he's more than, he's 65 to 74 years, he's 70 years old, as well as he has got vascular disease, prior MI and atherosclerotic, significant atherosclerotic disease. So I'll put him on a score of 3, which is a high risk. Versus what is the bleeding risk? And if I look at the bleeding risk, he's hypertensive and he's elderly. So he has got 2 points. And if it is less than 3, then he is not a high risk for bleeding. And I go by this flow diagram where when the patient has, a male patient has got a risk score of more than 3 and male patient and the bleeding score of 2, he requires OAC. And I would subject him on OAC and would prefer to give him a novel oral anticoagulant agent if the patient can afford it. Because it has got a lower risk of major, fatal, and intracranial bleeding. It is simple to use and rapid onset of action. The other management issue is that now that I have subjected the patient, taken him on the table, what choice of DES? There is an improvement in stent design. Yesterday, we were listening to some speakers who were telling us that the improvement of design has got a direct bearing on stent thrombosis. And newer generation of stent design with thin struts, inherent resistance to thrombogenicity, and a passivized coating, durable polymer, which is improved, or biodegradable or no polymer, abluminal stent, coating. These lead to low incidence of thrombogenicity and allow a shorter duration of DAPT. It is supported by various evidence like the Leaders Free trial, where a biofreedom drug-coated stent was used compared against a bare metal for with a 1-month DAPT. Onyx 1, where Resolute Onyx stent versus the biofreedom coated stent, again the similar finding, 1 month DAPT, that neither did it increase the thrombogenicity nor the bleeding. Zeus with the Endeavor stent and the Zynes family of stents, where Zynes 28, 1 month DAPT versus 6 months DAPT, and 90 days DAPT versus 1 year. And none of them had shown increased risk of thrombogenicity or bleeding. So I will choose one of the newer generation stents. What would be the post-procedure anti-thrombotic management? Coming back to the same slide, the patient, I loaded him with aspirin and clopidogrel, not the, in some cases I may consider ticagrelol, but in my patient, I would like to give clopidogrel along with aspirin loading. And aspirin should be continued I would like to continue it for 1 month rather than 1 week or up to the hospital stay, because I feel that there is an increased thrombotic risk and less bleeding risk. It is reasonable to and extend the aspirin therapy beyond 1 month is not recommended as per the guidelines. And I will discontinue P2Y12 inhibitor at 1 year, and also as a default strategy, as recommended by American College of Cardiology Consensus Statement 2021, a double therapy regimen with NOAC plus P2Y12 inhibitor with use of aspirin limited to the peri-PCI period should be the default strategy for most patients. I forgot to tell you that the patient will also be on a novel anticoagulant Why? And when will I start? It would be once the patient is in hospital, once the patient is about to be discharged, let's say a week or around 10 days, I would put him on novel oral anticoagulant. And these are some of the randomized controlled trials on double versus the triple antithrombotic therapy, which show, and these are the trials in a tabulated form, which show that all these trials, the meta-analysis showed that bleeding outcomes were reduced and the ischemic outcomes were similar, not more, except in one or two, one trial like the Reduel trial, where there were indicators of increased stent thrombosis, especially with the dabigatran dosage of 110 milligram BD. So I would, therefore, I would say that since there are some indicators of increased stent thrombosis and MI in patients who are in very high thrombotic risk, I would consider giving longer period of aspirin. So it would be individualized. Optimal timing of discontinuation has to be individualized. It's not one glove fits all. Therefore, this would be my slide to tell us that how I would go about. In my case, when the patient is at high risk of ischemia and at low risk of bleeding, I would consider triple therapy for around peri-PCI period and 1 month of triple therapy, followed by double therapy of OAC and P2Y12 inhibitor for 1 year, and following which I would OAC alone. That would be in my patient who is at low bleeding risk and high thrombotic risk. How to manage atrial fibrillation with Stemi, rate control versus rhythm control, which I would say in my patient, because there is no, as we know that by the RACE and AFFIRM trial, that there is no difference in composite of clinical events, NYHA class or hospitalization between the strict target heart rate less than 80 or at rest and 110 at exercise versus a lenient control. I would go for lenient control in my patient. And we all know that beta blockers or non-dihydropyridine calcium channel blockers are the first line treatment. If not controlled, one can consider giving digoxin. And if it's a serious issue, then one can give IV beta blocker if there is no heart failure or no sign of hypotension. Consider giving IV amiodarone or IV digitalis if there is hypertension or acute heart failure. If patient has got a lot of symptoms and it doesn't control, quality of life is poor on rhythm, then I will consider giving rhythm control. Also comorbidities like hypertension, because it has to be optimally controlled because it increases the recurrence of atrial fibrillation and the risk of stroke, and ICH is increased in uncontrolled hypertension. And autonomic dysfunction, negative intrathoracic pressure and hypertension in OSA, it leads to atrial remodeling and OSA. Therefore, CPAP is a therapy which reverses atrial remodeling and controls atrial fibrillation. So these are the comorbidities that I would be treating in my patient. So to summarize, this 70-year-old male with STEMI and AF who is eligible for primary PCI, I would first consider the ischemic risk versus the bleeding risk, and I call him high ischemic risk and a low bleeding risk. I will load with aspirin and clopidogrel 600 milligram, perform PCI under unfractionated heparin, continue aspirin 75 and clopidogrel 75 for 12 months. For 1 month aspirin and 12 months clopidogrel. Add PPI and avoid NSAID. Use newer generation DES with low thrombogenicity. Start NOAC, preferably Apixaban 5 milligram BD, because that was the dosage used for prevention of stroke in atrial fibrillation patients. And it also has got less GI side effect. Dabigatran also may be considered for similar reasons, and continue beyond 12 months. AF rate control strategy first, treat comorbidities, and reassess the need for modification of dual antithrombotic therapy in follow-up more frequently. Thank you very much for your kind attention.
Dr. Pandit, it was an excellent presentation. I have one query. How long does this atrial fibrillation persist in the long run? And do we have to give this NOACs lifelong, or can we stop after some time in these patients?
If we are saying that atrial fibrillation is due to the atrial infarct, then there is also atrial myopathy, and there is a damage to the atrial myocardium. There can be a fibrotic areas in the scar which has been confirmed by CMR in one study. Therefore, such patients who develop atrial fibrillation following atrial infarct will also be candidates for long-term, maybe lifelong OACs.
Dr. Pandit, I want to know two things: why you have left out rivaroxaban and what is the BMI of your patients? Because OSA, BMI, AF, they go hand in hand, and reduction in BMI results in often sustained NSR. So just my interest to know these two things.
Rivaroxaban, because the dosage used in the atrial fibrillation ACS trials was not the dosage used for prevention of atrial fibrillation, which was 20 milligrams recommended dose. And also more side effects like GI side effect, or let's say less side effects with epixaban and dabigatran. Therefore, my consideration of these two rather than otherwise, there is evidence to use rivaroxaban too. As regards BMI, if the patient is having an ideal BMI, then there is no need. But if the patient is obese, surely that leads to OSA as well as more chances of recurrence of AF, difficult to control atrial fibrillation, etc. So achievement of to control all the risk factors and achieve the ideal body weight would be the rationale. For a patient of CAD, we have to control all the risk factors. Similarly, in these patients.
Thank you, Dr. Pandit. It was very enlightening on multiple problems in a single patient, which look very simple to look at, but very difficult, detailed scientific decision making. Thank you very much. Can we go for the third case?
Yeah, Rajiv, I think you can invite Dr. Kamal Sharma for the next case discussion.
Hello, good evening. Good afternoon, everyone. Respected.
Good afternoon, Dr. Kamal. We invite you for the third case, and I'm sure we are going to learn many things from your presentation.
Respected seniors, thank you, organizing committee, for allowing me to present my case here. So this is a very interesting case and a very different format, and I'm really, I'm pretty sure that the reason that this topic was given was primarily for understanding a different concept altogether, which is concept of MINS. I'll take you through that, why I intend to say so. Because the case that has been given is a 47-year-old male post-cholecystectomy, developing chest pain after 12 hours, troponin positive. It's not clearly mentioned. It's really indeed an MI, and it's 1 mm ST elevation in inferior lead. So let's look at what would come to one's mind. So I hope when a patient comes with a post-operative assessment which shows this kind of a picture, I hope he had a good pre-op assessment, because that is going to derive the outcomes and depend how you intend to revasc or not revasc and arrive at your differentials in managing the patient. So the 6 independent predictors that have been well implicated at the major cardiac events should include not only the kind of surgery, risk of heart failure, CV stroke, risk of ischemic heart disease, diabetes, and creatinine. And based on these scoring, one can arrive what was the perioperative likelihood of this patient arriving or presenting with a fatal or non-fatal myocardial MI, myocardial infarction, or a cardiac arrest. Now, we must understand not all ST elevations are acute MI. That's the first and foremost thing, especially in the post-operative period. Myocardial injury ischemia would, of course, be the first differential that a cardiologist would keep in his mind. But we have to keep in consideration that this can be anything else other than acute MI also. And for that, you need just a workup before you intend to intervene or not. So acute pericarditis, repolarization patterns, myocardial injury due to trauma, tumor invasion, myocarditis, hypothermia, ICH, hyperkalemia, hypercalcemia, post-DC shocks, Brugada, antiarrhythmics, a lot of other differentials, and the list is not complete. So MINS is the terminology, which is myocardial cell injury during the first 30 days after non-cardiac surgery due to ischemic etiology, that there is no evidence of non-ischemic etiology like sepsis, rapid atrial fibrillation, pulmonary embolism, cardioversion, chronically elevated troponin, etc. Once they've been ruled out, that's when you can define it as a MINS, and it's independently associated, of course, with mortality. And the incidence varies from 8 to 19%. So we could just not think about every patient presenting as a ST elevation transmural myocardial infarction as we consider. 40% of MINS will be positive with non-high sensitivity troponins also, and 20 to 30% would still remain so even with when you choose the high sensitivity biomarkers. The two important studies that have looked into MINS is Poise study and Vision study. The Poise is one that defined the perioperative MI as elevated biomarkers with one of the following, which is ischemic symptoms, ECG changes into contagious leads, coronary artery intervention if it was warranted or done, and evidence of MI on imaging or autopsy. And this Poise study showed that the incidence was 5% within 1 month in the Poise study for development of myocardial infarction. The second was Vision cohort, looking at 21,000 plus patients, looked at troponin assays during the first 3 post-operative day, of which 40% had a baseline troponins done to define whether they were rising or not. So study adjudicators defined that 11% had evidence of non-ischemic etiology of elevated troponins and elevated perioperative biomarkers if that were present, and 13.8% had preoperative high troponin treat measurement that was greater or equal to peak troponin values. So it brings to this patient. This patient we'll have to consider a lot of aspects. Whether this patient is diabetic, hypertensive, had a prior MI, what is his baseline EF, what are his comorbidities, is he having anything like COPD, CRF, obstructive sleep apnea, CV stroke, bleeding diastasis, what are his baseline parameters? That's not been defined. Does he have elevated baseline biomarkers and not just troponins? What about his CKMB, BNP, D-dimer? Because we all know that the absolute increase in a rise in the troponin, even for the baseline, but more than 14 from the baseline, would increase his mortality. The CARP trial also looked at a very high-risk age group of age more than 70 in abdominal surgery, diabetics, angina, and baseline STT, which were the predictors of development of subsequent MI. Now, which in this case, the details are missing, barring the age, which is less than 70, of course. Another interesting aspect that one need to look is whether the patient underwent a laparotomy or was it a laparoscopic cholecystectomy. What was the indication? What did he underwent this same for, say, for a malignancy or for a chronic cholecystitis? Was it a gallstone? Was it having obstructive jaundice? What was the indication that he underwent this for? What was the risk that we'll have to look at for in terms of bleeding, and also as for the outcomes? What is his DAPT score? What is his Hesbled score? What is his Gray score? What is his Stemi score? And of course, we'll have to look at his hemodynamics and metabolic parameters. What are his hemodynamics and how is he holding on to his blood gases, etc. So the choice between invasive and non-invasive testing, as per these study protocols, have been the angiography would surely be recommended and preferred in the ST elevation MI, elevated troponins, which is this case, supposing if he doesn't have an STMI, it's an STMI, refractory angina, instability, recent stents, post-CABG, and those who were initially managed conservatively but are high risk for non-invasive strategy. This is Mook's algorithm proposed way back in 2008 for an STMI, which talks about hemodynamic instability as a driver for invasive strategy, and a hemodynamic stable stable status. One can look at initial medical management with DAPT, beta blockers, statins, with or without ACE inhibitors, and refractory symptoms. One can go ahead and do a cath. In STMI, again, the medical therapy remains pretty much on the same. The cardiac cath and primary PCI with or without IBP is recommended for instability in those who are stable. Absolutely contraindicated for heparin anticoagulation, etc. Again, would be deprived of the same but put on medical management. And if those who are stable and they are not contraindicated to be anticoagulated with heparin, you can still think of a PCI. So heparin anticoagulation would be a strategy that would always come in the way. Either you're trying to do an invasive strategy with or without IBP or not. So this patient would hence require biomarkers, echocardiography, CT angiogram, again, would be a consideration if you are suspecting something else rather than ST elevation MI. But again, issue would be contrast nephropathy. Then so in that case, invasive strategy would always be better. You can go in with a minimal dye and do an angiogram instead. What about cardiac MR? Can it be of help? But then again, what about the clips if the cholecystectomy has been done? There have been cases where you would like to do imaging. There have been case reports which have been reported that perioperative, these patients actually come with spontaneous coronary artery dissections rather than a plaque rupture or a plaque erosion. There have been cases with recently reported of intramural hematoma. This is a recent case which was there on Twitter by my friend Mamas, who showed a case of acute inferior oval MI, and on angiogram looked pretty much like a tight stenosis, and imaging actually showed intramural hematoma with dissection and was left on medical management. So medical management, as per the guidelines, talks about aspirin and statin being class 1B. Statin, of course, is recommended standardly. But surprisingly, in mains, I found a lot of literature which talks about Novax now, though the level of evidence stays about grade 2B. And there is STMI, which they do talk about beta blockers as 1B. Dabigatran has been studied in one of the big studies called MANAGE trial in dabigatran, which 20% of the patients actually met myocardial infarction criteria, but did not have a high bleeding risk, with the elevated post-operative troponin thought to be due to MI with or without evidence of non-ischemic cause within 35 days of surgery. And they were randomized to dabigatran 110 BD for maximum of 2 years. And remember, this was not immediate acute phase. This was at the time of discharge. 74% patients received a single antiplatelet, only aspirin, and 7% were on DAPT. At 16 months, the risk of primary efficacy endpoint of MACE was lower for dabigatran, almost hazards of 0.72, 11% versus 17%. So in medical management, without the lytics, one would be thinking of putting these MINS patients to receive, those who receive the therapeutic intensification, that is aspirin, statin, beta blocker, and ACE. The primary outcome of 12 months survival without a major events in the patients who did not receive was much higher, and the 4 therapies actually reduced the hazards ratio to 0.63. Now, so the option, assuming that all we have ruled out and we are definitely dealing with an acute ST elevation, myocardial infarction, the choice would become primary PCI, because then you need to just probably give anticoagulant like heparin perioperatively, and sometimes you can actually end up reversing immediately after doing a PCI. The considerations would be whether you would go for a bare metal or a drug-eluting stent, and definitive strategy and therapeutic strategy would be an invasive angiogram to confirm or rule out what we are dealing with. On top of that, one should also be looking at the risk or need for the anticoagulation, TIMI and myocardial blood gradings, ejection fraction, and of course, the issue would be the cost, contrast nephropathy, and DAPT. So, though the PCI looks very elusive, I mean, very interesting, and the tempting alternative for both the patients who come with post-operative ST elevations and biomarker elevation, it may not always be the first and only thing that one may think of. This is one of the cases that we could think of similar scenario. This was a patient who had come with complete heart block. Now, this was definitely not 1 mm. Complete heart block, needed a temporary pacemaker, and then of course, just like any other PCI, would end up doing revasc for this patient. But then this is something that would come to mind as the most definitive treatment once one has evaluated and exhausted all differentials that one can think of in a scenario with just 1 millimeter elevation, immediate post-operative phase. Thank you very much. Over to Chair.
Kamal, thank you. And as always, you presented in your absolutely always clear, crystal clear way, and great presentation. Just adding one or two things which you said, I completely agree with the algorithm you presented, because troponin is such an overused test nowadays by the anesthetists in the post-operative ICUs. We all get inundated by such referrals. So, and as you rightly mentioned, doing a echo or doing supportive analysis and ruling out other conditions, maybe look at the serial way the troponins behave. That is also a good strategy, because we recently had a similar case, ulcerative colitis, operated 4 days ago, and he had some episode of discomfort. 29-year-old guy. So the ECG showed a left bundle branch block, and everybody was in a hue and cry that it's a MI, and troponin was actually, it climbed to 3. And we were pretty certain that it's a post-operative thing. So we ended up doing an angiogram because that was required, but it was completely normal. So again, my compliments, you really, really dissected it out very well.
Thank you very much, sir. I completely agree, sir. Serial biomarkers are an important parameter, and I mentioned in my slide, I skipped the word serial, but I mentioned biomarkers as the next thing. Maybe complementing it serially or parallelly, adding maybe CPKMB apart from just troponins, or just troponin I and then adding maybe troponin T. Look at how the two are varying differently, with renal parameters also making a big role into how the biomarkers are going to change. So
and
baseline,
very rightly, you said that angiography looks very attractive, but it should be our threshold should always be a bit high. You're absolutely right.
Right. Thank you, sir.
Dr. Kamal, I want to just come in because the way I look at it, earlier you come across the event following the procedure. More I am biased for conservative approach unless I am complicated by hemodynamic instability. And I'll say along with troponin, I believe in serial echocardiogram. If the echocardiograms are stable, not showing much of the problem is not progressive, it is better to be conservative. And as you said, I mean, once you see your slide, probably I have to rethink myself. Probably my algorithm is shorter than yours. And it needs to be more elaborate than making a mess after the procedure, because the real mess will start on anticoagulation, antiplatelet following the angioplasty. Up to angioplasty, it is reasonably safe journey. The problem is once you finish the procedure, what happens to the patient? And then it is do and die situation. There is no callback. So you have to be very, very judicious. And I think serial echo should also complement serial enzymes and take a judicious call. I am biased more toward conservative approach unless I am compelled and sucked in by the disease. Thank you very much.
Thank you, sir. Completely agree, sir.
Dr. Harshvardhan.
It was an excellent presentation indeed. I think all the three presentations done so far have been wonderful. They have dissected the cases so well. And I think with that, we should go to the last case of the session, which is by Dr. Sanjeev Sharma. And he'll be discussing a case of a 65-year-old female who is hypertensive, chronic liver disease, period ST elevation MI, and has presented with the window period of 4 hours. Also has a history of hemorrhagic stroke 2 years back. So question is how I will approach this patient. Obviously, the patient is high bleeding risk and has presented with STEMI in 4 hours window period. May I invite Dr. Sanjeev Sharma?
So because of technical reasons, Dr. Sanjeev Sharma will not be able to take this talk. Instead of him, Dr. Varsha will be presenting the case.
Okay. I'll invite Dr. Varsha to please share her screen and discuss this case.
Hello. I'll be presenting, first of all, good afternoon, everyone. I'll be presenting this case of a 65-year-old female, hypertensive, chronic liver disease, anterior ST elevation MI, presented within 4 hours to our emergency with a history of hemorrhagic stroke 2 years back. She had a blood pressure of 160/90 at the time of presentation with a heart rate of 88 beats per minute. ECG was suggestive of an anterior wall MI, and a screening echo done in the casualty showed a wall motion abnormality of the LAD territory with LV ejection fraction of 40 to 45%. She's a known hypertensive for the last 8 years on tablet amlodipine, tablet telmisartan 40, and propranolol 20 mg once a day. She's non-diabetic. She had a hemorrhagic stroke 2 years back with no residual neurological deficit. She's a known case of chronic liver disease, hepatitis C related, with a childhood class A and a score of 5. In the ER, we gave her a chewable non-enteric coated aspirin, 325 milligrams, a clopidogrel 300 milligram, injection of low molecular weight heparin 5,000 units intravenously, along with a pantoprazole injection 40 milligrams intravenously. This was, we took her to the cath lab where we did the angiogram. The right coronary system was normal. We did the angio by the radial route. When doing the left angiogram, there was separate origin of the LAD and the LCX. The LCX was normal. We couldn't hook the LAD with the normal Tiger catheter. We tried the Judkins left, but ultimately we succeeded by hooking it with the Amplats 1 catheter. There was a tight stenosis of the LAD and Stemi 2 flow in the distal part. So what should be the approach to this patient with high bleeding risk? For years, concerns about thrombosis and recurrent ischemia in patients undergoing PCI have prevailed, prompting the use of potent anti-thrombotic strategies and long durations of DAPT. Remarkable improvements in the way in which PCI is performed have led to a new interest in investigating strategies that target patients at high risk of bleeding. Such patients should be promptly identified to define appropriate bleeding prevention strategies, and bleeding avoidance strategies include actions targeting at minimizing the risk of bleeding before, during, and after PCI. Patient factors include, we should first recognize these patients who are at high bleeding risk, identify the high bleeding risk factors, identify the correctable bleeding risk factors like control of hypertension, LA appendage occlusion, etc., and monitor the bleeding patients periodically for the change in the bleeding or ischemic profile over time. For pharmacology as concerned, we should reduce the DAPT duration to either 1 or 3 months. The DAPT choice is an issue. Then we can de-escalate to the less potent antiplatelets. We can use DOACs instead of warfarin for atrial fibrillation, and liberal use of PPI can be done. So far as the procedure is concerned, functional assessment should be done as far as possible. We should limit the number of stents and the number and the length. We should avoid complex stenting if possible. Use of image guidance for stents optimization, and the choice of drug-eluting stent should be taken into consideration. The factors associated with an increased risk of bleeding after PCI include age more than 75 years, renal disease, liver disease, active cancer, anemia, low platelet count, stroke, intracranial hemorrhage, brain AV malformation, a history of bleeding, either a bleeding diathesis or prior history of transfusion or bleeding. Then it can be use of oral anticoagulation, NSAIDs, steroids, or there is a planned surgery on DAPT, recent trauma or surgery. These were the major and minor criteria for high bleeding risk at the time of PCI as defined by the BAC criteria. The patient is considered as a high bleeding risk if there is at least one major criteria or two minor criteria are met. Then we have the BAC score. BAC type 3 or 5 bleeding is considered as significant bleeding. To avoid bleeding during PCI, we have to give consideration to the vascular access site, anticoagulation, antiplatelets, choice of stent, and stent optimization. Coming to vascular access site, according to the Matrix trial in which ACS patients were taken, radial access was associated with lower rate of net adverse clinical events than femoral access, and there was reduction in bleeding events and cardiovascular mortality with no difference in MACE at 1 year. There was another meta-analysis involving 30,096 patients with PCI performed, and where radial access was associated with a 47% lower risk of bleeding as compared to femoral access, regardless of whether invasive coronary angiography was performed with or without PCI. So the clinical guidelines recommend the preferential use of radial approach for PCI. If femoral access is required, puncture with a safe zone targeting guided by fluoroscopy or ultrasound is recommended. The anticoagulant recommended is unfractionated heparin as the anticoagulant of choice. Enoxaparin or bivalirudin can be used, especially where there is heparin-induced thrombocytopenia. Clopidogrel has a class 1 recommendation for patients who cannot use or tolerate prasugrel and ticagrelor, including those at high risk of bleeding. Also, it is preferred in patients who are at high risk of bleeding due to concurrent use of oral anticoagulants. In the popular age trial, clopidogrel was associated with a lower risk of bleeding than therapy with ticagrelor or prasugrel, and was not associated with a higher rate of occurrence of the combined endpoints of all-cause death, myocardial infarction, stroke, and bleeding, and it is a viable alternative to the more potent P2Y12 inhibitors for patients in this high bleeding risk category. Then coming to antiplatelet therapy with P2Y12 inhibitors, Cangrelor, which has recently been launched in India, can be used in patients who are P2Y12 naive, as it has a faster offset of action and there is no dose adjustment required with kidney disease. Now coming to the choice of stent, drug-eluting stents are recommended regardless of the clinical presentation and the anticipated duration of DAPT. A mandatory period of DAPT is required after stent implantation while endothelial coverage occurs to decrease the risk of stent thrombosis. With novel drug-eluting stents, the absolute risk of stent thrombosis is decreased, allowing shortening the mandatory DAPT period. Now, there were certain trials of stents in short DAPT in patients who were high risk of bleeding. There was the Leaders Free trial in 2015 using Biofreedom stent, where DAPT duration was 1 month. The senior trial involving the elderly came in 2018, in which the Synergy DES was used, and patients took DAPT for 1 month in case of stable CAD and 6 months for ACS. Then the Onyx 1 trial for Resolute Onyx stent, DAPT for 1 month. The Cobra Reduce, where the Cobra stent was used for a short period, DAPT was used. Then the Leaders Free True trial, where again the Biofreedom DCS was used and DAPT was given for 1 month. The Onyx 1 Clear, where the Resolute Onyx stent was given used and DAPT was given again for 1 month. Then there was the Science 90 and Science 28 trials, which have recently come, where the Science family of stents has been used. In the Science 90 trial, Science DAPT was used for a minimum duration of 3 months. And in the Science 28, the DAPT was used for a minimum duration of 1 month. In the Evolved Short DAPT, where the Synergy drug-eluting stent was used, DAPT was given for 3 months. In the recently published Master DAPT trial, the Ultimatus Master stent was used and DAPT was given in the shorter group for 1 month and in the standard therapy group for 3 months, and it was considered as non-inferior. So the currently approved devices for use in patients in high risk of bleeding include the Resolute Onyx, Synergy and Science family of stents in the USA, and the Resolute Onyx and the Science stents in Europe. Some stents such as Biofreedom, Synergy and Ultimaster have obtained labeling updates in Europe for early discontinuation of DAPT when clinically indicated or necessary. Also, we need to optimize the stent by IVUS, such as IVUS or OCT, to reduce the risk of target lesion failure and repeat revascularization. Use of IVUS to confirm the quality of the PCI procedure and the correct apposition of the stent struts as a prerequisite for faster and more complete endothelization is intuitively important in patients at high risk of bleeding who might need a short duration of DAPT. There were some other trials where short DAPT was used, followed by a P2 vital inhibitors. But here, all comers were taken, regardless of the bleeding risk. This included the Global Leaders trial, where DAPT was given for 1 month, followed by ticagrelor monotherapy. The Glassy trial, again 1 month DAPT. The Stop DAPT2 for 1 month DAPT. Smart Choice, 3 months DAPT. The Twilight trial, we gave ticagrelor monotherapy after 3 months of DAPT, and the TRECOP trial, where ticagrelor monotherapy was given after 3 months of DAPT. So now coming back to our patient, here we had to switch over to the femoral route in view of difficult hooking from the radial side. We took an XP3 6F catheter to hook the LAD. A standard BMW wire was used to cross the lesion in LAD. The lesion was pre-dilated with a 2.5 into 12 mm stent at 10 atmospheres. A Science 3.5 into 28 mm stent was deployed across the lesion at 10 atmospheres. This is the final result of the procedure, where we can see TIMI 3 flow. The patient is currently doing well at 2 months of follow-up. She is currently on DAPT, aspirin and clopidogrel. Her LV ejection fraction has improved to 50%, and she did not have any significant episodes of bleeding during follow-up. To summarize, during PCI, radial axis is the preferred axis. We should use weight-adjusted heparin therapy with frequent checks of the ACT for optimal anticoagulation. For stent selection, we should use coronary stents as indicated and try and discontinue DAPT as early as possible. We should optimize the stent using intravascular imaging to ensure well expansion and apposition. Then after PCI, choice of antiplatelet therapy is ideally clopidogrel in patients who require combination therapy and who are at risk of unacceptable bleeding complications with prasugrel or ticagrelor. The duration of DAPT can be reduced to 1 to 3 months in patients who have high bleeding risk and have gone PCI. We can also switch to clopidogrel after we've given prasugrel or ticagrelor for 30 days. The liberal use of PPIs should be done in patients who have a low potential for pharmacological drug-drug interactions in combination with clopidogrel. take-home message is that patients at high risk of bleeding are an underserved population. The numbers of such patients are increasing enormously, almost 40%, and this is a very difficult subset of patients to treat. We should have dedicated therapies available for this high bleeding risk subset of patients, especially the elderly subgroup. Most of the data for short DAPT in high bleeding risk patients is with stents like Ultimaster, Onyx, and the Xience family of stents. However, whether these findings can be extrapolated to other stent platforms needs to be evaluated. Thank you.
Just one question, Varsha. Great presentation. Just not necessarily related to your case. Just some food for thought. We have Dr. Rajiv here, Dr. Harsh here, even Kamal is there. So this is a mid LAD. We have a concern for a potential bleed because it's a hemorrhagic stroke. So I wonder if somebody would just a provocative question or a provocative thought. It's a mid LAD. You put in a 3.5 drug eluting, if I got it right. So maybe we can think about putting a bare metal stent and get rid of the potent anti-thrombotics sometime down the line.
We thought about it, but there was no stent available on the shelves.
No, it's not a question on that. I think we have already the guidelines. Hello, Aditya. The guidelines are only for deregulating stents, okay? And maybe after a month or so, it's a drug eluting or it's just a bare metal. We don't know. So we don't have any guidelines. And probably it was no residual deficit almost 2 years back, and type A CLD, and if it was, I think, advanced CLD, probably we'll have to think otherwise. And ideally, if we are doing an elective case, probably all these patients who have CLD should undergo endoscopy to look at the varices and then take a call. It was the acute MI, I think, then probably.
I completely agree with your strategy. I mean, I'm just for discussion.
Dr. Sharma, do you stage liver disease when you talk of CLD?
Yeah, of course we have to, because
we have to. So
CLD is a very vague term.
Yeah, CLD is a very vague term, and
type A, type C.
I'm missing the name. I'm missing the name of the classification, but So my question is, why instead of contesting so much on the type of the stent platform, the disease, there is more or less unanimous opinion of putting these patients on single antiplatelet like global leaders and the 3-month ticagrelor trial. Why did you attempt that? That automatically reduced to one antiplatelet, and one antiplatelet is always safer than dual antiplatelet. That is my question. I would have put the patient on ticagrelor and aspirin and taken off aspirin after a month, and I am done. That is how I look at it. What is your take on that?
Yeah, I think these are the things which can be discussed endlessly and no end to that, because all patients, all these group of patients are prone to bleeding. Of course, ticagrelor is always a good choice and less bleeding as compared to prasugrel. But looking at so many factors, we thought it was a mid-LAD and not a very high thrombotic burden CLD patient. So why not put him on? Put her on.
Whatever I understand in antiplatelet, one antiplatelet, whatever you use is safer than dual antiplatelet.
Yeah, of course we can stop aspirin.
If you take off one drug after a month, I would be safer than having dual drug like aspirin and clopidogrel on long-term basis.
Yeah, aspirin can be discontinued, and I think we have gained a lot of confidence after master DEP trial where they have used clopidogrel in about 4,000 patients, and they stopped aspirin and only the monotherapy clopidogrel was continued, and they probably had a very good response. So all these trials give us confidence. Yes, clopidogrel is back, and I think in yesterday's talk, Dr. Praful in this debate has emphasized on clopidogrel and given a lot of data that yes, this drug is back, and maybe in type A lesion should be used. And
I asked my co-panelist, how many of you, when you use ticagrelor, it's a general question, just a kind of survey, how many of you take off aspirin after 3 months or 1 month, or you continue both? Because I take off without fear and I am yet to suffer.
Rajiv, I think so because of want of time, we will not be able to proceed further.
Okay,
Thank you.
Thank you very much. We enjoyed this session.
Thank you so
all
much.
the cases were very interesting. Thank you very much.
Thank you so much. And now I would like to request, as we move on to our next session, our chairs, Professor S.C. Manchanda, sir, Dr. Pancholia, Dr. C.P. Roy, Dr. Dipnakar Ghosh, Dr. Jeevar Zakaria, and Dr. P.K. Hasija to conduct the next session post-PCI, post-STEMI management. Professor Manchanda, sir, please.
Good afternoon. Am I audible?
Yes, sir, we can hear you, sir.
Well, this is a very important session that we are having. Although as you heard, we have advanced technically in doing the best angioplasties and putting the best stents, etc. But I think the post-STI management is not that much important. It's not given that much of importance. Of course, we have guideline-directed medical therapy, which is also not followed really properly. But what is neglected completely is the rehabilitation after STEMI. And I think in this session, we are trying to talk about that because all the good job done by the interventionists really should not go waste. And it is possible to improve the survival and quality of life if we use the post-MI management properly, especially cardiac rehabilitation. We know that rehabilitation can decrease mortality by as much as 25 to 30%, but completely neglected subject not being followed in our country. So without taking much time, I welcome my co-chairpersons, Dr. Pancholia, Dr. C.P. Roy, and others. And without, I think, taking much time, I would like to invite the first speaker, Dr. D.P. Sinha, to talk about the guideline-directed medical therapy after STEMI.
Good afternoon, everybody. And thanks to the organizers for asking me to be present on this platform. It's a very important topic after all. My slides visible? Hello?
Yes.
Yeah, you are visible.
Okay. Thank you. So my topic is post-MI guideline-directed medical therapy. How relevant, how feasible. So practically, I have three aspects to cover here. What is post-MI GDMT? Whether it is relevant, that means how beneficial it is, and how feasible, which I will take it up as a how to make it feasible. So this is the burden of CVD, 61 million CSD cases in 2015, and 3 million STEMI every year. And outcome after index MI, that 18.3% of the patients with MI had a recurrent MI stroke or CV death within the first 365 days after the index MI. The risk of subsequent cardiac event after MI was independently associated with age, medical history, and the use of revascularization of the index event in all patients with acute MI. Those patients who remain stable for the first 365 days after MI were still at the higher risk. 1 of 5 participant patients experienced an event during the subsequent event. And this is the Kaplan-Meier estimate of the risk of the combined endpoint, myocardial infarction, ischemic stroke, or the CVD mortality, which as the age increases, and the median is approximately 13% per year. This is 365 days. And if you group the subjects into the high risk and low risk group, of course, the patients in the elderly and then high risk group has the highest event rate at approximately 35%. But the overall event rate is approximately again 13%. So what does a guideline-directed medical therapy means? It means class 1 recommendations from major societal guidelines are said to constitute guideline-directed medical therapy. The cumulative probability of a subsequent event in the stable post-MI population was 9%, and after 12 and 20% after 36 months of follow-up. So these are the guideline-directed medical therapy, that is oral beta blockers, lipid-lowering therapies with an LDL-C goal of less than 70 milligram per deciliter, or a reduction of at least 50% in the baseline LDL-C is recommended. It is ACE inhibitors and ARB are again class 1A agents, ACE inhibitors, and MRAs are also class 1 agent, if recommended. And antiplatelet therapies with aspirin and DAPT is also class 1 agent. If you look at the guidelines across the Atlantic, the ESC and the ACCHA guidelines are more or less concordant with the GDMT, that is as antiplatelets, beta blockers, ACE inhibitors are ARB and statins. They are more or less concordant in the recommendations that these are the drugs that should be used. So now look at some of the older data. How does it help? Aspirin in the evidence of secondary prevention trial, that is a 2002 data, that is 20% of relative risk reduction after use of aspirin. And the beta blocker evidence is again approximately 20% of beta blocker effect in the secondary prevention study as well. If we look at the various trials, that you see that the total relative risk reduction is approximately 20%. Real evidence is again very old data from the CAPRI that it is beneficial compared to aspirin alone. And in CURE trial after PCI, aspirin plus clopidogrel fared better than aspirin alone. And the CREDO trial, again the same data also. DAP, dual antiplatelet agents, produces continued benefit when used for 1 year. If you look at the angiotensin converting enzyme inhibitors, this is a slightly complex slide. But anyway, if you look at the data that whether you use angiotensin converting enzyme inhibitors, either in the early in the post-infarction period or in the late, there is always a remarkable benefit of approximately 20% here. And again, and the last is the statins. You are all familiar with this graph that as we go low, the statin, the relative risk actually decreases with a 2% of CV deaths due to 1 millimole reduction in the cholesterol levels. So, having said that, all these 4 drugs, they are all very well and recommended. But is there any strong data that use of this will give us to better outcome? There is a Prometheus registry so that it has a database of approximately 20,000 patients had biomarker positive ACS, and GDMT as described as approximately 56 patients. And if you look at the survival curves, cumulative incidence, that subjects who received GDMT had a significantly lower event rate over a period of 1 year. That is, after relative risk reduction was 32%. And death at 1 year was approximately 40% lower. So adoption of evidence-based and survival for patients with Stemi, it has got a strong association. If we look at the Swedish RIS HIA database, short and long-term survival in Stemi in a single country over a 12-year period, gradual reduction in variability leading to a high level of guideline adherence in that particular country. And if you look that 12-year follow-up period, the cumulative risk of death has gradually decreased from approximately 20% over a follow-up period of 12 years. So adherence to the guideline-directed medical therapy and its association with rehospitalization and mortality following coronary artery bypass surgery. This is a study where after post-surgical, nearly 1,100 patients studied, and in conclusion, they concluded that in CABG patients, discharge recommendation to GDMT was associated with a lower 1-year readmissions and mortality and lower intermediate term mortality. Another data that 147 patients of STEMI who underwent coronary angiography with successful reperfusion, 87% of the patients received the combination of the 4 guideline-directed medical therapy, combining of dual antiplatelet, beta blocker, statin, and ACE inhibitors. And they also concluded that optimal secondary prevention remedications are known to be effective in reducing the risk of repeat ischemic events in ACS. And this is the full data that all-cause mortality was reduced, death or cardiovascular hospitalizations were reduced, the individual components of the all of the major adverse outcome, cardiac outcome. Now the question, so the guideline-directed medical therapy should be there. It is very relevant, should be implemented. But how can we make it feasible? How to make this thing feasible? There are 3 parts of it: education, that is information transfer, and competence training, and quality improvement. 3 education pillars are there for to make the guidelines GDMT feasible. Information transfer is right now what we are doing, holding seminars, different sessions, educating the doctors. And number 2 is competence training, which can be done by various novel methods are being tried, like the GDMT team in hospitals or protocol-driven physician-led pharmacist, nurse practitioner to oversee implementation of GDMT. Clinical decision support instruments built into electronic health records systems provide an opportunity to improve provider adherence to cardiovascular clinical practice guidelines. These can be defined ways of motivating and implementing the GDMT. And what are the results? What is the outcome we are looking with the GDMT? If you look at the nationwide data of the NCDR action, go with the guidelines registry set up in 2007, and the benchmark was used. Here you see that with the highly performing hospitals at a 99% approximately adherence to all these 5 agents: aspirin, propiodols, beta blocker, ACE inhibitors, and statin. But low performing hospitals were not that adherent to the guideline-directed agents. Whether the similar thing can be done in India? We had a pinnacle registry coming from the southern India, which of course not on STEMI, but on heart failure, where they have over a period of time, 2008 to 2014, 6 years, there have been education, intensive training, and you can see that the medication use has improved substantially from approximately 30% to more than 50% in these 6 years. So this is quite feasible in India. We have to be at it. Thank you.
Thank you, Dr. Sinha, for your excellent presentation. Just like to ask you one question, Rishi. I think this guideline-directed medical therapy will depend upon the complications that a patient has. For example, if he has left ventricular failure, then the guideline therapy changes. As you said, that MRAs should be added, and maybe ARNI. And when do you want to add, suppose a patient has significant left ventricular failure, when do you want to add ARNI and SGLT2 in such patients, in the hospital stay or after discharge?
Thank you, sir, for bringing up this very important topic. See, this guideline-directed medical therapy, these 4 agents, this antiplatelet agents, beta blockers, ACE inhibitors, and statins, are basically for a stable patient. But what about an unstable patient who has gone into failure? Of course, there we have to introduce the class 1 agents, the MRAs, the SGL2s are now class 1 agents, and the ARNIs are now class 1 agent. Yes, we are replacing the ACE inhibitors. Both the European Society and the American Heart Association, ACCAHA, has shown that ARNI is preferred rather than ACE inhibitors in patients with heart failure. So these 3 agents will come in patients with complications. But we are talking about patients' basic guideline-directed medical therapy, which comprises of these 4 pillars.
I was asking, how soon can you introduce them? Can you introduce before discharge?
See, ARNI has been found to be beneficial if it is without waiting. You can start in the hospitalization itself. with SGLT2 inhibitors, you can also introduce the hospital insult. What about the aldosterone antagonist? There is data that to suggest that if you start it on the day 0 or day 1 itself, it is beneficial. But many of the authorities will recommend that you start it a bit later, 3 to 5 days later after the index event.
I'll pass on to the other chairperson, Dr. Pancholia, Dr. C.P. Roy.
Dr. Sinha? Yeah.
I think there was a study in Kerala, the ACS Quality Improvement Program, which looked at the 30-day event rate after an acute coronary syndrome, a randomized control trial. And that trial actually showed a trend towards a better improvement in the 30-day event rate in patients who followed an ideal toolkit of post-MI management.
Yeah, Dr. Jakar, yeah. Sorry, I missed that.
That was a very randomized control trial on this post-MI management in India. And that trial actually showed, unfortunately or fortunately, the treatment rate of control patients were also very good in Kerala at that time. So that the difference between the active arm and the control arm was not very robust.
Thing is that these are all part of the how to enable the physicians to change their practice. In more, India is a big country. One part of the major hospitals, as I saw
that is the Kerala experience showed that when you showed the physicians that this is the data and there is a difference when you give a guideline directed medical treatment, the patients are benefited. Automatically that transfers into their changes their practice pattern also.
Yeah, that is correct. That is also shown in other countries as well. Even in USA, as I showed that in high-performing hospitals, the adherence to GDMT is more than 99%, 98%, like that. But in low-performing hospitals, it is less, 70%. So in India, you have to go continuously try to teach and implement the guideline-directed medical therapy and enable the physicians to do that.
The best way is to do the registries, do a study ourselves, what we are doing, how is our guideline-directed medical treatment, and that will teach us to improve.
Yeah, sure. Yeah, in this respect, I can tell you one thing that with the Presco.
Sorry to interrupt, sir, but if we can move on to the next speaker because of paucity of time, sir. And we can probably have the discussions at the end of all the talks.
Okay.
Yeah, I think Dr. Pancholia take over. Dr. Pancholia, would you like to take over?
Thank you very much. So the next talk will be on the post-MI return to work, do and don'ts. Dr. Jay Gopal from Palakkad.
Yeah,
Dr. Jay Gopal, please.
Yeah, good afternoon, respected chairpersons and dear friends. As Professor Manchandra mentioned earlier, you have a lot of guidelines when it comes to treatment of STEMI, whether it's a reperfusion therapy or, just now we were discussing on the guideline-based medical therapy, but little is stressed about what one should be doing and what one should not be doing, and that too in the context of somebody getting back to work. Well, I think the most relevant literature which I could really pick up was basically from the European Society of Preventive Cardiology, which has given us some overview and sort of an excellent review on what one should be doing. So let me start with a case discussion. This is a real-life scenario about a 45-year-old male hypertensive head load worker. This guy has a STEMI, anterior wall MI. He comes to hospital within a short while, but unfortunately, this guy gets a recurrent VT, VF, and even had a cardiac arrest while in the hospital, revived on a ventilator. PCI to LAD done within 2 hours. Excellent result. But the LV EF is about 30-35%. And he's fairly stable, discharged on the 5th day on dual antiplatelets, all the guideline-based medical therapy which we are talking about. And that was a kind of EKG. I mean, very scary for the physician. Now the question, it's a real dilemma. You have a completely reperfused vessels. This is a kind of ECG prior to discharge. And so what do we do? The question comes back to you at the end of 3rd or 4th week and asks you, when can I get back to work? So the entire story. LV dysfunction, cardiac arrest, revived, STEMI, but then fully flowing vessels. Now, let's look at the real world data, the return to work, that's the RTW, which is an acronym here. So the initial treatment strategy, within 12 months, it's only about 67 to 93% they come back to work. And if you look in the literature, this is again a good review in the JACC 2015, it's found that it's only close to about within the mean time delay is about 2 to 3 months. And again, another national Danish registry where they had a very high initial rate of return to work, about 91%. What they found at the end of 1 year when they followed up, it was that about 25% of them, they really did not go back to work because of many reasons. And that's what people are interested in and trying to find out why. So the lot of factors are very relevant here. For example, the most important thing is the medical, because what I was talking about, the cardiac, you're concerned mostly about the left ventricular ejection fraction. That's what the physicians or the cardiologists would look to. But perhaps more important than that, what is really stressed today is the functional capacity. And that's what we should be aiming at, looking at the cardiopulmonary exercise stress testing and to see where you are, which may not be a practical solution to everyone. But there are other issues like the non-cardiac, the diabetes part of it, chronic kidney disease, chronic obstructive airway disease, which can also be really, really detrimental. But more important is the psychosocial. For example, you have a patient who has had a cardiac arrest, has gone through this trauma. That is important. You need to also focus on to the work-related factors and again, the self-estimation. So the psychosocial factors, which has not really been thought about in great, is also one to need to consider about the work gratification, where what one would get in the situation like this. For example, the cardiac related, as mentioned earlier, would be the functional testing, cardiopulmonary exercise testing, rhythm stability, which is very important. Complications, for example, the patient we had who had a cardiac arrest, all these things need to be considered. But I think the more important thing is the psychosocial, which is not really looked into, the work gratification, whether he is being recognized in his place, the work pressures which one should go through. And again, the depression, anxiety, doing night duties, and high physical and mental requirement like the patient in question here. And what they found out in a Swedish longitudinal occupational survey is that when you are in a stressful occupational exposure, one need to also consider that arrhythmia like atrial fibrillation really predominates here, and the hazard ratio is about 1.37. And women, apart from this, they also have to do the domestic chores. So again, the problems are confounded. In fact, there is a wonderful article which has come in the Circulation Cardiovascular, where they analyzed a fairly large number of patients who returned to work after myocardial infarction, comparison between young men and women. And they found that women are less likely to come back to work after men. And the disadvantage perhaps related to many factors. Now, looking at the psychosocial factors, there are 6 barriers, which I don't want to go into, but the anxiety, comorbidity, very important, old age, and facilitators, again, job control. And more important, perhaps, is a financial satisfaction, which plays a very important role for the patients. Now, work-related factors are very important. I think this is perhaps the most important thing, like the case in question here. Intensity of exercise. With, for example, a head load worker needs to go back to a real kind of physical effort. And the specific workplace situation, for example, the atmosphere, the pollution or things like that, the high noise levels, and all these things are perhaps very important. And there was also a survey which also looked into, and what is very important is people having a university degree being self-employed and presenting a lower value. There are many scales to see the depression level, assessing the psychosocial factors, which I'll come to a little later on. That's a very important role. So I think the predominant role when you see address this question of when to return to work, for the cardiologist, it's basically looking at only the medical examination, coordination of the treatment, again assessing this sudden cardiac risk, stratification, and final cardiology assessment. Perhaps most important, apart from LV ejection fraction, is the cardiopulmonary testing, exercise testing, and again, communication with the general practitioner. But I think all this group of patients, the psychologists, social workers, physiotherapists, occupational therapists, again, need to be talking to the patient, and it has to be patient-centric. Now, if you were to have an algorithm, this is what is proposed. If somebody has an acute treatment, acute coronary syndrome, we basically look into the functional parameters. And that's where what is really recommended, at least in a study in Germany, where they put into the bicycle ergometry, which is not very practical in our country, but perhaps a simple stress test would be useful, which I'll come to a little later on. But a cardiac pulmonary exercise testing is probably what is recommended. Again, when the person is fairly normal in the effort level, he can get back to work, full-time work in about 6 to 8 hours a day. Otherwise, based on his exercise test level, we need to be addressing the issues where the number of meds involved is very important. So I think this is known to everyone. I need not re-emphasize where the ability to do a 6 minutes walk test, and also the kind of effort that can be done, which can be easily calculated based on his job, based on for example, a vigorous effort would approximately be about 8 minutes. And for a person who has to do a high physical load, it has to be more than 8.5 or close to 9 meds. Or in short, more than 7 meds would be what is required on a stress testing to decide whether he can go for a real physical conditioning. And there is an algorithm which has been proposed by the European Society Council for Cardiology Practice. Acute coronary syndrome, we look into whether a revascularization has been performed. If it is so, look at the ejection fraction. If it's more than 0.50%, and if the stress test is negative, his working capacity is normal, he can be back to work as early as possible. Whereas if the stress test is positive, then I think M5 is that he can perform tasks which are less than 5 meds. Whereas if you have a low ejection fraction and a positive stress test, that is, he is not suitable for any kind of work. So I think essentially this algorithm is very useful, very simple way of assessing when a patient could be back to work. I think the stress which Professor Manchanda alluded to, I think little emphasis is in our country on cardiac rehabilitation. I don't want to go into the depth because there is another talk which is coming in the same session. But I think it's important to understand there has to be a promotion of physical activity, nutritional advice, tobacco cessation, medication adherence, and education. We all know the good effects of cardiac rehabilitation, reduction of cardiovascular mortality by about 26%, reduction in hospital admissions. Not only that, improvement in the lipid profile, and again, the psychological well-being is all these things which are perhaps very important in a cardiac rehabilitation. In fact, there have been strategies which have been done in our own country itself, where outcomes after a 12-week rehabilitation program, the knowledge improvement in the intervention group is significant. 6 minutes walk distance is better, and again, a better improvement in the lipid parameters, and significantly higher levels of physical activity, as well as a means of 10 minutes continuous physical activity time. I think these are significant, and again, it addresses psychosocial as well. So we all know that the reduction in all-cause mortality. I don't want to stress this further, but then unfortunately in our country, if you look at the cardiopulmonary rehabilitation, it's mostly centered around the urban countries, maybe a little bit in suburban, but in the rural area, it's a very dismal figure, and really not very happy to talk about. So the question finally comes, for somebody to get back to work, what is the other alternative? I think the home-based cardiac rehabilitation is a potential strategy, which again is something, there are a lot of benefits which could go into, but there are some disadvantages as well, which I am sure will be talked about in the cardiac rehabilitation. And I think at this point of time, I need not have to go to there are 4 phases. I don't want to go to the phase 1 and 2. Phase 3 is what we are looking at, 6 to 8 weeks when they're back to work. So this is intermediate outpatient area where the exercise and the kind of exercise to be included in the phase 3 is outlined here. So 10-minute walking, the biceps curls. It's not just the isotonic, but even the isometric exercise could be advised based on the algorithm that we have here. And then one could have an education checklist session, just list. Not only it's important that the physical effort is taken to smoking, the diet, physical activity, the psychological issues, all these have to be addressed by the entire team. Again, sexual dysfunction, all these things are important. Occupational factors, and again, cardiopulmonary resuscitation. And you also need to understand that when a patient who has gone for cardiac arrest, these are the patients who really do not go back to work because of the psychosocial factors involved. So there are some do's for risk factors. Aim for about 20 to 30 minutes of exercise daily, and if they are not used to increase, it gradually has to be increased. Stop smoking, blood pressure control. Alcohol, again, very important, not to exceed about 21 units a drink for men, 14 for women, with no more than 1 to 2 drinks. And then lose weight if it's overweight, have a healthy diet, easier said than done. And all these things would definitely help. But I think at this point of time, when we try to say about cardiac rehabilitation, it's also important to understand there are some contraindications, some don'ts, which you need to be taken into consideration when somebody has an ongoing chest pain, unstable angina, uncontrolled hypertension, orthostatic hypotension, arrhythmias, severe aortic stenosis, uncontrolled diabetes, heart failure, resting heart rate of more than 100. All these things would again be a contraindication. One has to be careful in this regard. Otherwise, I think the way to go about is cardiac rehabilitation. Most of our patients today in the reperfused era should be able to be back to work in about 3 to 4 weeks of time. Thank you all for the kind attention.
Thank you very much, Dr. Jayagopal, for your focused presentation on the getting back to work after STEMI, what to and what not to do. We'll have all the questions at the end of all the presentations. So we move on to the next presentation, and that is by Dr. Charan Lanjevar on early discharge post-primary PCI. How soon is safe enough? Dr. Lanjevar.
Good afternoon. Let me thank at the outset to Dr. Nitish Naik and Dr. Rakesh Yadav to give a nice opportunity for an interesting talk here. I'm going to talk on early discharge in post-AMI patients, post-PCI patients rather. I'm not getting my slides. My slides are visible?
Yes, yes.
Thank you. So let us start with the case. This is a case scenario where 53-year-old male, hypertensive, non-diabetic, non-smoker, having an angina of 3 hours duration, coming to lab within 5 hours. He was hemodynamically stable, no failure, having Philip class 1. ECG was showing extensive interval MI, and echo was ejection fraction of 45%. Taken for primary. This is the shoot angiogram, left LED total occlusion in the proximal segment. RCA is normal, and he underwent a successful primary angioplasty with TIMI-3 flow in the distal LED. So the question is, what time you will discharge this patient, and what is the evidence to discharge safely, maybe from 24 hours to 48 hours after the hospitalization and 48 to 72 hours. So even we are not sure about what is the safety and what medical legal issues are there. So to outline, let us to reply that question, I will go through across my scientific data. I will discuss with how relevant in India this topic is, feasibility and the benefits of the early discharge, guidelines and their limitations, safety concerns with early discharge policy, and evidence supporting early discharge. As the Stemi PCI care is improving overall India and everywhere, and with the better quality anti-thrombotic agents and the reperfusion therapies, we are having a good results as far as Stemi PCI is concerned. However, the longer stay in the hospital is causing a major hazard as far as on the financial issues and also on the psychiatric status, besides the increasing the expense of therapy to the patient. What is the relevance in our country as such, as we are a median income strategy nation? So India has highest number of ACS patients with more than 60% contributing to STEMI. The number of primary PCRs are increasing day by day in our country due to increased availability of centers capable of primary PCI, easy availability of the personnel required for a PPCI, improved equipment of the hardware, including wires, balloons, stents, the thinner stents, and all, and the different health schemes available throughout the states and at the central government level also. So even financially, lot of health schemes are taking care of those patients. What is the need of discharging patient early? So one aspect was the economic aspect as far as health expenditure is concerned. Another is the technical aspect. Early discharge makes feasible due to following things, like mainly technological advances, pharmacological advances, considering the newer antiplatelet agents like ticagrelor, prasugrel, GPI inhibitors, and the procedural innovations which are come in the recent past. As far as the pandemic effect of COVID-19 is concerned, all of us gone through it, and we know that there was a lot of bed problem when we had a pandemic in our last year session. So to free up the limited hospital resources, beds, personnel, etc., and also as an infection control strategy, there is a need to discharge patient early. Benefits of early discharge, not only to reduce the length of the stay, but improve the patient satisfaction and better resource utilization. As far as the elective PCI is concerned, there are a lot of papers who talks about same-day discharge, and it has been already been shown by different trials. And as you can see this in figure, that as you can see in this figure, that both the 30-day and the rehospitalization between same-day discharge and overnight stay patient were not significantly different. What the guidelines say, the 2017 guidelines, ESC guidelines say that it's a class 2A indication. Early discharge within 48 to 72 hours should be considered appropriate in selected low-risk patient if early rehabilitation and adequate follow-up are arranged. So that's very important. So what is the limitation? One is how to identify those low-risk patients. There is no uniformity criteria as such. What is the appropriate timing of discharge in those is not clearly defined. Evidence for these recommendations is very sparse. and no randomized controlled trials assessing this strategy has enough statistical power. So what can go wrong with if you discharge those patients early? One important factor, the complication. Every interventional cardiologist gets scared about related complication to the STEMI and also the procedure like primary angioplasty. Other factors influencing early discharge include the functional status of the patient, presence of comorbidities like stroke, diabetes, or any other problem during the STEMI, absence of acceptable social support. So the potential disadvantages of this strategy include less time for the patient education, drug titration, and cardiac rehabilitation. That is the negative side of that. Coming to the STEMI complication, generally what the different trials and different studies have already shown that whatever complication occur, they occur within 72 hours of post-STEMI and the procedure. This complication could be early complication related to the procedure, as well as delayed complication related to the side access complications, stent thrombosis, delayed contrast reactions, and the arrhythmias. As far as the radial interventions are increasing in our India and all over, we can see that the radial complications are hardly there within 6 to 24 hours after the post-STEMI procedure in those patients. So studies evaluating the safety of early discharges. There is a meta-analysis by Gong, and he has taken 5 randomized controlled trials, including about 1,500 patients, and found that early discharge strategy after successful primary angioplasty is safe among selected low-risk patients. A shorter hospital stay could benefit both the patient and the healthcare system. So these are the 5 RCTs, including, however, number of patients were high in those patients in all trials, and you can see that the discharge within different trials and discharge timings are different. 24 to 30 hours. The Melberg has less than 72 hours. So one uniformity was not that maintained there. Another thing, the risk criteria. Few follow the Zoel risk criteria and another follow the different criteria. Let us go to what is the comparative rate of mortality in that meta-analysis. We could see that at the early discharge as well as the conventional discharge has the same 30-day mortality as well as 30-day outcome in those patients. One study, safety and feasibility of same-day discharge strategy for primary PCR. Patients were discharged. There were 2 groups, less than 24 hours and 24 to 48 hours. And this group this was studied in about 600 patients and found that the low-risk patients are safe to discharge within 24 hours. Another study, which is published in Egyptian Heart Journal by Haji study, and it was done in 557 patients. And this study also demonstrated the same, that discharging the patient within 24 hours or within 48 hours has the same outcomes. There is no difference as far as safety endpoints are concerned. So how to identify those low-risk patients suitable for early discharge? So there are different score systems. There is Zoel risk score, PAMIS criteria, and Cadillac risk score. They are used in different trials. So one important score which is easily can be done is as well risk score. The simple criteria are there: age of the patient, 60 years or older. If it is more than 60, it requires 1 point. Time to reperfusion, if it is more than 4 hours, more than 1 point. Anterior infarct, hemiflow after the angioplasty, 3 vessel disease, and Kelly class. So if you have more than 3, then it is a high risk. Less than 3 score is safe to discharge those patients. Other criteria, more or the less, they are all clinical criteria and angiographic criteria and the post-op procedural criteria. This is also another Cadillac risk score, but I think the Zoel risk score is more which can be easily followed, which has a specific points. A Canadian study has done one important study at Ottawa, and they come up with the very early discharge policy protocol. It consists of 4 blocks. One is important is you have to identify which are the low risk patient, then the pre-discharge evaluation of the patient, then on the discharge, what else can be done by the paramedicals and the medical guy, and when the post-discharge follow-up can be there after 1 month to the interventional cardiologist. So this is the overall protocol. Step 1, eligibility criteria. Eligibility criteria I will go in detail in the next slide. Step 2 is you have to just make early discharge program and complete the pre-discharge task. Pre-discharge task mainly focuses on the cardiology nursing coordinator to talk to them, and also the interventional cardiology, order the proper treatment at that point and refer patient to the cardiac rehabilitation and for the recounseling. Then the follow-up, there is a telehealth nursing follow-up at the 48 hours, 7 days and 30 days, and a follow-up, a few questions are there which talks about the clinical as well as post-clinical parameters. Then this is the checklist which has been given. These are the most important.
Apologies for interruption, Dr. Lanjevar. We'll have to move on to the next talk because of time constraints.
Yes, this is my last slide. So take-home messages: early discharge post-primary PCI is an attractive and relevant strategy. It benefits patient and care providers. It saves the resources. Studies and guidelines support the early discharge policy. However, important to identify those low-risk patients eligible who will get benefit from this strategy. Thank you very much.
Dr. C.P. Roy, please take over.
Okay. So the next speaker is Dr. Anil Dhal. He is my old colleague, a brilliant cardiologist. And the topic is setting up a cardiac rehab program post-MI, the bare essentials.
Thank you, sir, for those very kind words. And I know we are all running behind time. So I'll try and be quick about it, because this is a very ambitious thing to discuss a topic as nebulous and as cardiac rehabilitation in very little time. So if you can see my slides, I'll just, yeah. So we all know that when William Hebden did describe angina, he actually told people that if you have angina, you go back and chop wood in the forest for 6 months and you will get better. But after that, we went into a kind of a lull and did not want to have much activity, especially since Herrick described an MI, and in 30s, everybody was confined to bed rest. In 40s, there was a chair therapy. And it was only somewhere after the 70s that we started having early ablation. So if we just take a quick recap as to what is cardiac rehab, and we've all had quotations of 26% and 24% improvement in mortality, but these are very, very multifactorial issues, and it's very difficult to actually get a precise figure, because in time, the treatment modalities themselves have changed. But a composition of exercise, diet, stress reduction, obviously good medical management, stopping tobacco use will all contribute to what we can define as cardiac rehabilitation, because it should definitely decrease the chance of a second event, or what we can call a MACE, a risk of sudden cardiac death or a future cardiac event, maybe decrease some medication, control some risk factors, and maybe also contribute to weight loss. But when we look at a patient with STEMI, we all know that our primary target as a cardiologist is to salvage the myocardium, to minimize the risk of arrhythmic death, to minimize the risk of re-MI, and to have an infarct-related artery reperfusion to further limit myocardial damage, to actually improve the LV function and the LV remodeling. Because we all know that the LV remodels, and it can undergo this by infarct expansion and global remodeling. So the composite of care would be prompt revascularization, appropriate antiplatelet antithrombotics, beta blockers, heart rate control, ACE inhibitors, ARB, ARNI, MRAs, LDL lowering, and although we can't afford the EVOPAX trial, but it's a very attractive hypothesis. The early use of SGLT2 inhibitors, tobacco cessation, exercise, and a very nebulous term called lifestyle advice and stress management, because I think these are easier said than done. Because one size does not fit all. The patients are all going to be different. Nobody's read a textbook and come. Everybody is going to have different LV function. Somebody's going to have mitral regurgitation. Somebody's going to have pulmonary hypertension. Their functional class is going to be different. The 6-minute walk test, the exercise test, the cardiopulmonary exercise testing, it's all going to be different. There's going to be different in in ischemic burden, residual ischemia, some CTO you have left as a residual ischemia, the arrhythmic risk, a risk of concurrent drugs, suppose somebody has atrial fibrillation, the sudden cardiac death risk, weight, somebody is obese, somebody is thin fat, somebody has sarcopenia, the elderly, age itself, clinical cause, ambulation, risk factors, smoking, presence or absence of diabetes, psychosocial stresses, sleep, and in these COVID times, job security, self-esteem, gender, affluence. Does he have the money to spend on all these rehab strategies? Whether he's living in a metro, in an urban, rural area, whether he's a loner, whether he's a team player, what is his family, spousal, and caregiver support? Is the spouse only enjoying the brutality of the honesty and constantly nagging him or her, and not being able to provide the requisite emotional support? What about the comorbidities? Somebody's had a stroke, somebody's got peripheral vascular disease, osteoarthritis, malignancies. What about his ventilatory capacity? People have advanced OSA, COPD, ILD, previous fitness. What are his fitness goals? Mental robustness, attitude, illiteracy, comfort of device use, connectivity, bandwidth, and goals. So it's so nebulous that it's easier said than done. We all understand that it's easy to refer, very difficult to comply. And we all know that comprehensive cardiac rehabilitation will have multiple components, which will include exercise, diet, medication, tobacco counseling, psychosocial assessment, and all this will lead to target behavior, immediate outcome, and secondary prevention. So it's a multidisciplinary effort to decrease cardiovascular mortality and hospitalization. And you can compare it to somebody who has no exercise at all, which is very difficult. Like I said, what is healthy lifestyle? We all talk about it. Nobody can define it. Maybe survival in terms of longevity should be taken as healthy lifestyle. Well, really, the risk factors don't add. The relevance of achieving ideal body weight, well, it's important, but is weight good enough? Or is it muscle mass and body fat composition? What should be taken as more important is something we need to understand. We all know that every 1 milliliter per kilogram per minute increase in peak oxygen uptake decreases the risk for cardiovascular and all-cause mortality by about 15%. So we all understand that 30 to 60 minutes of moderate to intense aerobic activity, at least 5 days in a week, will help us in decreasing cardiovascular mortality. Also, it will build muscle mass and benefit insulin sensitivity, lipid control, and blood pressure control. The sexual advice is usually forgotten. We all understand that the risk of sudden death or AMI is low, but we never factor that the energy expenditure is probably just like climbing 2 flights of stairs. Like has been mentioned by my previous speakers, job losses, psychosocial stresses, and not having good family support can have a 2-fold increase of mood and anxiety disorders, and can themselves also contribute, along with things like sleep disorders, can contribute to a large amount of factors. Living in a polluted environment, we all have air pollution, particulate matter, environmental pollution. So all this is something which is part of cardiac rehab. But one thing which is common in cardiac rehab appears to be exercise. Because whether you do any other form of treatment, whether to benefit your glycemic control, your blood pressure control, your lipid control, your smoking cessation, in everything physical exercise can contribute, not only by itself, but by improving psychosocial factors. So there can be somatic objective, educative objectives, and psychosocial objectives, which can further increase aerobic endurance training and resistance training. So when we have to give an exercise prescription, we have to understand the exercise goals, the content, the method, the intensity, the duration, as well as the frequency. You can take it as fit, frequency, intensity, time undertaken, and the type of activity. But we also know that one size does not fit all. It's pointless telling somebody who is 60% overweight that you should run 10 miles a day. It's impossible. And training can be either supervised or in rehabilitative groups, or it can be home-based activity, because we have to find the optimal dose and intensity of exercise. How do we do this? We have to risk stratify the patient. And how do we do that? We have to look at personal characteristics, behavioral characteristics. Do we have time? Do we have counselors to do it? And we have to individualize the objectives of the exercise program and to adapt the dose and the training and to control the efficacy. Now we can use a standard exercise test or what is talked about in textbooks of using a cardiopulmonary exercise test. We can use this and make an exercise prescription according to it. And again, it can be taken as low, moderate, and high conditions. We can put stages of exercise, initial stages, 4 to 6 exercise units, improvement stage, maintenance stage, and we can follow the Borg scale, which is the rate of perceived exertion, which is, or we can actually use the exercise intensity, trying to define the anaerobic threshold, because we know that our exercise can either be aerobic cardiorespiratory or it can be resistance training. We also understand that the aerobic activity can either be a medium intensity continuous training or it can be a high intensity interval training. And high intensity interval training appears to be the fashion of the day because it's still aerobic below VO2 max. It is above the intensity threshold where fatigue occurs and muscle metabolites start to accumulate. And the intensity cannot be sustained for prolonged periods without dropping the intensity. And it also allows for recovery. So it helps us in gaining muscle mass and it helps us in a graded fashion increasing our performance. What about resistance training? We also understand that in a variety of conditions, there would be absolute or relative contraindications to resistance training. So by and large, we make a simple prescription of different phases, maybe a phase 1, which includes a warm-up, a phase 2, which increases the exercise intensity, phase 3, which probably includes an aerobic or a cardiorespiratory fitness, and phase 4, which is a cool down. And we understand that by doing high intensity training, the post-infarction LV remodeling has been shown in some case reports to actually improve. Well, what about yoga? Professor Manchanda is here, and he's been a great proponent. And this was put together by Prabhakar and him and all the other people who are so erudite in this, in a yoga care trial, wherein there were 4 phases in patient care: formal, outpatient, formal, session 2, and a long-term maintenance with different weeks following an MI. And this was actually put through in a formal OPD session. They defined the exercises, the yogic exercises, whether it was Anulom Vilom or Brahmari or Ujjayi Pranayam, and some meditation, relaxation. So this also included some psychosocial and meditation factors, included further into a formal OPD session. And thereafter having some core and elective items in a more complex set of exercises. But what happened to the results? The MACE was actually comparable, 6.7% versus 7.4%. And the self-rated health was 77 versus 76. There was a greater return to pre-infarct activity in the yoga care group, but there was no difference in tobacco cessation or medication adherence or any of the secondary outcome. And this has recently been published. And this is all for us to see that despite the fact that we felt that this would be a perfect solution, the adherence, the compliance, and the regulation is also very important. So when we are planning a strategy, we have to think of the advantages and disadvantages of a home-based or a center-based. We all know how travel is important, and therefore a facility-based can only be in person.
Sorry, sir, we have overrun the time, and we'll just have time for a couple of questions across all the speakers.
I'm fine. I'm fine with that. You want me to conclude? Then I can quickly conclude. Otherwise, we. All right. So I think that if you just look at telecardiology is probably a way of because we can improve the accessibility. We can have data which is coming in through a lot of trackers and wearables, which can be used with AI to coordinate all this. And this can be a sensor suite which can be made to drive an AI-driven algorithm, and a specialized team can then offer targeted care. And this can lead to more focused cardiac rehab, not just by commercial programs like the Peloton or the Tread, which are basing with something with a computer in front. We also need to determine our social determinants of cardiovascular risk, because our social media is going to give us some answers. and the whole is going to be greater than the sum of its parts. So if we put it all together, we need to individualize to our geography, to our patient population, to the resources we have, and we have the tools with all the modern wearables to put it together and achieve better cardiac rehabilitation. Thank you.
Well, any comments? I think we have 4 speakers, 4 chairpersons.
Dr. Lanjewar.
Yes, sir.
There was a paper in JAHA which highlighting the added value of anti-pro-BNP to the JOL criteria, JOL risk score. What is your comment?
Actually, yes, there is a paper very well mentioned, sir. Basically, it talks about the infarct size, and when it takes time to get down, that was the only problem, because you will be scared if the troponin is high at second or third. Then generally most of our patient will not be normalized as far as troponins are concerned. So mostly we will not be able to discharge those patients. So that was one disadvantage of that. But yes, on more safety ground, we could mention that criteria in the JOL one.
Dr. Charanjeevar, in the CSI COVID AMI study, there are 41,000 patients with acute MI. The mean hospital days in the Indian study was 4 days, 3.98 days exactly. It is more for STEMI, and the 3.5 days mean was the NSTEMI. So in India too, I think we are discharging early. But how early do you discharge now? Now I think it seems that India data says that it's 4 days. Is it true for every patient in your center also, or is it different?
Number of trials which I gave the data, they talked about, they divided into 2, within the 24 hours and after the 24 hours. So presently, I think it is safe to discharge the patient who has low risk, like which I told about the patient characteristic, like younger age, no other risk
Average,
factors.
I was talking. Average, how many days?
Sir, average less than 48 hours. Most of the patient can be discharged if they are in the low risk group.
But we are actually admitting them for 4 days now. Right.
Yes.
Okay, thank you. Dr. Jayagopal, the patient you showed, that head load worker. Now, if this LV function is normal, LV function is impaired, and do you think that you will, even if he has achieved 7 minutes in exercise, if the ejection fraction remains 30%, will you allow him to go back to his work?
Not within the next 3 months. I think these are patients who should take a little longer time for them to get used to the rehab.
So that it is safe to send a head load worker back to head load working.
Yes, maybe at the end of 3 months, once he has had that fitness level, if he's back to, see, people can still live on a 35% EF doing. In fact, I had a similar patient from US where he had multiple stents, 35%, and the protocol was very clear there. They put him back after 3 months, but after perfect cardiac rehabilitation, where he went through, he could do about 9 to 10 minutes on a stress machine. So I think if we are able to do that at the end of 3 months, he can go back even with an EF of 35%. Provided there are no arrhythmias, all these things are important. I think I just have another question to Dr. Charan also. I mean, interesting this thing. People have started looking into the troponin levels in STEMI. Many people do not look into the troponin because it's an EKG diagnosis. And there is a correlation between the level of troponin rise and the event rate later on. I mean, the prognostication also. So will that be a strategy to think about an early discharge?
Till now, whatever the trials and whatever the data is available with us, including the meta-analysis, they have not considered this troponin as an inclusion criteria. It has been excluded. And I think, but this is very good suggestion, because it is going to talk about more hard point aims as far as cardiac troponin is concerned.
But if I may just add, the unfortunate part is that most of these biomarkers are not completely standardized. And what is elevated in one may not be elevated in the other. So we should actually see what is the infarct size and what is therefore the LV function. And all this thing about trying to see 7 meds being equivalent to a class 1, and therefore you still give importance that for 3 months you do not allow a worker to return to work. If he is class 1 and he can perform 7 meds, it will be a little, he will be suffering psychosocial stresses because he'll have job loss for 3 months. So one has to be a little balanced about this. I think, if somebody can do 9 or 10 meds, we actually clear them for flying. We clear them to be airline and Air Force pilots. So we should not set very high goals for post MI recovery. I think if somebody can do 7
in this connection, I mean, regarding yoga and the early rehabilitation in Indian patient, do you still think that after the yoga care study, do you recommend a routine yoga for all patients discharged with acute MI in India?
I think Professor Manchanda is here and he probably has done much more work on this than I have. But before I may just add that yoga is the most sustainable form of exercise. We may not have any head-to-head comparison data which shows us in a randomized control trial that this is magic. Nothing is magic. It'll all work. And I think it's a very eminently suitable exercise. Rest over to Professor Manchanda, I'm sure.
I just like to comment. I'm glad you see the psychosocial factors after MI have been discussed. You see, we did a study several years back. 40% of patients have depression, and depression has a very bad prognosis in these patients. And we have to take care of those psychosocial factors, and yoga can take care of that. That was, told about this study. You see, there are 2 components of this study. This study is still going on. This was a study at 22 months. And already there was a benefit being shown, although statistically not significant. Those patients who completed yoga much better, those adhered, they had a definite reduction of the primary endpoint like the myocardial infarction, death, and so on. So I think the study is still going on. We cannot say it's a negative. Yoga is not only a few asanas or exercise. It is a complete lifestyle. I call it lifestyle polypid because it consists of a sattvic diet, which is a vegetarian diet, and we know the role of Mediterranean diet. It can reduce by 56% in secondary prevention, and also diet is a part of yoga. Exercise is a part of yoga. Yoga is equal to mild to moderate exercise depending upon what you are doing. Yoga is also can take care of these addictions and so on. And finally, it is very important to manage stress and all. You saw in this study also the return to work was much earlier. So the factor of so-called, we did not measure the anxiety, etc., but the study is still going on and the curves are already separating. If you saw, it was not statistically significant, but in those who did this, who complied with the yoga, it was a statistically significant decrease at 22 months also. So I don't think that yoga can be just negated. There are several other studies also to show that yoga can reduce mortality by as much as 57%. There's a study from United States, 9 years follow, and they did show that it decreases by 57%. And I think the sense of well-being, you have to really talk to these patients who are doing yoga and all. And if you see, the quality of life completely changes in these patients. And the most important thing, you see what we found, which has not been set in this, that the control of mind, which is the weakness of the mind. People know exercise good, still they don't know. After a few months or years, they forget. They don't follow the proper diet at all. What we found is that yoga can increase the willpower, and they follow not only the lifestyle, but also the drug adherence. This has not been assessed in this, but there are several studies to show that because the willpower is increased. So, and even in the editorial, it has been mentioned that yoga could be one of the cheap methods of cardiac rehabilitation in the developing countries, and not only developing countries, the whole world actually. It has been compared to cardiac rehabilitation, which is hardly being done. Even US, hardly 50% are being done, and UK also very little. So I think this could be a good substitute. I do not think it's a negative study. Okay. It's not a negative study at all. If you see, it's 22 months. The return of work is much better. The quality of life is much better. Right.
We would like to thank everyone for a very interesting and interactive session. However, we'll have to move on to the next session because of paucity of time. And for the next session of rapid fire red hot topics, I'd like to invite the chairpersons for the session, Dr. Biswajit Majumdar, and I'd like to request Dr. Anil Dhal and Dr. A.K. Pancholia to kindly stay back as chairpersons for this session. And I would also like to request Dr. C.P. Roy to kindly chair this session. If we can have Dr. Majumdar to kindly begin the session, please. In case Dr. Mukhopadhyay is not here, Majumdar is not here, can we have Dr. Anil Dhal to begin the session, please?
So this is a rapid fire session, and we have a rapid fire cardiologist, one of the most dashing fellows I ever had who worked with me is Dr. Navreet. He's going to talk to us about a very rapid fire and red hot topic that is spontaneous coronary artery dissection and STEMI. So over to you, Navreet.
Good afternoon, sir, and it's truly humbling to be presenting in front of my teacher right from my MD days. Probably I became a cardiologist seeing you. Can I share screen, sir?
We can't see your slides yet.
Can you?
Yes, now it is.
So I'm Colonel Navreet. I'm recently been posted to the Army Institute of Cardiothoracic Sciences, and the topic I was speaking on is the spontaneous coronary artery dissection in STEMI. I would probably cover it in the ACS scenario itself. I'd like to note I have nothing to declare except that I have just a few cases of my own. The rest are copy-paste, and great colleagues and seniors have really helped me make these slides. The pathophysiology is quite interesting. It is basically dissection in the absence of atherosclerotic vessel disease, meaning that it is neither traumatic nor iatrogenic or atherosclerotic. And the two methods which have been explained, the two pathophysiological methods, are that it could be a rupture of the vasa vasorum and then dissection taking place, or a dissection flap occurring and then extending down. So if you see in the two pathological images, you have a false lumen and you have a chinked out kidney-shaped other lumen, the true lumen. Important point to note is the absence of atherosclerosis, and I think that also will be essential when we talk about the role of single antiplatelets versus dual antiplatelets, because the should I say the muck that creates all the clots is absent in this disease etiology. These are two images basically to show the OCT as well as the IVUS of a dissection, where it is quite evident that the OCT is far more precise, but can't give us the depth. And we can see the asterisks. If you see the asterisks there, that's the intramural hematoma, and that's the flap, which is probably better seen in depth in the IVUS. It's been intimately linked with fibromuscular dysplasia, which is basically arterial stenosis and aneurysms dissections in middle-sized or medium-sized vessels. It is a genetic disorder reported, the case reports being majorly from Canada and now coming up from France. Another thing which has been noticed in spontaneous dissection is the tortuosity of the vessels, and that truly corresponds to the severity of the tortuosity. The more severe the tortuosity, more is the more is the dissection, probably emanating from that primary loss of support in the media. Diagnosis is essential. On most occasions, they do present with chest pain, but it's quite atypical and may go unnoticed if they are in the emergency and not well heard to, especially because they are young, they are women, they come back after normal exertion. So the suspicion has to be there. And like aortic dissection, this disease does go unnoticed on occasions, so keep a high suspicion on this. Angiography remains the first and the most important diagnostic test. Ideally, if we suspect it, we should go from the femoral artery, because if we have dissection in the coronaries, we could also have dissection somewhere in the, we could cause a dissection in the radial and then become caught up in that. Once we suspect it, catheter manipulation should be minimal, slow, The injection should not be too harsh. CT coronary angiograms come up in a big way, but still will not demonstrate to us the smaller, or I would say the medium-sized vessels in the coronary tree from 2.5 below. So therefore, not recommended. Not recommended. Because angiogram doesn't show us the walls, imaging becomes the key. And with that, we come to the classification. And as though we are very fond of it, it really makes no prognostic difference in this. Type 1 is the normal common dissection which we always notice, and that's the barber shop pole. You see, that's the barber shop pole image which I put up there, and it's that spiral dissection which is so closely associated. But this happens only about 25% of the cases. Majority will be passed on, like the type 2 dissection, it's about 70%, would be a diffuse narrowing, a diffuse sudden narrowing of the blood vessel, which can go all the way down. So this could be missed as an atherosclerotic disease or a natively thin vessel, but this is actually the cause and is presented by the intramural hematoma. This could be further confusing by a very small, less than 20 millimeter lesion, which would again be mimicking an atherosclerotic disease. The differential diagnosis of imaging is very important. As imaging becomes more and more important in our day-to-day practice, we come to that's an inferior wall MI. You see that in the distal RCA, you have a plaque rupture. Now, this appears like a flap of a dissection, but it's actually a plaque rupture. And you can see the red clot in the subsequent frames. Recanalization of a coronary artery tree, which gives us the lotus root appearance. The lotus root appearance is again a image which can mimic SCAD. Silent SCAD, patient just presents with mild chest pain. We find nothing on angiogram. If you do a imaging, you would probably find a small intramural hematoma sitting there. This is an interesting case. I borrowed these slides from a senior colleague of mine who got caught thinking. See, look at the first top slide. It looks like a normal common garden atherosclerotic disease in a 54-year-old man. And so he wired it and stented it, and lo and behold, the moment he stented, he thought it was the progression of the plaque, but actually he was careful. He did the OCT run, and look what we find. We find that the lumen has been compressed by a large hematoma which was pushed down. So probably this was a type 3 dissection, which presented acutely. We thought it was an ACS, an NSTMI, and you see the chinking of the vessel, loss of the lumen by the compression of the hematoma, which continues actually. And further, one of the complications of this is that the hematoma was present even behind the stent. So there was poor expansion of the stent because of that intramural hematoma. So we see two wonderful things in this case, though at that time we suspected just to be migration of the atheroma. Management, well, very simple. Clinically stable, don't do anything. Patient is sick, take up for a PCI, or if back to the wall, a CABG. The rest, gray areas, you can keep debating. Medical management remains the same, except the dual antiplatelets are going out of fashion. Heparin does help a little, majorly because we want to preserve the patency of the vessel, at the same time prevent progression. Thrombolytics 2B3 is not to be given. Amazing is H.C. Pretty. She's the lady who actually first described coronary dissection. And it's so nice to hear what she gave. And way back in 31, an ounce of castor oil, bismuth, soda, 3 minutes of dilute hydrocyanic acid. So from where to where have we reached in coronary dissection? This is a trial which came out, a registry report which came out 3 weeks back from the French team, and which showed that single antiplatelets far were better than dual antiplatelets. And this emanates probably from the fact that we don't have that atheromatous burden in the vessel. It's a pretty clean vessel. and therefore a single antiplatelet would do equally well or better. Complete healing takes place in about 4 to 6 weeks. We can see recanalization of the LAD very well. Unique features of PCI, if we ever have to go in for that, is that the catheter dissection, induced dissection should be prevented. We should be slow. Wiring should be, again, careful. Look for side branches. Let's not increase the dissection. Intrahumeral hematoma extension should be prevented by using long stents. You could use a cutting balloon, though it's double-edged weapon. DEB, self-expanding stents have all been used, but the bottom is that liberal use of OCT and IVUS is the key. So before I end, unique features and the take-home message. Rare occurrence, what maximum 4% of cases, but a high recurrence, 25% would recur. Atypical symptoms are common, and the subset is very unique. FMDs, connectivity disorders, tortuous vessels, people aren't taking great exercises. And a CIG is most important, but then hold your horses. Don't go for the vessel straight away, hold your horses. Liberal use of IVUS, OCT will help. And with that, I come to the end. Of course, I put these words because they are the ones which stick on in our mind: the lotus root appearance, the string of beads, surprisingly, the disco trial from France, the disco registry disco trial, and the barber shop poll, which depicts the spiral dissection. I've finished, sir. I hope in time.
Thank
yes.
you, Navreet. Beautiful presentation, excellent. You have shown very nice cases also. I have a presentation where I will also show one case, a long dissection. And you have rightly told that conservative management should be more than PCI and CABG very rarely, especially in multi-vessel cases where there are multiple dissections, long dissections. But this is also not suitable because these patients are extremely unstable hemodynamically sometimes, especially which are hemodynamically significant. Some of the lesions are of theoretical value, but these are of practical significance. If it is a long one with multiple lumens, multiple flaps with hematoma in between, and it's very difficult to go even with IVUS or OCT guidance. So you have told each and every word. It's a really fascinating slide that the catheter manipulation should be extremely gentle. Contrast injection should be slow but steady so that we get good images. And IVUS and OCT should be used with all the time.
Thank you, sir. Thank you so much, sir.
Thank you.
Thank you, Anil, sir.
Thank you, Navreet. The only issue which a lot of OCT has been talked about in spontaneous coronary artery dissection, but we all have to inject contrast when we are doing OCT. So one has to be very, very careful. The points you've already brought out, maybe another approach if you're clinically suspecting the patient to have a SCAD is to consider doing more liberal use of CT coronary angiograms so that you don't even do the catheter manipulations in the cath lab. However, if there's, Damon pointed out, if the patient is hemodynamically unstable, then we will have to use our interventional tools. Anyway, thank you very much for a very nice presentation.
Dr. Dhal, sir, can I come in, sir?
Yes, please.
But at the same time, SCAD is diagnosed very well with OCT, though we're going to give a dye. But SCAD is differentiating an intramural multi-layered thrombus from SCAD. The best differentiating tool is in fact OCT only. So
undoubtedly, Sanjeev. The best tool remains an OCT. However, be cognizant of the fact that to try and get better OCT images and to get better contrast, blood clearance, you would have to inject contrast, and that may further expand your dissection. So just be cognizant of this fact. There is nothing else to it. We all understand that the best diagnosis, the best images come with the OCT, but we also realize that to perform an OCT, we have to clear the blood. So and there is a hydrodynamic effect. Yeah, we have to move on now.
Dr. Dhal, can I speak?
Please,
Dr.
please.
Saibal, this side.
Bolo Saibal.
Now,
I was just wanted to know, suppose the patient is having 75% or 90% luminal obstruction due to a SCAD and a hematoma. What is the percutaneous approach? That was not discussed at all.
Pardon me, sir?
What is the patient is having this?
I think, Saibal, there is some disturbance in the communication, but Navreet did mention that in event
there is a lesion in mid and compressing.
I think Navreet did mention that if there is any hemodynamic significance, if there is, suppose you have a patient who's in cardiogenic shock, you have to intervene.
Just I wanted to know, there is a
if you are
if you have to the cutting balloon has a role. No, sir, that is not the issue. The issue is how do we tackle, there is a flow limiting hematoma which has produced active ischemia. How do you go about it? That is the point.
So if you have to intervene, then and if you want to cut the flap, you can consider use of a cutting balloon. But like you said, these cases are few and far between. There is unlikely ever to be statistically significant results to show us one way or the other.
No, this is what he was talking all has come out in a review in circulation.
Listen, we are aware, Saibal, of those reviews.
That's what I'm asking, sir. I'm one of the chairpersons, so I think I should be allowed to talk on this.
No, you should be allowed to talk. I'm
so
saying
let me
that
talk, and I heard this. That is individualized. What is to be told is, if you have to go for stenting, first you have to keep an eye that suppose there is no intraluminal communication, and then you have to limit the expansion of the hematoma distally or proximally. So if you have to stent, protostent distally, proximally, and then over the segment which is appearing narrow. That is one point which is written, so that if there is no intraluminal connection, the hematoma will spread if you don't decompress it or you put a stent there. Because there needs to be an avenue for this hematoma to drain. If it is no intimal connection, there will be a propagation distally or proximally if you put a stent. So they have written, if type 3, where there is a normal segment proximally and distally, first put 2 stents, or you have to cover those parts so that your hematoma doesn't progress proximally or distally. If you don't have an intraluminal communication, or you try to do an intraluminal communication by using a cutting balloon. That is the point I wanted to say. I don't know whether he has highlighted that point, so that's just I wanted to tell this.
So that was the way we my colleague actually tackled this hematoma at Kanpur. He put a stent distally and then used a cutting in between. So you're very right. That's what.
But I did that is the thing.
So I think you missed, Saibal. You missed the presentation. So
no, I was just highlighting. That is what I was
okay.
telling.
I think we must move on because we are getting behind time. Yeah, good point.
Yeah, let's move on.
Thank you so much, sir. Thanks, sir.
The next presentation is Dr. Bhanu is there?
Yeah, I'm here. Can you hear?
Okay, Bhanu. Yeah. Hello, Bhanu. Over to you.
Hello, and can you see my slides? No.
Not yet. We can see you.
No. Are you able to see my slides?
No, Bhanu, we are not able to see. Maybe the previous. Navreet, have you stopped sharing?
You go to the green one, share screen, on the right-hand side after chat. You just click that one, share screen, Bhanu.
Yeah, I am doing that. Allow Zoom, open system preferences.
Just wait, after clicking, it will come.
Okay. So what you can do is, Dr. Dhal.
Yeah, we can move on to one more presentation.
You move to the next presentation, and I'll join from a different laptop.
Sure,
There's a problem in this.
Okay. Dhiman, you would like to call the next speaker, please?
I haven't got the details,
So Safal?
Yeah, I'll just start screen sharing.
Oh, great.
I'm getting the message you cannot start screen share while the other participant is sharing.
So I think Navreet has not stopped screen share. That's what I was asking.
Should I?
I am trying that. So I mean, I did press that. I know. I'll just go and.
Or if somebody from the audiovisual team can just give
just
the
stop
rights.
Screen share. That's it.
Okay.
I can share now.
Yes, sir.
Okay. Is it happening, sir?
All right.
Okay.
Is my PowerPoint visible now, sir?
Yes,
sir.
All right. So the topic that I have been given is 4:38. I'll try to finish by 4:48.10 minutes. The topic that I have been given is there still a role for clopidogrel in primary PCI? So the topic is not define the role for clopidogrel in primary PCI. The topic is there a role? Which implies that many of us think that probably now there is no role for clopidogrel in primary PCI. So clopidogrel is this old lion, which has ruled for a great time. And now these two young Turks are challenging it, ticagrelor and prasugrel. Prasugrel is still a little benign. The injured lion, it is not attacking, but ticagrelor has decided to attack it till death. So let's see. On what basis? Primarily on basis of the Plato trial, which has had magic results. The rate of overall major bleeding did not increase, although the non-procedure related bleeding increased, and there was a mortality benefit. Now, Triton-Timmy 38 still said that, all right, we reduce stent thrombosis, we reduce ischemic events, but yes, we increase the bleeding risk. Plato clearly said that somewhere I have achieved a magic. I may also have some pleiotropic effects for ticagrelor. So prasugrel has already given space to clopidogrel, age more than 75, weight less than 60, history of CVA, and basically the HPR patients. But ticagrelor says, I virtually have no contraindication. I am magic. So the situation of what clopidogrel now is like the Pandavas in Mahabharata asking for just 5 villages. And just that much of space even ticagrelor is today not ready to give. The first space that you would ask for would be the elderly patients. But this sub-study from Plato, around 2,800 patients, clearly states that their benefit is across all age groups. Age is not a defining criterion. So then what? Is clopidogrel dead? Well, as the use of ticagrelor grew and grew and grew, over the past 2 years, a lot of real world data has come. And somehow there is a lot of difference between the real world scenario versus the magic results of Plato. I will just flip through these quickly for want of time. This is the START antiplatelet registry, where the HBR patients were HBR, at least one HBR criteria they should have had. They were taken, and there was no difference with use of ticagrelor in the net adverse events. Now, this study by Turgeon et al. Needs mention because it's a population-based cohort study of 11,000 odd patients, 45% of them being Stemi. And in this population-based cohort, outpatient use of ticagrelor was not associated with a statistically significant reduction in MACE versus clopidogrel, although it was associated with more major bleeding. Now, as I said, the sub-study of Plato said that use me across any age, including more than 75. The popular age trial, although done in N-STEMI patients, clearly stated that this was disadvantageous. Clopidogrel was better tolerated. There was more bleeding with ticagrelor. Here we have data from a very well organized registry, the SCAR registry from Sweden. The conclusion is treatment with ticagrelor was not superior to clopidogrel in patients with acute coronary syndrome. Now, apart from this, there are other studies. There are studies from Taiwan, at least 3 of them. Now, the issue is we can nitpick each of these studies. But the question is, till today, there is no real world data that has externally validated the magic findings of Plato. Question is why? Number one, even when Plato was published, it was discussed that the bulk of benefit in Plato came from a very limited geographic area. Finally, this thing took a backseat. Note that only 6% of the Asian population was there in Plato. So Is it that in other geographic areas, it is not working that magic? It is nothing new that the trial population varies from real world scenario, and the real world results are what matter. External validation is a must, and that is still awaited. What could be the reasons that the real world scenario is coming as different? The most important reason is BD dosing. You start an antibiotic with BD dosing for 7 days for URI. Many of us will complete the 14 tablets in 8 or 9 days instead of 7 days. Whereas OD dosing, 5 tablets we will complete in 5 days. If for 7 days we cannot complete an antibiotic course of BD dosing, to say that BD dosing does not matter for somebody who has to take it for a long time is clearly away from reality. Next, the so-called transient dyspnea, which occurred in 14% of the Plato trial, and in 1% it required drug discontinuation. In the registries, it is coming as quite frequent and frequently reducing compliance or requesting switchover for the less motivated real-world patients. Next, 60% PCIs were done in the Plato trial. Of these, 48% were bare metal stents, 12% were first-generation DES. Now that we are primarily using second-generation DES, frequently with better imaging modalities, it is possible that the ischemic risk per se is reducing, while the bleeding risk remains the same. So this ischemia versus bleeding, the balance is again tilting away from ticagrelor. And lastly, at least in India, where most patients are buying drugs out of their pocket, cost is a very, very important factor. So with this context, what does clopidogrel, can clopidogrel get its 5 villages? So the first village that it must get, and that the guidelines have awarded it, are patients requiring oral anticoagulants. No doubt, for a patient on oral anticoagulants, the preferred drug for loading will be 600 mg of clopidogrel. This is from the 2020 ACC expert consensus. No doubts, no controversies. Next, I don't think we need guidelines for this. Patients with poor affordability, more important in the government sector, where for one stent they have spent their entire savings. What they will do, they will take the full prescription from outside, except the most expensive drug. So these things have to be taken into account. Next, I showed the popular AIDS trial. The elderly or HPR features, think twice before just running away from clopidogrel. Patients with doubtful compliance. One, you can assess the patient and the family, how they are likely to comply. And most important, dementic patients. At night, the whole family will be sitting together. At dinner time, they'll be given all their tablets. In the morning, everybody's running helter and skelter. If those tablets are missed, see, the most important aspect is not which antiplatelet a patient is getting. It is which antiplatelet that patient is adhering to. Another scenario, a patient with recurrent vomiting, you do not know how much of your oral antiplatelet is going to be absorbed. Either you give cangrelor, which is now available in India for a cost of around 12,000, or you give clopidogrel, you're not sure of how much is absorbed, you give additional GP2B. But the higher antiplatelets with GP2B, the bleeding will be in an unacceptable range. Lastly, I'll show you an angiogram. It will just be a schematic diagram because it is of a junior colleague's father. It will not be right to show the angiogram. Done at a peripheral center. 6 hours of pain this patient presented. A 72-year-old male. Quickly, an angiogram was done with the intent to do primary PCI. And what we had here was an ostial left main 90 followed by a proximal LAD 100. The cardiologist at the peripheral center was unable to have, there were a lot of discussions, lot of talk, either do the left main simultaneously or at least with a hanging guide, you bring back flow. None of that, well, the expertise was there. The last talk was that, all right, keep your check flow in, thrombolize this patient. At that time, he said the patient has been preloaded with ticagrelor. So should I thrombolize? Now in Plato, this was one exclusion criteria. Nobody can give you a clear cut that yes, go and thrombolize. Very sad scenario. So you know your expertise. Peripheral centers must do primary PCI, but you know your expertise if there's a reason, and especially elderly stemma, you may not get very easy anatomies. Keep your option for thrombolysis open. If you are preloading, do not preload blindly with ticagrelor. Clopidogrel will keep your options open. Line I missed is pregnancy, which clearly the non-teratogenic potential of clopidogrel is better known than either ticagrelor or prasugrel. So with this, I conclude, clopidogrel deserves more than its 5 villages, and it is here to stay. Clopidogrel does definitely have a role in primary PCR. Thank you.
Great job, Safal. You finished well in time. Any
Thanks.
questions? May I request Saibal to kindly lead the discussion?
I think he has put very strong points against ticagrelor, but we have to respect the Plato trial. Of course, acute coronary syndrome patients and Asians were less. Asians constituted only 6%. But I don't believe these are only points, but he has given other points which are valid. But it's no denying the fact that in majority of our patients, we use clopidogrel and clopidogrel only. I remember once I had a talk with Joe Fajade, and Joe Fajade asked me, do you believe that clopidogrel has so much of resistance? Or no, truly, I don't believe that 25-30% resistance. We read in the books. So your points, Dr. Ching, are very valid. And you have put very strong points, especially in our socio-economic environment. But it's not denying a fact that in severe ACS patients, again, we need to give either ticagrelor or prasugrel, because we have seen at least in a few patients, there is clopidogrel resistance. And, it's not only twice or once, but it's saving the patient also. So it's very important that, we give a little stronger one. And the incidence of bleeding is not much, it's much less. So we don't have to, even with prasugrel, the incidence of bleeding is much less than apprehended. So Anil, your comments, please.
I think you've said a lot of very controversial and very, very counterintuitive things, actually. So I don't think this is, the points which Safal had to make, he has put forth that there is a place for clopidogrel. We accept that. We accept that very cleanly. We also understand the limitations of the Plato trial. We understand the problems that they had with the CRO. We understand the differences in North America and Europe. We understand that only 106 patients during the entire Plato study were those which are following a STEMI. We understand a lot of these limitations. For anybody who wants to know more, we can take a 1-hour session only on this. But the truth is that it has been established as standard of care, considering the fact that we are not doing a lot of genotype studies. We are not doing loss of function allele studies. So we understand that we are trying to save our skins by getting better results. And the problem with clopidogrel was not just the fact that 35% of clopidogrel, we have done studies where we've demonstrated that 35% of Indian subjects are clopidogrel non-responders. However, the stent thrombosis rates are not 35% because you're also concurrently giving aspirin. And there are many other factors which contribute to stent thrombosis, not just clopidogrel. However, even one patient who has stent thrombosis makes you really introspect whether you did the right thing or you did not do the right thing. So absolutely. I think we'll leave it to that. He has made very vital points, high bleeding risk, elderly age group. There are certain instances where we would not use some of the other agents. We also understand that loading with clopidogrel is an issue sometimes because we know it takes time. It's a prodrug. It takes time to act. So all these things have to be factored. I guess everybody here is sanguine to these facts. So I think we'll move on before we continue to have an endless discussion on this. And I think if Bhanu is ready and if Safal has stopped sharing, maybe Bhanu could be ready with her presentation, which...
Yes, I have stopped and I will just make one last comment. We have had a good number of ticagrelor patients when transiently it was not available in the hospital supply who have stopped this drug for cost alone. And that is a simple fact.
So let me tell you.
I would request that we move on because otherwise we can endlessly go on this loop.
Thanks,
I would
Nitish.
request, yes, Dr. Bhanu, if you could start sharing.
So now my screen is visible.
Yeah, just make it on slideshow. Bhanu, just put it on slideshow. That's good. Excellent.
Okay, good evening, everyone. I would like to thank the organizers, Dr. Nitish and Dr. Rakesh Yadav, for having me here today, this evening. So my topic for today is MINOCA, a therapeutic approach. Diagnosis of MINOCA is made immediately once we have a patient of acute MI presenting with a normal coronary artery tree or a coronary artery stenosis, which is less than or equal to 50%. And most often these patients are let off and sent home with a diagnosis of patient presented with some angina with an acute MI, but had a normal coronary artery tree. So coming here to the clinical history, ECG, echo, the diagnosis of acute myocardial infarction is made. The coronary angiogram is normal. And then we proceed to an LV angiogram, which may show a regional wall motion abnormality pertaining to a particular epicardial pattern or pertaining to no epicardial pattern or a microvascular pattern. The epicardial causes could be, once we have an epicardial cause, we should go back to the coronary angiogram and look for a missed coronary dissection or a side branch occlusion. Or it could be that there's some plaque rupture or a coronary dissection or coronary artery spasm. Microvascular causes could be Takotsubo's, myocarditis, coronary artery spasm, or myocardial spasm or myocardial angina. So here is the flow chart for proceeding with such a patient: ACS, echo, coronary angiogram, and diagnosis of Minoka, which is often a working diagnosis. And then we can proceed, once we have done an LV-gram and ruled out Takotsubo's myocarditis, we proceed to an OCT or an intra-coronary imaging modality. OCT is more sensitive. And if this is abnormal, this may be abnormal in nearly 1/3 of the cases, where it can help us rule out plaque rupture, plaque erosion, spontaneous coronary artery dissection. If this is normal, best to proceed with a cardiac MR. The CMR itself, again, between these two modalities, we can make 2/3 or nearly 70% of the diagnosis. The thing with cardiac MR is that its sensitivity decreases as time proceeds. So it's best to do a cardiac MR in the first 2 weeks or as early as possible. It will help us to differentiate whether it's an ischemic etiology or a non-ischemic etiology. In case this is non-ischemic, we proceed, go ahead with proceed to diagnose myocarditis. And if there is ischemia, we should proceed with a physiological assessment. That is, rule out coronary artery spasm or microvascular disease. If this assessment of the physiological assessment is normal, proceed and rule out any source of cardiac cause of embolism, that is a transesophageal echo or a Holter monitoring to rule out any rhythm abnormalities. This is a study which showed the yield of cardiac MR in Minoka and showed that it could diagnose, or myocarditis was responsible for Minoka in cardiac MR study for 1/3 of the cases. 1/3 were inconclusive. These are the findings, OCT findings, which can be picked up in Minoka. That is, the first A and B show a typical coronary artery dissection in the position from 6 to 8. Then C shows an intact endothelium with a white thrombus. D is a classical plaque rupture. G and H show the calcific nodule which has ruptured. And E shows a TICFA, that is a thin endothelium which has a thickness of nearly less than 65 microns. Coming to the typical patient presenting with Minoka, these are usually in a younger age group compared to the coronary artery disease age group. The age is, it's usually in the 5th decade. Various studies have shown 52 to 54 or 58. Women, the percentage can women can be represented in nearly 40% of the cases. Hyperlipidemia and the traditional risk factors are lower. Though hypertension and smoking, there was no significant difference in these two age risk factors. So the causes of Minoka, it will be coronary, myocardial, or non-cardiac disorders. Coming to the coronary plaque disorders, that is two independent studies. The yield was nearly 40% in patients of Minoka. OCT is more sensitive, while IVUS is less. Plaque rupture and plaque erosion can be diagnosed. And it seems that with the limits of coronary angiography, that being a typical luminogram, we have to proceed with OCT and IVUS in these patients. This is again intravascular ultrasound showing a typical rupture. Coming to the treatment, so the treatment is very specific. Hence, the diagnosis, coming to a specific diagnosis in Minoka is very useful in treating these patients. If there's a plaque rupture or disorder, we go ahead with a dual antiplatelet therapy and it is recommended for 1 year, followed by a lifetime of single antiplatelet therapy. Also, statin needs to be added because of the underlying diagnosis of plaque rupture. Spontaneous coronary artery dissection is more commonly seen in the younger age group. Females, associated fibromuscular dysplasia may be found. Pregnancy and peripartum periods are the more vulnerable periods. It may, however, also be seen in patients with connective tissue disorders like Marfan's and Ehlers-Danlos syndrome. Conventional risk factors are usually absent. Hence, once we have, this can be diagnosed by a coronary angiogram is diagnostic, and the prognosis is usually excellent, though the recurrence rate can be as high as 27% in the following 5 years. Hence, they should be treated aggressively. And treatment, which is the classic cornerstone of this SCAD, is beta blockers in single antiplatelet therapy. This is spontaneous coronary artery dissection, often seen by us in the cath lab. Coronary artery spasm is the third diagnosis. And this is once the OCT and the CMR are normal, we should strongly consider the patient having coronary artery spasm, usually a nocturnal variation or rest angina responding to nitrates is a pointer in the history. And the vascular smooth muscular reactive, it can be present in nearly 28% of the patients, and it should be diagnosed because the treatment is very effective and is found to reduce long-term mortality. Hence, the coronary vasomotion disorder, this international study group has founded 3 core elements, namely nitrate responsive angina, transient ischemic ECG changes during the episode of angina, and angiographic evidence of coronary artery spasm. While doing the diagnostic test of intracoronary ergonovine and acetylcholine. So acetylcholine, about 200 micrograms, can be safely given in the left coronary tree, about 50 to 100 in the right coronary tree. It is safe and can be given in a patient who also comes during the acute in the first 24 to 48 hours. The treatment for this is specific, that is calcium channel blockers are very specific and are found to decrease mortality in the long term in the follow-up.
It's 5 o'clock.
In the case of refractory symptoms, Fasudil and denopamine have been tested in Japan in certain small sample sizes. Coronary microvascular dysfunction can be a diagnosis usually of exclusion, but the symptoms are classical of myocardial ischemia with objective evidence of myocardial ischemia, which can be demonstrated by PET scan or by CMR, absence of obstructive CAD, and confirmation of coronary blood flow reserve, which is usually difficult, and it may be a diagnosis of exclusion once we have excluded the first 3 diagnostic diagnostic tests in Minoka. Previous studies have reported excellent results. Angina seems to be persistent, and the response may not be so satisfactory, and the patient may keep coming back even on calcium antagonists. Fasudil is the drug which is being studied for this. Myocarditis is an inflammatory disease of the cardiac muscle, which has it can be, we know the classical cases of myocarditis, which can be infectious or non-infectious. And in this age, it has also been classically found with COVID. The clinical presentation of acute myocarditis can be very variable, from fatigue, chest pain to cardiogenic shock. Myocarditis in Minoka is common with a mean prevalence of 33%. CMR can be useful in making the diagnosis of myocarditis, and it is very useful in differentiating it from ischemic causes, though endomyocardial biopsy is the gold standard. Timing of these, again, investigations, as I had said before, should be early, as the sensitivity decreases with time, especially in cases of acute myocarditis.
Dr. Bhanu, since we are running short on, Dr. Bhanu, may I request you to just conclude, because we're running short on time, and if you could just conclude your concluding slide, just do your concluding slide.
Okay. So conventional treatment of myocarditis is ACE inhibitors. Then type 2 MI, it is the supply and demand mismatch which should be corrected. Coming to this concluding slide, coronary artery disease, intravascular imaging. The treatment is dependent antiplatelet therapy, ACE inhibitors, beta blockers, dissection, conservative treatment, beta blockers and single antiplatelet therapy. Coronary artery spasm, again calcium antagonists, Rho kinase inhibitors, microvascular spasm, calcium channel blockers, Takotsubo's coronary embolism, transcatheter device closure, antiplatelet therapy and anticoagulation. Then myocardial infarction depending upon the cause of the oxygen supply demand mismatch, if it can be treated with aspirin and statins. Prognosis can be same as MI and coronary artery disease. It can have similar or worse outcomes. As in the Sweetheart registry, mortality was as high as 14%. This is the last slide, which shows that we have to have a personalized diagnostic approach in this disorder, LV angio, OCT, intra-coronary trans, and therefore a tailored pharmacological approach is required. And by my talk, I would like to highlight that these patients should not be ignored and we must proceed because, as was shown in the Sweetheart registry, that the mortality in certain cases can be as high as patients of MI coronary artery disease. Thank you.
So great, Bhanu, you very well summarized the entire landscape of Minoka, and we are running short of time. I can see Nitish is quite distressed. So let's move on to the next talk. If there are any discussions, I think we'll do it at the end of the talks because of the session, if there is time permitting. Otherwise, great talk.
Thank you. I can see other speakers waiting, so I would.
Yeah.
Dr. Pranav, can you put up your slides, please? Can you please share your slides?
Yeah, sir. I'm just do that. Just a moment.
I would request all the subsequent speakers to get their slides on their desktops so that it's ready. Yeah. Over to Pranav Jyoti.
Are the slides visible, sir?
Yes, Pranav. Let's go ahead.
Yeah. Thank you, sir. Thank you so much. Thank you for the opportunity to the organizers, especially Professor Nitish Naik and Professor Rakesh Yadav, for this opportunity to present in front of this illustrious gathering this evening. And so STEMI in young, a very important topic. It is among the leading causes of morbidity and mortality. And the Framingham Heart Study's 10-year follow-up data that showed incidence of MI was 12.9, 38, and 71 per 1,000 in male, and 2.2, 5.2, and 13 per 1,000 in the age groups, similar age groups. But coming to the Indian population, the prevalence of STEMI in young Indians is distressingly high. It is almost 11.7% in the Indian group. And even more distressing is the fact that MI occurs a decade earlier in Asian Indians. And the median age of having an MI is 52 years in South Asians versus 62 years in those of European origin. And the CREATE registry, the mean age of presentation with an ACS was 57 years. And gender differences are very prominent. Male preponderance has been demonstrated by almost all these studies that have been done on young MI subset of patients. Possibly female hormones which delay initiation and progression of CAD may play a role. And although female prevalence is low, but the mortality and the outcomes are worse compared to the male counterparts. So the plaque-based mechanisms dominate as the etiology for myocardial infarction in young individuals. Only 10 to 11% of patients have a non-plaque etiology, some of which has already been discussed. And among the plaque-based mechanisms, an intact fibrous cap, or the IFC, or plaque erosion, should be considered, especially in the younger women who are smokers. OCT-based study where plaque erosion was found to be a predictable clinical entity in patients with ST elevation myocardial infarction, especially those females less than 50 years and who were smokers. And interestingly, the lesions were found to be in the proximal LAD and near a bifurcation segment. Coming to the clinical presentation, which is also found to be different in the young patients. These patients usually present with a fully evolved myocardial infarction without any history of antecedent angina. The higher incidence of STEMI in Indian population has been found in many studies, similar studies performed in this age group. And most of these patients belong to lower middle and the lower socioeconomic status. And coming to the risk factor profile, the Inter-Heart South Asian study identified 8 coronary risk factors, and these accounted for almost 90% of all cases of acute MI in Indians. And further scrutiny of the Inter-Heart study revealed that Indians who developed STEMI had lower LDL cholesterol levels than others in this study. They also had lower HDL cholesterol. And ApoB by ApoA1 showed the strongest association with the risk of acute MI in Indians. And this shows that Indians deserve a separate consensus in the management of acute coronary syndrome, as there are many unknown factors at play. And compared with the older counterparts, the younger patients tended to have a lower prevalence of hypertension and diabetes. And smoking was the most common risk factor, and its use was significantly more in young MI patients than in older patients. And there were also sex-based differences in the younger patients. Young females were more diabetic and hypertensive compared with their male counterparts. And in contrast, smoking was more commonly seen in young males. And in another comparative study between the Asian Indians and the American versus the American physicians, despite low incidence of conventional risk factors, the prevalence of CAD in the Asian physicians were 4 times higher. And in the CAD in the CADI study, except for diabetes, prevalence of all other conventional risk factors were lower. And this Asian-Indian paradox suggests possible important role of genetic factors not amenable to even maximum modification of lifestyle. And other important risk factors like family history of premature coronary artery disease in first-degree relatives, association of lipoprotein little a, hyperhomocystinemia, insulin resistance, abdominal obesity have been well described. And there are certain genetic studies which are conducted linking candidate gene polymorphisms to strong family history of CAD. And now coming to the angiographic characteristics of the young patients, they had frequently presented with single vessel disease compared with the older population. And the LAD was the most commonly involved artery. And multi-vessel disease like double vessel or triple vessel disease and left main involvement were less compared to the older counterparts. And thrombus burden were not different between the younger and the older groups in this particular study. And the data from the thrombolytic group who were transferred for cardiac catheterization showed better post-fibrinolytic telemetry flow in the young patients. Also, other interesting angiographic findings in the younger age group were non-obstructive CAD, normal coronaries, and SCAD and Minoka coronary ectasia. So all these were also important findings in the young age group. Now coming to the clinical outcomes, outcome data have shown that younger MI patients had reduced mortality both in hospital and at 1 year. And younger male STEMI patients also showed lower mortality than younger female patients. As coming to the management, as time is muscle, early reperfusion is the key in managing young STEMI patients. STEMI management in India need to adopt the dual strategy of combining primary PCI with pharmacoinvasive reperfusion and develop a framework for a system of care. And primary PCI may be employed for patients located close to the cath lab. Such option would be available mostly for patients in urban areas with presumed short transportation time to the hospital equipped with 24/7 primary PCI capabilities. Patients in rural areas with long transportation time to PCI capable hospitals would utilize the pharmacoinvasive strategy with thrombolysis therapy followed by cardiac catheterization and PCI as indicated within 3 to 24 hours of thrombolysis. And the architecture of this system is based on a hub and spoke model with each unit being called a Stemi cluster. The hub and the spoke model, this demonstrated that by linking several small peripheral spoke hospitals with a centrally located PCI capable hub hospital, the use and timelines of reperfusion therapy could be improved. And the concept of spoken hub, which is based on the distance of the place from where the patient is communicating and the commuting and the location of the primary, secondary or tertiary care centers. But since the whole concept revolved around few locations in India, which were having advantages in terms of logistics and infrastructure, there have been challenges in its universal application in our diversified country. The factors which were associated with delayed presentation and mostly the patient attitude who do not consider symptoms to be serious, then other factors like lack of equipment, proper first-line medication, living far away from the hospitals, lack of suitable transportation. And another important thing is a misinterpretation of the nature of the pain. And finally, lack of infrastructure, like lack of coronary care units, cath labs. And control of epidemic of CAD in young Indian population needs multi-pronged preventive measures through primordial, primary, and secondary prevention. And to sum up, the prevalence of STEMI in young Indians is strikingly high compared to the Western population. And it appears to be a unique entity with different clinical, epidemiological risk factors and geographic characteristics and outcomes compared to older patients. And early reperfusion should be the approach, adopting the dual strategy of combining primary PCI with pharmacoinvasive reperfusion. Outcome is favorable in young STEMI patients, particularly in patients who had received timely reperfusion therapy. Smoking and tobacco consumption is a major risk factor in this population, where less severe form of disease, mostly single vessel disease, is predominant. However, prevention of other modifiable, conventional, as well as non-conventional risk factors need to be addressed. And the lack of awareness regarding timely treatment of STEMI is an area of concern that also needs to be addressed. And adequate measures for infrastructure development need to be undertaken. Thank you, sir. Thank you.
Thanks, Dr. Bhattacharya, for your excellent speech. Very nice points, very nicely spoken. And just one question that you mentioned about little lipoprotein A, but we find that in many patients, even if little lipoprotein A is very high, it is not causing the disease, but sometimes it causes. So any particular message apart from little lipoprotein A, along with increased little lipoprotein A, presence of something else is obnoxious, like one is high cholesterol, of course, high lipids. Apart from that,
it may be a combination of many risk factors, sir. So it is difficult to really pinpoint one certain risk factor as the culprit.
Only
factor.
to tell that there is a recent big publication where they have pointed out that little lipoprotein A is of no concern if the highly sensitive CRP is at normal level. Only it becomes incremental if the highly sensitive CRP is very high. And another thing, you know, many of these patients, the coronary artery obstruction, like Minoka Vanu has shown nicely. Recently, Greg came to our NIC meeting and he was telling that with near spectroscopy, they have found that 20-30% lesions, they also produce large infarcts. And the outcome is much worse with medical treatment, all sorts of drug given high dosage, statins and everything, dual antiplatelet agents. The event rate is 10.4% at 1 year against 4%. He has mentioned about putting a BVS, I think stenting. Any comments about that? Nitish, I would also ask Anil and Nitish your opinion regarding this finding by CRF under the leadership of Greg.
So we've always known that 20-30% plaques can be vulnerable because they're metabolically active. And we also know that because in this case, there is no preconditioning and there is There are no collaterals. The MIs are usually there in proximal coronaries. They are much larger. So this is just a validation of the same vulnerable plaque hypothesis. I mean, many years ago, there was an editorial which said picking the plaques which pop. And I think that is pretty relevant because science has still not been able to pick appropriately the plaques which pop. And as far as lipoprotein small a is concerned, your point is well taken. However, I would just like to add that lipoprotein small a is a risk amplifier, and by and large amplifies what LDL is doing. However, we also know that all subclasses of LDL are not really as bad as it is made out to be. So the small dense lipoprotein and the oxidized LDL is probably more relevant. As far as inflammation is concerned, the data is so heterogeneous that depends on who has produced the data. There would be a lot of room for play on HSCRP. It is many factors which can influence it. If it has been assessed nephelometrically or otherwise, it makes a lot of difference. So and also all the lipid lowering agents are anti-inflammatory by themselves. So I don't really think that we're making out a case for an aggressive anti-inflammatory strategy, either by way of canakinumab or any other drug. There was a publication which actually assessed the role of tocilizumab. So that
no, Anil, you know, high intensity statins.
So,
we had a
so I think
publication.
Nitish
I would just like
telling
I
me
would
that
just
we
like
have
to
to move
interject.
on. Yeah.
I would just like to interject. I think so, since we are really running short on time, because we will take some of these.
Yeah, sure, Nitish, go on, please. Yeah.
Yeah. So I'll just request Dr. Jabir, who's the last.
Jabir is going to say something very, very interesting because this is something, especially when we are dealing with the dengue endemic dengue. So we are going to deal with patients who've got thrombocytopenia, and Jabir will show us the way. Jabir, we can see your slides.
Yes. Yeah, right. And I'm audible also.
Yes, absolutely. Loud and clear, as always.
So as Dr. Anil was pointing out, this is an important topic or a quite interesting topic, STEMI with a thrombocytopenia. So there's a patient who presented 2 months ago to us, 54 years old male with rest angina of 4 hours duration, hemodynamically stable admission. He was diabetic and hypertensive, no previous CV and no previous major bleeds. I don't know whether the electrocardiogram is clear. It was an inferior myocardial infarction and his platelet count 73,000 cells per cubic millimeter. And one of the most important problem, the platelet count comes once after the management of STEMI in most of the cases, because we don't wait for a platelet count to come. That's a separate issue. So thrombocytopenia, which is defined as a count of less than 150,000 per ml. And a mild one, if it is between 100 to 150,000, if it is between 50 to 100,000, it is moderate. Severe if it is less than 50,000. And some of the people consider it as profound thrombocytopenia of another magnitude that is less than 30,000. So this data, they looked at more than 67 lakh patients with a primary diagnosed acute myocardial infarction and looked for the thrombocytopenia. They found an incidence of 3.3%. And they found the PCI was less. This was between 2004 to 2014. We were not much aggressive at that time. After a multivariable adjustment, this thrombocytopenia was independently associated with nearly twofold increase odds of in-hospital mortality. And there was an independent association with ischemic stroke, cardiogenic shock, cardiac arrest, and bleeding complications. From the study of Horizon's AMI, they looked at thrombocytopenia, and I would like to remind you, all the studies, significant thrombocytopenia was an exclusion criteria. So all these are predominantly mild or moderate thrombocytopenia, mostly between 1 lakh and 150,000. But this mild thrombocytopenia of less than 150,000 that connected to death, statistically significant association with mortality, MACE, and major bleed. And baseline platelet count of less than 150,000 was an independent predictor of morbidity and mortality, and thus the 30-day MACE rate. This was published in 2018. It was actually ACC 2018, a poster presentation. They looked at the thrombocytopenia and the control group in those patients who had undergone primary angioplasty for ST elevation MI. Death, major bleeding, readmission, length of stay, and median total hospitalization. everything were high in those patients. Sorry for the trouble. So the presence of thrombocytopenia with STEMI who are undergoing primary PCI, higher mortality, major bleeding, increased readmission, increased length of hospital stay, and high hospitalization cost. And what is the impact of thrombocytopenia on in-hospital outcomes after a PCI? Higher vascular complications, acute ischemic cerebrovascular event, acute hemorrhagic cerebrovascular events, cardiac tamponade, and of course mortality. And those patients who have received platelet transfusion, they also had a higher mortality. And low platelet count of less than 1 lakh, that is a major criteria. One major criteria is sufficient to define a high bleeding risk by the ARC consortium. So HB a high bleeding risk status if the patient has a platelet count of more than 1. So these are the things that we have to consider. Thrombocytopenic patient presenting with STEMI, or a STEMI patient who develops thrombocytopenia during the hospital stay. So we are more worried about the patient with STEMI who presents with a thrombocytopenia, the drugs to be used. So the questions, is it really a thrombocytopenia? What is the bleeding risk? What should be the revascularization strategy? What should be the antiplatelet strategy? Can we use a glycoprotein 2B3A receptor antagonist? Should we correct the platelet levels? First, if you are seeing the thrombocytopenia for the first time, unless there is a history of thrombocytopenia or a non-case of autoimmune thrombocytopenia coming with STEMI, we may think when the platelet count is low, how can STEMI occur? Reports up to 5,000 platelets they can, because platelets may be functionally abnormal. This is platelet autoantibodies to the epitopes which is exposed by EDTA. In that case, always recheck it with the citrate as the anticoagulant and repeat the count and look at the peripheral smear whether there are clumped platelets. Thrombolysis, one word about thrombolysis. It is better or prudent not to use thrombolytic therapy if the platelet count is less than 50,000 per ml. And the most important things we require are the strategies to minimize bleeding risk in acute coronary syndrome patients with thrombocytopenia. Avoid NSAIDs, utilize a proton pump inhibitor unless contraindicated. Always prefer a radial approach. The newer generation stents, which can be used in the high bleeding risk population where you can have a low, small duration of the DAP therapy, short duration of the DAP. Restrict the DAP to 1 month post-stent. Avoid GP2B3A antagonists. Aspirin should be used in the low dose and triple therapy should be avoided. And of course, use an imaging and a precision PCI so that even if you cut off the dual antiplatelet therapy quite early, the patient should not develop a stent thrombosis. Antiplatelet strategy. This is one situation where I prefer clopidogrel. We had the first of clopidogrel versus the newer antiplatelets. This is one situation where clopidogrel is preferred and it's the safest strategy. No data on ticagrelor or prasugrel and may be avoided. Unfractionated heparin preferred, or bevuloridine, which may be the safest anticoagulant, but of course we have the problem of availability. As far as possible, glycoprotein 2B3A receptor antagonist to be avoided. So an acute coronary syndrome patient presenting with a thrombocytopenia of less than 1 lakh, platelet count, identify and correct a reversible cause. If the platelet count is less than 50, or if there is an active bleeding, no antiplatelet agents, avoid PCI. If it is more than 50,000, it is relatively safe. So go in for a percutaneous coronary intervention. DAPT, aspirin and clopidogrel for 1 month, followed by clopidogrel for next 1 year. Proton pump inhibitor should be given as mandatory. If no PCI, clopidogrel monotherapy and proton pump inhibition. And many of the people believe that, and we also, most of us believe that 30,000 is a sufficient cutoff. We can go for a PCI if the platelet count is more than 30,000. This algorithm I took from Deepak Bhatt, who presented it in 2017. What is the role of platelet transfusion? Patients with a platelet count above 50,000 may not require platelet transfusion. Those with the established ITP and platelet count below 30,000 or who come with active bleeding, he may be given a platelet transfusion to keep the platelet count above 50,000. Platelet count below 10,000 is really an indication for prophylactic platelet transfusion. And you may have to give 6 units, that is somewhere around 300 ml, to raise the platelet above 30,000 per ml. So what did I do with our patient, which I saw? We did angioplasty, put on aspirin and clopidogrel, he's doing well. So the take-home message, thrombocytopenia increases mortality and morbidity, and also the bleeding risk in STEMI. Bleeding issues are proportional to the severity of thrombocytopenia. Platelet count above 50,000 can be managed with standard STEMI care. Aspirin, clopidogrel, unfractionated heparin, and beviloridine are preferred agents. Short DAPT is preferred, 1 month DAPT followed by SAP, which is clopidogrel. Precision PCI is a key factor. This is the situation where you should use the imaging, do a precision PCI so that antiplatelets, dual antiplatelet can be cut off at the earliest point. Better to avoid primary PCI in those with a platelet count below 30,000 and avoid thrombolytic therapy in those with platelet count less than 50,000. Thank you so much for your patient listening.
Thank you,
Thank you,
Jabir, for a really fantastic
talk.
presentation. So I think so in the interest of time, we will not be able to take any questions. I'm sure there'll be lots of questions to Jabir, but this is a very practical problem. But I think so we'll take them offline. I'm sure Jabir would be available to answer any questions that can be there on the chats. But we'll move on to the next session, which is my best bailout case during primary PCI, the master's technique. And we have 4 very eminent masters today, Dr. Praveen Chandra, Dr. Dhiman Kali, Dr. N.V. Reddy, and Dr. Vijay Trehan. And to take us through the steps, we have our chairpersons, Dr. Bhuvan Tiwari, Gautam Sharma, Dr. H.K. Bali, Dr. Kirti Punamia, Dr. Raja Bala, Dr. Sunil Modi, and Dr. Sandeep Mishra. So may I request Dr. H.K. Bali to set the ball rolling with the next present. And I request Dr. Praveen Chandra to put up his slides.
Yeah, sit down.
Hello, can you hear me?
Yes, we can hear you, sir.
Okay, fine. So thank you very much for this opportunity, Dr. Naik, Dr. Yadav. And I can see that this meeting is really very, very educative. And I went through some presentations earlier and very nice comments by Dr. Dhal and Dr. Kahali. So with this, we move to this actual real cases, and I'm going to show you 2 cases which we did very recently. One is for the left main and one is for the vein grafts. So, this is a patient who is a 60-year-old patient who came with actually initially acute coronary syndrome. His angiogram was done elsewhere and he was shifted to us for a surgery. So, and his echo and everything was reasonably stable, but, he was having recurrent chest pains. And when we, if you look at the angiogram, this was the angiogram which he came with. And, but he became little unstable. His ST started getting elevated. So we immediately moved him to the cath lab while he was waiting for surgery. And then the wire was, as soon as the wire was inserted, his flow was completely stopped. His BP came to 30 systolic, 40 systolic, and that was the time of severe crisis. So when this happened, now the question was what to do in this situation, whether to quickly put a stent or try to put some more wires, because there were so many branches coming out, and there were multiple branches actually coming out from this distal left main. So we decided that we have to immediately restore some flow, and unless until we do that, it will be very difficult to actually make him survive. So we immediately, rather than putting balloon pump or any other hemodynamic support devices, the decision was made to immediately put a stent so that the flow is restored, and maybe that will be probably a way to go. So with this, we immediately took a stent, which was from the left main going into the LAD. And as soon as we inflated the stent, and as soon as you put the stent, actually the flow had initiated a little bit, and then we inflated the stent, and as you can see here, that the flow has restarted and the blood pressure started coming up. The patient was immediately stable, and then of course we thought that let us post dilated in the proximal part, make it about 4 millimeter or something, because this was a 3 millimeter stent and this is a 4 millimeter balloon. With this, we were able to get a good supply into the LAD. But the problem was not over. And as you can see, all the branches got occluded. The circumflex, the ramus, the diagonal, everything got occluded. So now the question was whether to leave it alone or to do something. Actually, we have to do something because there are so many branches, he will not do so well. And as it was progressing, as you can see, that the flow was really very bad in all these branches. The entire lateral area is completely without any myocardial supply. So we, and you can see that, at some point in time, the patient also had a very low BP. So we did there was some massage happening at that time, but overall the patient was stable after that. And then we took a wire which was taken into the ramus, and we did a kissing balloon inflation followed by a stent, because this vessel was not looking too good after the kissing inflation. So we put a stent into this large diagonal or ramus, whatever you call it. And after that, we were quite satisfied with the flow into the diagonal. And then we said, okay, we'll have to now go into the circumflex. So the same wire, which is a Fielder XT wire, was taken back from the diagonal, and then it was taken into the circumflex, and with some difficulty, although it was a 90-degree, and we were not able to see the actual point of where we have to go, but still we were able to actually put the wire. And once the wire was there, you can see that there was a large chunk of thrombus which had moved inside. So we dilated this with a 2 millimeter balloon, and then once that was done, we immediately decided that we'll have to put a stent here because it's a big vessel and the flow was like not so great, and we cannot leave it with just balloon alone. So at this stage, you can see we are trying to put a stent, and this is the third stent we are putting from the left main into the circumflex with a balloon in the left main to LED segment, so that we will do a kissing inflation after that. So once the stent was in position, we started doing the inflation into the LED and to the circumflex, and this is the final shot after we did the the proximal optimization of the first stent. We were able to get a good result, and you can see all the branches are now flowing very nicely. Patient became stable. There was no need to put an intra-aortic balloon pump or anything in for hemodynamic support. So that was one case. And the second interesting one is again very recently done. He's a post-bypass patient. 2005 bypass was done, and then he came a week back with an inferior wall MI, chest pain, uneasiness, swelling. And then when he was brought to the cath lab immediately for a primary angioplasty, you can see that this is the left coronary angiogram. The vein graft to OM is fine, and the vein graft to the RCA is completely blocked off in the middle. Now the question was whether we should do anything or try to just leave it behind. So since it is acute MI situation, had it been a stable angina, I don't think anybody will go ahead and do anything about this, but it's acute MI. And we said, okay, we'll have to try and see how much we can salvage this artery. So we immediately put a wire, and you can see this is with the guiding catheter. There is no flow beyond, so we don't know how long the stent will be, but as soon as we put the wire, we put the balloon, just daughtering the balloon, we looked at the flow, and the flow had restarted. And also at this stage, we wanted to know how long the stent has to be. And so at this, and also to see whether we can put a distal protection device. So we saw that, there is some, thrombus which is already down below, and there is, a lesion here. So we said, okay, there's no point taking a distal protection now. So we decided to put a stent based on this finding, which we had taken by the injection while the balloon was inside. So the proximal stent was done. And as soon as the proximal stent was done, the patient developed VTVF. And during the course, he had to be shocked at least 9 times. So you can see that, this artery is looking all right, but beyond this, it is still occluded. However, we gave 2B3A and everything else. And soon after that, and also did some, daughtering of this balloon, and also did a thrombosuction. So you can see a thrombosuction is being done. So once it was done, we started getting some flow down below, and with this and some nitroglycerin and diltiazem, etc., the flow started improving, and you can see that the arteries are really opened up very well. The distal thrombus is all gone, and the flow is quite nice actually. So we didn't do too much of ballooning over there because we thought that if we disrupt the thrombus too much, it will really go deep into the circulation. So there was some residual thrombus here. So at this stage, we decided that we will do nothing. We'll leave it like this and see how it progresses with 2B, 3A and dual antiplatelet, etc. So the check angiogram was done after a few days to see whether we still need to put a stent. And we found that the flow is quite good. And it is Stemi 3 and there is nothing much left here. So we left this patient alone and this patient did very well after this. So I think, to conclude, there are two things which we have to keep in mind, that in vein grafts, if we are doing primary PCI, we have to manage the thrombus very, on the basis of how it looks, where it is, and whether there is any distal embolization already which has happened. So in this patient, we didn't do any distal protection device or thrombosuction was done very mildly in the distal part. Identify the length of stent by simultaneous injections. And of course, adequate antiplatelets and lytics, if required, can also be given in some patients. And if there is a residual thrombus, it is better to be conservative, check it back if the flow is good. And for left main, I think rapid restoration of flow is the key to success. Open jail our side branches, and if required, put stents. And of course, if we do everything quickly and maintain flow fast, it will be easy to avoid an intra-aortic balloon pump or impella in these patients. So I think, with this, these are the two interesting cases that I wanted to share. Thank you very much.
Great cases, Parveen, both of them. And Anil, would you like to make some comments on this?
No. Praveen has done a remarkable save. The only one thing, food for thought, that I may like to say is that I'm very scared of vein graft primary PCI, and I actually look at the native before I, just because we know that these kind of things can happen with distal embolization. A lot of VTVF, hemodynamic collapse can happen. So look at the native. It may behave like a CTO, but it may not have so much of embolizable burden.
Dr. Parveen, before we go further, 2 points. That we are getting some new treatment options for large thrombi in coronaries, and including veins. One is Catrax 4, which is coming along, and where you can actually take out the clot, and there is initial data to show that would be good, which may be useful in venous thrombosis. And the other is what we call as a JAG marination, that you take a 7 French guide liner, put it right close to the thrombus. Distally, obviously, we're thinking of where the wire can cross the lesion, and distally occlude the vessel with a large balloon at low pressure and inject TPA about 5 milligrams, or some people have tried 10 milligrams of that, what we call as a JAG marination. Wait for 4 to 5 minutes and you find very good results. So what are your thoughts on these two new technologies which are coming along? I have found JAG marination to be useful. The Catrax 4 is obviously new, and we would have.
See, the marinade we've been using, sir. We've been using the marinade without going into what has been described as the JAG marinade right now. We've been using something like that. If you remember,
idea is you occlude both the sides. With the guide liner, you occlude the proximal side, so there is no spillover of the TPA and the thrombolytic, whatever thrombolytic agent you use. And so this you are occluding the balloon. This is local marination.
So, this is a very important aspect which Dr. Bali has alluded to, that in vein grafts, sometimes it is very difficult to know where exactly you have to end the stent, what is the site. So that is why I was taking this first shot I take always without dilating it, with just a daughtering effect, which actually minimizes the thrombus to move distally. And then you can know where exactly is the lesion, how much the length of the stent is. Because many times what happens is, if you do a pre-dilatation, suddenly there is a slow flow. And then you don't know where you have to end the stent. So that is one thing. The second, which we have been doing, Dr. Dhal may be remembering, for many years, we actually punctured the balloon when you want to really quickly do it. So with the pre-dilatation balloon, you puncture it with a blade or needle or whatever, take the balloon deep inside and start injecting and keep pulling the balloon. And you will know exactly where, what is the length of the lesion, what is the, the vessel distally, and also you will know that whether the vessel is big or small, because sometimes you don't even know how big is the vessel distally. So I think those are the steps which we have to take. So
Yeah,
thank you very much for
but
your comment.
Dr. Wali's point with the penumbra cat RX being available, it's an expensive modality, but yes, the thromboaspiration, which it will do, will be far more efficient than whatever we have been doing till now. But the simple point which I was trying to make was that in occluded vein grafts, we are likely to have embolizable material. And this is one place where you can try and see if you can choose to go with the native, because that is likely to behave like a CTO and more controlled situation. However, if you have to deal with the vein graft, then all these tricks come into play.
Dr. Praveen, how was the RCA, native RCA in that patient?
Yeah, as you saw, I showed you the angiogram. The native RCA was completely blocked off from the beginning. It was a long, and so there was no point in actually tackling the the CTO of the RCA, which would have taken 3 hours, and by the time the patient would have an infarcted RCA territory. So that is what I wanted to highlight. That if it was a chronic stable angina situation, I would have said, do not touch this vein graft. But in acute MI situations, many times I have seen that the thrombus is not that much. You are able to get a good flow distally. And as you saw this, that we've got such a good flow. And there was no slow flow compared to many times when we do interventions, we get bad slow flow.
Yeah.
I think we can move on to the next case, and that is being presented by Dr. Reddy. And may I request Dr. Reddy to put up his slides, please.
Can you see my slides, sir?
We can see your slides. If you can just put them in presentation mode.
Good evening, respected chairpersons and moderators. This is a patient, is a 51-year-old male who was on chemotherapy for a seminoma testis, was in the hospital and was received 3 cycles of chemotherapy, and is a known hypertensive, diabetic, and hypothyroidism on medication. On January, in the hospital, he had a chest discomfort associated with palpitations. Immediately, ECG was taken, and it showed that there is an atrial fibrillation with testis segment elevation in the inferior lead. And his routine investigations for hemoglobin was 11 grams, WBC count was normal, platelet counts also normal limits, and B and creatinine was within normal limits. And immediately he was loaded with the ticagrelor and ecosprin 75 milligrams, and decided to take him for an angiography. And since he was in the hospital, he decided to take him for a PCI. And the approach was right radial approach, and we used a 6-punch sheath and a 6-punch guide. After angiography, we have taken 6-punch guide. Tiger was used to do the angiography. This was his angiography, and left system was normal, and on the right coronary angiography shows there is a thrombotic lesion in the right coronary angiogram, which is in a dominant vessel, and we did a thrombosuction, and after thrombosuction, then we decided to use a stent directly, and the stent was used about Directly, we used a stent 4 into 30 mm stent was used nowadays, and everything was fine. Then you can see that the result was very good. We thought that everything is fine. Then we shifted into the ward. And this is a post and final result in both LAO and RAO was good. There is no distal dissection. Stent is well expanded. Then 4 hours later, I had a chest pain. Sorry. I think I'm painting this. Okay. 4 hours later, he had a chest pain associated with ECG changes. This was sorry. You can see that the same inferior wall, there is an ST elevation. And took for angiography again, immediately went into the lab since he was in hospital only. Then we saw that there is an proximal artery is totally occluded again. Again, we have done a thrombosection. Thrombosection was done and we removed a certain thrombus particles also. And then decided to give an intra-coronary lysis. Repeated thrombosection was done. We noticed that there is some irregularity in the coronary. We thought it maybe thrombus must have spilled in, extended into the lumen. Then you get intra-coronary tenecteplase 5 milligrams and the GPA, the glycoprotein inhibitor also 5 ml was given, and decided to dilate the stent with using the since stent was 4 mm, then we used a 4.5 mm balloon, dilated entire stent, and everything went on well. There was again I established TIMI3 flow and shifted him to the ward again. Then after some time again he had a chest pain, and then this is a first this thing like TPA was introduced because in precautions. This is a final report at 6 p.m. on the same day. Again he had a chest pain associated with a complete heart block this time. Now again we are worried about what is happening. This again he is repeatedly getting this. Then we took him to the lab again. Again did angio. Angio shows the same site it was occluded. Same site it is. You can see the same site it is occluded again. And again same thing. Thrombosuction. Again using a tenecteplase intra-coronary and plus 5 milligram bolus dilation, and we used a balloon to dilate and continued GP2 infusion. And there was a thrombus in the distal to the stent also. Some of the thrombus is migrated into the PDA, and this was aspirated and it was settled. Then I took him for what is exactly is happening. I was not knowing, because in spite of using such a large stent and dilated with a 4.5 mm balloon, and the result was good, why is repeatedly getting thrombosis at the same site? And then I took him for then I had to know that what exactly I did an IVAS. Surprisingly, when IVAS I did, it shows that the vessel is more than 4 mm. It is almost 5 mm vessel. So there is a stent was malopposed to the vessel. That must be causing the repeated stent thrombosis. Then again I had to use a balloon to dilate, and I have to use a 5 mm stent. Since I know the vessel size in a 5 mm, then I use the 5 mm stents to cover the proximally as well as distally, and dilate within a 5.5 mm balloon. And then this is the final result. And after the end, I did an IVAS. IVAS shows that the stent is fully opposed to the wall, and this is a final result. This is a final result after using the 5 mm stent and dilating with the 5.5 mm balloon. And this is the final result. There is a small thrombus looks at the PDA origin, but the flow was very good, and they said to stop at this. The stent thrombosis, in this case, stent thrombosis, as you know, that high associated with high mortality and morbidity, often leading to cardiac events and sudden death. And immediate attention to restore the flow is very important, either a thrombus aspiration or angioplasty. And one need to check the compliance of the drugs, whether the drug is resistant. But in this case, we have given ticagrelor and ecosprin, though there is no chance of like it's not a clopidogrel suspecting the resistance. And more antiplatelet drugs should be continued in these cases, and then should be assessed what exactly is the cause for the repeated stent thrombosis. Usually imaging is very helpful. If I had not done imaging, I was not knowing that the coronary artery size was really large in this case. I would again keep on dilating with a 4.5 or 5 mm balloon. May not be succeeded in this case. So optimization of stent, the deployed stent is very important, and look for edge dissection or any other associated intramural thrombus. In addition, stent placement has to be very careful. As you know that the more the lengthier the stent, the thrombus formation is very high. With this, I'm going to stop my case, and thank you, sir.
Yeah, this.
Sir. Thank you, sir.
Yeah.
Yes, Dr. Modi.
And this case clearly shows the utility of imaging, the OCT, or if you have IVAS, then you can do IVAS, but probably OCT will be much better, imaging in these cases. So we had similar cases, didn't occlude the same day, but they occluded later. And so particularly in the primary angioplasties, you often end up with the suboptimal size stent, and because you don't know the distal vessel so accurately. I think these are typical examples of that imaging techniques are extremely helpful.
I mean, we have used the 4 mm stent on the dilator with the 4.5 mm. I think that was, we thought that that is a good size. But
that's exactly, I'm saying that you were very happy with 4, but then it showed 5 millimeters. So
5 millimeters.
that is why, what we feel that we have ended with the good results may not be good results just by the angiogram. And that is why I think some of these patients, the imaging is very, very useful, and it should be done if you have the. I just wanted to ask Dr. Praveen Chandra if he is here, or Dr. Bali. The previous case of Praveen Chandra, tells me that if you are doing an elective post-bypass intervention, in my own experience and in the experience of others, a good CT angio helps me a lot, in the knowing the vessels, distal vessels, which Praveen was saying that we don't know what is going on distal vessel, whether it is adequate size or not. But if you have a CT angio, then you can plan your strategies much, much better way, unless you are doing an emergency, intervention or primary intervention. If you are doing an elective intervention, then a prior CT angio is very helpful.
Yeah, intervention. Modi, the issue is that if you are intervening in a occluded SVG, the idea is only to intervene fast and open up that vessel as early as possible so that blood flow is.
No, I'm not talking of emergency interventions. I'm talking of an
elective procedure.
Elective intervention, which is often done in these post-bypass patients.
That could be useful. But coming back to Dr. Reddy's case, 2 points which I would like to ask.
Yes,
one is that, which Dr. Modi very rightly pointed out, that in acute MI, many times the right coronary particularly, we do underestimate the size of the vessel, and the vessel grows over a period of time. That is one. Second is that you used a 4 millimeter stent initially, and subsequently after OCT, you used a 5 millimeter stent. So the second stent which you used, where did you use that, and why did you use that 5 millimeter stent? Or was there a particular reason for it, or the previous stent which was 4 millimeter, you could have dilated that to 5 millimeter by OCT. So where did you use that 5 millimeter stent, and which was that what is the make of that 5 millimeter stent we are talking about?
I'm talking about the 1X I used. 1X stent I used in this case. Actually, I was showing more than 5 actually. It was 5, more than 5. I decided to, since 4 millimeter stretching it and distorting the stent, it may not be good, since I had a 5 mm stent 1X.
So where did you use it? You used inside the previous stent?
Yes, inside. No, I did not use for.
So may I request the chairperson? We are getting late. So
I use it proximally as well as distally. Almost 80% of this, so 60 to 70% of the stent has been covered proximally as well as distally, and dilated with the same 5.5 mm stent balloon as well as 5.5 mm balloon again.
So can we move to the next speaker, sir? We are running late up.
Okay, Dr. Yadav, please go ahead.
Thank you, sir. Thank you very much.
Kali, Dr. Dhiman Kali is very well here. Sir?
Thank you, Rakesh. I am here only. Yeah, I am here only.
Please. The technical team kindly assure. Yes, okay. You are audible and well visible, sir.
First of all, thank you, Rakesh and Nitish, for kindly asking me to speak on the occasion. They are my great friends. So today I'm going to show a patient with whom I have struggled for almost 90 minutes. And, The patient presented with an acute inferior wall MI at 24 hours. It was a late presentation. Many patients we get like that, but the patient was having ongoing chest pain, but he was out of the thrombolytic window. So lysis could not be done and patient taken for delayed primary PCI. Now, repeated episodes of slow flow and no flow as anticipated, despite adequate medication and repeated dosage of IC adenosine, IC nitro and means nitroprusside, and IV nicorandil many doses. I use 8-10 doses of nicorandil, and intralesional adenosine was also given several dosage. Even after balloon dilatation and IC FT5 2 bolus at 10 minutes interval given. Finally, of course, we could achieve TIMI3 flow established with good grade 3 blush with reconstitution of a super dominant RCA, but the course was very stormy. So this was the left side. We'll deal with the left side later on. We can see a proximal bifurcation lesion in the LAD large diagonal. This is the RCA, huge RCA, and I think it's 4.3, 4.4. So it's completely occluded, 24 hours done. So we put a WAN and then we dilated with a 1.5 balloon because I don't want to, don't like to rather dilate lesions in primary PCI. Just I would like to go for a direct stenting, taking a 0.5 more size, as we appreciated in the last case also, that this is also like that, a huge RCA, super dominant RCA. And so then we took because the flow was not there and we were not sure that whether putting a stent would do the job. So we took a bigger balloon, 3 millimeter balloon, because these are little organized clots. So to make them opposed to the vessel wall, and how otherwise there is downstreaming of the, this microthrombi. We dilated with a higher stent, because higher size balloon, because putting a stent at this stage would not have been, beneficial. So we did it, and in between we have given intralesional with a microcatheter, a few doses of adenosine 60 and nitro 1 or 2 doses, but that also did not improve the situation because he had got obstruction of the vessel and also solidified, thrombus, and which was not yielding. So we dilated and post-dilated to have some good flow, but as you can see, the flow was not at all commendable. So at this stage, we have almost exhausted giving adenosine 60, almost 25, 30 doses, not only intra-coronary, but intralesionally also with a few doses of nitro. And we have taken a 4 into 44 millimeter stent. And, we couldn't measure the actual size also, as Praveen was also discussing, because, it's a real problem for us, and then we took a stent which goes up to 4.4. We don't like to post-dilate also in such primary patients, as much as less dilatation with the balloon as much as possible, because we have already dilated with a 1.5 and 3 millimeter balloon, and used a lot of adenosine, nitroprusside, nicorandil 10-12 doses, IV. Of course, we don't give intra-coronary nicorandil because this is a second-line drug, but nothing was doing. So we dilated the stent at higher 16 atmospheric pressure. That takes it to 4.4, I think, 16, 17, 4.4, and but still we could not cover the full length because we would like to go for a 448 giants, but unfortunately it was not available. So we had to take this stent. So we find that a little bit of RCA is uncovered, but we are a little happy that at least we could establish TIMI3 flow with some good blush. So we took a smaller stent this time for 16 millimeter, again, covered the whole length, and dilated with overlapping of the previous stent we can see a small thrombus. We have already given some intracoronary 2 boluses of eptifibatide, and we have started infusion of eptifibatide as well. The ACT was quite good, 280 seconds. So with preconditioning with this DAPT, and this is the final result as we have shown. I think it's a super dominant RCA, but it's very easy. We have demonstrated in 4 or 5 minutes of time, but it took me 90 minutes of hard struggle to establish good flow in this vessel, and we cannot leave such a vessel, which is a super dominant one, and especially in a situation where the patient was showing dynamic ST elevation changes and the patient was complaining of severe chest pain even at 24 hours. So because the left artery cannot be held responsible for the chest pain, so it was RCA only. And the enzymes were already elevated, TROP-I was strongly positive, so we could establish flow. So if we go judiciously, we can establish flow even in such an artery. Now, as my friend was discussing, Praveen, that no reflow defined as stagnant contrast agent in the distal vasculature with our apparent without any apparent proximal obstruction. Incidence is 2% only with simple PTCA, 7% with rotablation, 12% in cases of primary PTCA, and like Praveen's case, 42% in degenerated saphenous vein graft. I need a comment by my good friend Ashok Sheth that we hate to do primary in vein grafts therefore. And it caused principally embolization of atheromatous aggravated by microembolization of platelet-rich thrombi that releases serotonin, leading intense arteriolar vasospasm in the distal vasculature. So differential diagnosis of no reflow or slow flow phenomenon is one dissection, acute thrombus formation in the proximal or distal segment, not always appreciated by conventional angiography, and intracoronary adenosine nitroprusside. Sometimes it doesn't work when 30 doses of adenosine intracoronary doesn't work. Before that, of course, after 7-8 doses, we go for intralesional application of adenosine and nitroprusside. And though clear way catheter is not available in our lab because of cost factor, we go through a microcatheter that does the job well. We sometimes give IC verapamil, nicardipine is again not available. And I go on giving repeated doses of intravenous nicorandil. Management of air embolism, if anything, strong hand injection of contrast may help to dissipate the air bubble to distal microcirculation. Also in resistance cases, no other than Antonio Colombo in his latest edition of Tips and Trips have told that you draw some 10-20 milliliter of blood through the syringe and then inject it forcefully, and that sometimes causes good flow. And he has also advocated as a last resort what they have been talking, Dr. Reddy and others, that even if you get also Praveen, that you give some 5 milligrams of incremental doses of 1080 place at regular intervals, say a few seconds, 30 seconds, 60 seconds, etc. Sometimes it helps in desperately bad cases. So we could establish flow. This is my second case, 100% occluded causing infero-posterior wall MI. Very simple case, 51-year-old male patient, just to see what retrograde, flow of the thrombus can do. Havocs, non-diabetic, hypertensive, heavy smoker, 40 to 60 per day, admitted to our hospital with no prior thrombolysis. Echo LVF 48%, 45%, akinetic infero-posterior wall. Direct stent PTCA performed uneventfully, but patient has a non-hemorrhagic stroke in the temporoparietal region after 1 hour. Though the procedure was done meticulously without any problem during the procedure, and primary PCI may have such unforeseen complications, even if done perfectly with IRA having TIMI3 flow. So this is the 100% occluded left circumflex artery, LAD is okay. And, left circumflex, see beautiful flow, we have established TIMI3 flow. Just I like to go for direct stenting because, though the term dot to balloon has come, but we hate to put balloon, even I don't go for tottering unless proved to have it. But this patient without any, problem during the angioplasty, had a temporoparietal infarct causing loss of speech, and the patient was few more days in the hospital. Then, of course, we could discharge him in some good shape. Prevention of complications caused by an aspiration device is always very important. No angiographic evidence of thrombus in the repeat diagnostic angiogram should be established. Correct way to manipulate an aspiration catheter. Use of an aspirating catheter involves flushing the aspiration lumen fully and then advancing it proximal to the lesion with the port lock. Once proximal to the lesion, the aspiration lumen should be exposed to negative suction and return of the blood should be verified before advancing across the lesion. And many authorities tell just to open the white channel connector for a few seconds before injecting the dye so that the retrograde embolization is prevented. Sometimes the retrograde emboli goes from proximal LAD to proximal circumflex. The patient immediately goes to cardiac arrest or cardiogenic shock. So we should always keep another wear in the other artery when we are dealing with a proximal thrombus and lesion. This is why manipulation of hardware in the IRA should be gentle and minimal to avoid dislodgement of the thrombus. Very important. The use of manual aspiration thrombectomy, which is easier to use and cheaper, is effective in reducing slow flow and increase the chances of normal flow at the end of the procedure. Though it has been downgraded by many authorities, but a recent MI, I think, in a large artery with large thrombus burden, manual aspiration has some effect. Export catheter is good, 0.04 inches in diameter, internal diameter, arterial catheter with 0.059 inches in diameter, and it is 3.2 times more effective than export catheter and 1.2 times more effective than Pronto catheter, Pronto 6 LP, which has an internal bore of 0.56 inches. During PCI or thrombectomy at the proximal segment of the LAD and LCX, sometimes fragments of large thrombi may be squeezed back and occlude the ostium of the adjacent vessel. Not only that, even the left main, or as it has done to the cerebral circulation, though very, very rarely. I got such a patient after, I think, 10 years, but it do happen. Fragments of thrombus can even adhere to balloons or the aspiration catheter, which when withdrawn or retracted into the guide may lead to embolization and occlusion of the non-IRA branches with havoc effects. A large non-infarcted vessel may have dramatic consequences, including immediate cardiac arrest and profound shock. If an ostial LAD or circumflex lesion is treated, it is reasonable to protect the adjacent vessel with a distal protection device not done in our country, or an additional wear to allow immediate. This is the case, 3 very interesting case, 36-year-old gentleman, and he had familial hypercholesterolemia, 365 total cholesterol, 275 LDL cholesterol, admitted with STEMI within 3 hours with severe ongoing chest pain, and the patient immediately after putting the wear was, just crying with chest pain. Very strong man, but he was crying virtually with severe chest pain. We gave morphine, this and that. And then we put 2 stents with bifurcation, with ballooning and then stenting. And this is the post-dilatation of both the stents, because we always dilate with the same balloon or a little oversized balloon, kissing balloon, you can tell. And this is the final result. The patient improved. So whenever we just dilated for 12-14 seconds, but still the patient was getting severely hypotensive, severely bradycardic, and we had to give atropine and everything possible on the heart. And the final result was very good. We put the patient on prasugrel and aspirin, and the patient has been doing well with evolocumab. But regarding V-stenting, delivery of simultaneous implant of 2 stents suitable for Medina class 011 lesion, equal-sized arteries, very proximal lesion of both coronary arteries, as it is this case, bifurcation angles less than 90 degrees between 2 branches, and 2 stents forming a new carina. So this is a very effective method in such desperate cases. This is the 4th case. We have been talking about spontaneous dissection. This is a nice case from a 42-year-old lady coming from a very good family, presented with acute inferior MI within 2 hours, non-diabetic hypertension. Yeah, I'm going to show this picture. This is one of the beautiful pictures, and I presented in the AHA meeting in November. And see the dissection right from the very proximal portion, I shouldn't tell ostium, And right from the proximal portion, it is extending up to the distal portion with apparent some narrowing of the vessel. We kept the patient on conservative therapy because wearing such a vessel is dangerous, and putting such a long stents, none other than Colombo tells that there is chances of fracture, there is chances of more instant restenosis and side branch compromise. So there was good blush, if we can note, even in this artery, and there has been a lot of discussion. I'm not going to detail it, just I would like to show the conservative management is favored in this patient, and you can see the film after 3 months. This is the after 3 months, you can see a beautiful artery, small amount of dissection here and there, but the flow is very good. Look at the blast, Stemi 3 blast. So I think it's excellent result. We put the patient on beta blockers and statins high dosage, and the patient, and also SAPT, not DAPT, as advocated by various trials, and the patient has been doing well. And this is a angiogram after 3 months. So the patient has been doing beautifully well. His ejection fraction improved from 35% to 55%. So now almost she is having a normal ventricle. And this is the left system, good. And I have a question to the faculty that is there any prevention for this patient, because sometimes they have recurrence of these things. So take home message, primary PCI is always challenging, complications are unpredictable, having no flow, slow flow, dissection, undersizing, oversizing. Just now I saw a beautiful case of undersizing. So always take 0.5 more than post-dilated. It was a onyx stent, so we could have easily gone up to 5.5. Distal propagation of thrombus with attended complications and hemodynamic instability. Challenging anatomy like SCAD, aneurysm, anomalous origin of left main and RCA, highly calcified lesion, as my friend showed, delayed presentation with LVF, serious ventricular tachyarrhythmias, problems like presence of CKD, chronic liver disease, coagulation abnormality, HBR population. However, prudence, experience with judicious use of technology can overcome all these problems and result in mortality of 3 to 4%. However, cardiogenic shock patients has a very high mortality. Thank you very much for your kind and patient hearing. Thanks.
Thank you, Dr. Dhiman. So, Dr. Wali, can we move to 4 lecture? We will have 1-2 questions in the last because we are running late.
Yes, as you said, absolutely. We can go to the next case.
Dr. Vijay Trehin. Dr. Vijay Trehin is, yes. Dr. Vijay, you are not audible, sir. The technical team, please assist.
Am I audible?
Yes, sir.
Sorry for that, but there's some problem in my computer. Thank you very much, Dr. Yadav, Dr. Nitish, for the opportunity, and I'll be starting my case. My screen, I suppose, is shared. Is my screen shared?
Yes, sir.
So starting off with the case state. So this was a 60-year male who underwent a CABG about a couple of decades ago and then presented with unstable angina about 20 years, after 20 years, that was 2016, with rest pain and shortness of breath. The only graft which was patent was radial to diagonal. His natives to RCA, the native RCA and LAD were occluded, so were the grafts. And his vein graft 2M was stenosed, which was stented at that point in time. And he made a tremendous recovery, his ejection fraction climbing from 25 to 40%, marked recovery in his symptoms, and he was fruitfully employed in his working. After 5 years, again, he presented with unstable angina, again the rest pain, TOC positive. This time, again, the ejection fraction was low, and the RSBG, which was stented, also got occluded. That's the angiogram. This is the right. If you look at the distal, it is is all kind of nothing distally, no vessel distally. If you look at the left, the LED which is occluded and OM is occluded. And this was the way the radial which was feeding the OM. If you see, this is a retrofill through that free radial to OM. And this was otherwise coming from above through these stents. And this is the occluded venous graft, which had a long segment of 9 centimeter long segment of 4 Zion stents. So here he is with us for his treatment, having recurrent rest pain and heart failure. I started to wire the vein graft. Everybody will say, why foolish, should not wire it. But I did it, took it down into the OM. The idea was not to open the vein graft because it's a long segment and will have a huge embolization. But I just wanted to keep the wire in the distal OM so that I don't put a catheter in the radial graft because that is feeding into this. And also I will not shoot any contrast through it because there was a concern because ejection fraction and the renal function were also on the lower side. So I started like this. And if you look at it in the setting of ACS with the TROP positive, if you look at this OM, this looks like an acute occlusion. And there is a very short distance to travel. It looks to be a very attractive target. But the wire which I had passed into the OM, I just passed it and then I pulled it back. Because I was cautious that since I'm not full on heparin, I have not crossed the CTO. So I thought since it has crossed, I can again cross it back. So I just pulled it back into the stent. And this was my playground. And if you look at the playground, this was no different from what it was 5 years ago. There was an ostial OM stenosis with an ectasia and some moderate distal disease. I started to get into OM, which was somewhat difficult with the help of microcatheter. I entered the OM. And there was some difficulty in taking fine cross microcatheter into the OM, but yes, it went in. And look at the AL catheter seating well. It is not occluding the left main, which is quite roomy. And
what is going on now?
Then the fine cross is delivered into the OM.
What's going on?
Now, after the fine cross in the OM, I drove the whisper wire from the vein graft, stented vein graft, which was occluded, into the OM to serve as a target. And now I thought, let me start and chase this OM. Anybody out of the panel, am I doing a wrong thing by chasing OM and not SVG? Dr. Yadav, do you think we are doing wrong?
At present, you are going okay.
I think we are going okay. So we went ahead. We started with a whisper wire, and we thought just in case we find some invisible microchannel, that'd be good. But rather than finding a microchannel, we started to get rolling above the wire. So we thought probably whisper will not do the task. So by now, have we done any damage? If you look at the guiding catheter, it has not created any problem. If you look at the microcatheter, it has not.
Dr. Vijay, is your microcatheter too close to the occlusion for wire to work on? Would you like it a little proximal?
Yeah, this microcatheter is at the moment actually what is happening is you're not able to really see it because the contrast is not able to get into this occluded OM because of stenosis here. So as far as guide catheter and microcatheter shaft is concerned, I don't think they have done any mischief by now. And as far as the tip of the microcatheter or guide wire is concerned, one can possibly think as Dr. Bali was saying. So what we thought was maybe just pull it out and just do it like this. So we pulled out and did an extremely gentle tip injection through the microcatheter. What you find is the contrast is holding into this small shaft of OM. But I think probably no harm has been done because the contrast is stagnating fine, but the contrast is not going forward because of CTO. It cannot come backward because it is microcatheter is traversing through a stenosed OM ostium. So I think so far, at least no damage done, even if success is not there. Then I thought probably this wire will not work. So change to Gaia, we changed to Gaia. And then we started to work, escalate to Gaia. And then what we find is, if you look at it, the Gaia has gone beyond the boundary. I think it was little beyond also, but without finding the lumen. So if it has not found the lumen, I don't think it is good practice to keep working. See, what one expects is, if the wire goes in this direction, it's fine. Even if it goes in this direction, it's acceptable. But if the wire is walking up, which was happening in this case, this may be abnormal. It sometimes may be normal because sometimes you can have a change in geometry at the site of anastomosis. So we thought, let us just work very, very gently with this Gaia too. So this is what we were doing. we have a target there in the form of our dystally. Have we done anything wrong by now? Anybody? I'm asking you because I keep asking this question.
I would say that the Gaia and the microcatheter are not a very good combination because the tip load would be increasing and the torque, which we normally expect in 1:1 in Gaia.
Now your microcatheter has been pulled back. Microcatheter has been pulled back. The moment the guy is there, a microcatheter, you see microcatheter has been pulled back. So this microcatheter, you have to keep it there. And you can't change this wire into this osteo of OM, which you are not able to otherwise wire. So you have to keep a microcatheter there. And it's a short stump. All what you can do is you can withdraw it for a while. That's what was done in this case. Other than that, do you find any problem?
The other guide wire which you have into the occluded venous graft.
Yeah.
And take a microcatheter down there.
Yeah.
To see the vessel, whether you are heading towards that true vessel or not. Because we don't know how large this vessel is.
No, but Dr. Bali, with this, the distal, the wire just walked into it, through the stent into the OM without any resistance. It just walked into as if it was walking through a unoccluded vessel.
No, I'm suggesting that we take a.
Yeah, we know it, but I thought probably there is no need to inject contrast into an occluded vein graft, because if you take a microcatheter, I think that is still bulky. You're likely to still embolize some material into the distal circulation. So I was very sure that if you look at the distal wire and everything, all what you need is just a marker. The marker is there. You have a point, but I'll be happy even without that.
The other possibility I can think is that you may be into the other OM. You may not be into the same OM which was previously stented.
You can clearly see walking out of it. You can see the retros also filling in the same direction. I think the topography is so clear that one can be nearly 100% sure that you're in the same OM anatomically. Anyhow,
let's see.
I just gave a pause because we should, because usually it is nice to interact in between rather than just going as a monologue. So far, anything grossly abnormal?
Don't think so.
Not there. So we were thinking that we are sort of okay, but we are caught unaware. Suddenly, this patient gets into VF. And just a couple of seconds before this, I had taken a small whiff to see whether things are fine or not. And the things were fine. So there was nothing wrong as far as angiography is concerned. Suddenly, we got a VF. Of course, we tried to resuscitate some 5-6 shocks. The guide catheter from left came out. The one which was sitting in the SVGOM was still there. CPR continued. After many shocks, then the rhythm returns. First thing which I did was pull out the wire from the distal OM because that may be doing some mischief. It pulled out back into the SVG stents. Angio shoot, as I told you, taken about I think a couple of seconds before that was okay. So I thought there was absolutely no need to inject into the left main circumflex. And then this storm of electrical instability started. And then this is what was happening was we'll get a rhythm. This patient will then throw some excess systole, then NSVTs, then some sustained VTs, rapidly degenerating into VF, requiring DC shocks. And we had to give, I don't know how many, some 25, 30 shocks. And then came a time when the rhythm settled and this was still there in the SVG and the wire was still there in the stents. But I was uncomfortable. I just pulled it out. Now there is a sinus tachycardia patient on pressors. And I thought that, well, one of my catheter was in the left and the other was in the vein graft. And I pulled them out. So if I pull them out, then if they were causing ischemia, then I think that should not be there. And then things should settle. As happens, I think sometimes your guide catheter is inducing ischemia without you realizing that guide catheter angiographically is not causing obstruction, but it is obstructing the vessel. But it was not lasting longer. This honeymoon period was short. I again started to get into that storm, and I have recorded some, but I have not recorded all of them. And this time, used some chemicals in addition to that, and again got some rhythm. But this time, when we got the rhythm, we thought, let's just check it. We checked the left. This was just like as it was a couple of seconds before that arrest. But now the patient is on high dose pressors. His systolic BP just close to 50, 90. He is a sinus tachycardia. Again, those VPBs and NSVTs are there. The sword is right on our head. Potassium is okay. And unfortunately, our IBP was not working, and we do not have any other support with us. And if this patient was somewhere else, I think it would have been the best. I think mode of therapy would have been just put him on some kind of a hemodynamic support and maybe some anticoagulants and let the patient get out. But we didn't have that. So now what to do? Leave him alone. I think he's likely to dip. But what to do? Should we rechange the circumflex OM CTO? Or should we try to get into the occluded SVG, which I think an old occluded SVG is a kind of contraindication even if it has stents. Since we were caught and we had no option, I started to drive the wire again because the wire was going easily. So I took the wire deep into the OM, and then I took a thrombosuction device. With a stylet in, I could go deep into the OM, but with the stylet in, I didn't really aspirate anything and hardly any flow could be achieved. And then if you look at this aortoosteme of the vein graft, this is the aortoosteme, this is osteme, and you have a small 2 or 3 millimeter stump of the vein graft. I thought I can just use it like a Proxys device. I can take a guiding catheter, just wedge the guiding catheter into it, and if I wedge a guiding catheter into it, then the chances of embolizing anything into distal circulation will be reduced. And if I do not shoot anything, do not give a wedge injection at least, then probably my embolization chances will be less. I can do an injection from outside, but if you do a wedge injection, then surely you will embolize. So did this process of thrombosuction many times, and even did thrombo back, that means reverse Fogarty. And with reverse Fogarty, I started to get some material. One important point which I do always is, if anything comes here, then my guiding catheter with a strong section is always pulled back down into the descending aorta. And then I try to wash it here, decant everything, and then put it back into the place, if right coronary, left ostium, or into the aorta ostium, which I did maybe some 50 times in this case. Only very faint flow into this OM. And now what is happening is, without the stylet, it is not going very deep. With the stylet, I am not able to aspirate things. I used a very small balloon again to do a reverse Fogarty, and again going down and again going back after decanting. Now this is just some of the records which are there, and putting it back into the aorta ostium. I start getting some trickle into the distal circulation, and with this trickle, what you see is it is getting a little better. And downstream, I find that there is some area which is narrowed, which could be either a thrombus or it could be a stenosis. But since the thrombosuction device was getting stuck here, so I used a small balloon, then 1.5 millimeter balloon. And after that, my thrombosuction device could easily go down. And then I passed thrombosuction device and then did the reverse Fogarty. Now I start getting flow which is better. Then I pulled the wire, whether the wire is creating some problem distally to decrease the flow, but that was not the case. Then rewired it and started thrombosuction again. Now I started to see all the 3 divisions of the OM. And then again, if I see the same process is happening, the thrombosuction device walks easily into the stented segment, but finds it difficult to go beyond into the OM, especially without the stylet. Now, after doing a lot of thrombosuction in the stent, now my stented segment starts to look better. And so far, I have not at least significantly angiographically embolized anything into distal circulation, even though I'm not able to see any.
So you have to wind up in 30 seconds.
But at least it is not worsening. Now, this thing is happening time and again. And finally, after repeating this, maybe some 50 times, you still see a long thrombus. This is like thread-like thrombus, which possibly got stripped off the wire on which it formed.
Vijay sir, you have to wind up. Your time is over.
Sure. So then after this, let me just mind. Finally, I start getting a decent flow into the OM, and not only decent flow, there was a quick and steady improvement in the rhythm and in the hemodynamics, which permitted me to take the vasopressors off, everything on table. Now, if you see, there is a long thrombus. This kind of a thrombus you don't see, which is embolized from above. So almost anything which was above was aspirated. And this thrombus, if you look at the native vessel at the time when we took a retro shot from the radial, you can see this native OM without any filling defect. So this most likely formed at the time when the VAR was there in the distal circulation, and I was not very good with heparin. And finally, of course, I've checked that there is no guide catheter injury, and this patient subsequently improved. So what went wrong? This 20 years post CABG, 2 ACS episodes in the OM. I think last time we should have stented the SVG rather than stented the OM rather than stenting the SVG, but we missed out. And this time we tried to avoid contrast and avoid ischemia by intubating the diagnostic catheter into the feeder radial, which we did. But we also wanted to use a VAR from the occluded SVG, which is going to be used as a marker. But this turned out to be counterproductive because we were on 5,000 heparin. We could not give high dose of heparin. And since we took quite some time in trying to cross this OM, probably a thrombus formed. And this thrombus, which was on the VAR, got stripped off as we pulled it through an occluded vein graft. We, of course, got into VTVF because there was the guiding catheter was there in the LM, and we were giving some shots of dye through this. That induced a VTVF. And in the setting of ACS, when LV dysfunction, that can happen. But that should have stopped after the guiding catheter from both the vein graft and the left coronary were out. But this did not stop in this case because this patient's distal flow was got compromised because of a thrombus, which was left in the distal OM through the wire, which was kept parking there just to serve as a marker. And I think if you keep a guiding catheter wedged into the SVG, this can work like a proxys. And you can visit into the SVG ample number of times without causing a distal ambulation, especially if you do not wedge inject. And also, if you are trying to wash everything down into the descending aorta with a strong guiding catheter suction maintained, then I think your chances of ambulation to systemic circulation will also be very less. And if you are able to do all those things, then I think you can possibly very carefully take on an occluded, even a long segment of SVG stents got occluded because of thrombus in especially no option emergent situation, which happened in this case. Thank you very much.
Thank you, sir. Dr. Bali, sir, you have to wind up the session. Dr. J.C. Mohan.
I think wonderful case, and we would have liked to have discussion both on Dr. Mohan's case and Dr. Vijay Trahan's case. And Vijay's cases always are challenging and they invite so much of discussion. But maybe some other day, we should have a full session on this case. And I thank all the presenters. Wonderful cases. And we had a great presentation. And I thank you for the organizers also for inviting us to this session. Thanks.
Thank you all the chairperson and speaker. And now we have to move to the next session. This view and counter views, 4-minute speakers. And the chairpersons are Dr. Ashok Goel, Raghav, Jagan Mohan Thakran, Dr. Talwar, Dr. M.K. Das and Dr. P.K. Goel. And I request Dr. K.K. Talwar and Dr. M.K. Das to start the session.
Dr. Talwar is there.
Yeah, Dr. Das, you can start, please. Go ahead, Dr. Das. Good evening to everyone. Please go ahead.
Has Dr. J.C. Mohan joined? Rakesh, Dr.
Yes,
J.C. Mohan joined?
Mohan was there.
Has he joined or he has left? Dr. J.C. Mohan, are you there?
He was here till...
So if he is not there, then I think this views and counter views will have to be taken up by Dr. Lekha Pathak herself. And I'm sure that she will do the justice and sticking to the time. And it's a very great session that is views and counter views. And the topic was, is my practice right? Stemi presenting between 24 hours to 48 hours. And routine PCI still has a role. Dr. Mohan was supposed to put his views in favor of the topic and Lekha Pathak against it. But I think Dr. Lekha Pathak will have to cover the both. And this is a very important issue in Indian scenario because of the logistics and so many other factors present in real world scenario, present after 24 hours in many a case. And that's why the issue should be discussed in detail. Over to Dr. Lekha Pathak. Madam, sir. Madam.
Hello, Dr. Das. How are you?
I'm good, ma'am.
Now there's no opposition, so there is not much of fun in talking. Huh? But still, I'll complete as you requested. that we all know in our practice, the STEMI presents anytime. It may be early presentation, it may be a late presentation. And we have to decide many things. We have to take many things into consideration before saying yes or no to the PCI. And today we are talking about the PCI when it presents late. Let us see. Now, we all know that in India or all over the world, the STEMI presenting between 24 to 48 hours, routine PCI still has a role. Now, I'm going to oppose it. I'm going to say no, no, no to this proposition. We all know that in India as well as abroad, almost everywhere, the proportion of people come to present late in India is about more than 40%. Now, what is most important when we are deciding this is the total ischemic time, that is from the symptom onset to the initiation of reperfusion therapy, has two main components, the patient delay and the system delay. Now, patient delay, all of us know about it, many factors, which I come later on. But system delay is very, very important today in practice.
We are not seeing your slides.
Ma'am, you have to share the screen.
Share the okay.
We are not seeing your slide.
I'm not seeing. Oh.
The technical team, please help.
You can see me?
Yes, ma'am. You are not shared the slide. You have to share your slide.
I'm sharing the slide.
No, ma'am, you have to click on the share screen button.
Okay.
After clicking on that button, you have to select your slide.
There is a green button below, ma'am. Share screen. You just
share the screen.
Yes, ma'am.
Now, can you see?
Yes, sir. Thank you, ma'am. Thank you.
Okay, fine. So again, I think today's topic is STEMI presenting between 24 to 48 hours. Routine PCI still has a role. Now, Dr. J.C. Mohan was supposed to speak in favor of that, and I was supposed to speak against it. And therefore, I'm starting my talk that PCI does not have a role after 24 to 48 hours of STEMI. Yeah. Now, when the patient present led, India, almost 40% of the patients are presenting beyond the time of reperfusion suggested so far in the literature, and we are practicing. There are two important components of presentation and delay. One is the patient delay, which of course we all know about it, and the system delay. Today, system delay has become very important. In most of the hospitals are corporate hospitals, and when the patient comes to the hospital, in the middle of the night, the patient is asked to pay the complete package to the hospital, which is a very difficult thing, and it may be one of the important factors for delaying the angioplasty. Now, why do patient presence late? There are multiple factors. Now, patient may be having a lack of education. Patient may be having no chest pain if he has a diabetes, or atypical chest pain, or a stuttering chest pain, or maybe a wrong diagnosis, atypical presentation, or possibly he has landed into a non-PCI hospital. Now, whatever may be the reason, wherever the patient may be going, the pathophysiological changes start with time. Now, all of us are aware of this picture, this end table. And it is very clearly says that when we cross the 24 hours, the damage is already done beyond this point. So what about the primary PCI will help in late presenters? Now this is a very, very important diagram. We have all been seeing for years together and discussing it, but gives a very important information. The relationship between the duration of symptoms, mortality reduction, and extent of myocardial damage, salvage. The most important thing when we do a PCI is that how much myocardium is salvaged by the PCI, and whether it can reduce the extent of myocardial infarction, it can relieve the symptoms, and it can reduce the mortality and subsequent cardiac event. Now here you can see that if the PCI is taken within 3 hours from the onset of a chest pain, the critical time dependent, there is absolutely good myocardial salvage. But as the time passes, beyond the 6 hours to 12 hours, we are doing the angioplasty, but what are we ultimately getting it? Let us see during the course of the time. And all of us know that in 6 to 12 hours, although it is an indication for angioplasty, but when we do the angioplasty, within this time, we open the tube, but we are left nothing but with the myocardial damage, which already takes place. And from 12 to 24 hours, it's already controversial. And we are talking about 24 to 48 hours, which is really, really difficult. Do we have primary PCI for all latecomers? Should we do it or should we not do it? Let us see. Now, what was the traditional teaching? The traditional teaching was that all patients presenting within 12 hours of Stemi should be considered for reperfusion therapy. And second teaching was that reperfusion not routinely recommended in patients who present more than 12 hours after the onset of symptoms. So when they are present in 24 to 48 hours, the question of reperfusion do not arise. I think we have to ask some very harsh questions before we talk about the late PCI. What I was just saying, how good is the primary PCI for patients presenting within 12 hours? And I am aiming from 6 to 12 hours. Even early, that is 6 to 12 hours, fast and furious primary PCI, the myocardium is not fully salvaged. And in more than 75%, we are left nothing with except the LV dysfunction. And we are treating, after the angioplasty, the left ventricular failure, off and on, getting multiple readmissions and subsequent cardiac event. So whether it is worth doing or it is better not to touch the patient when he presents late after 24 to 48 hours. Then why PCI in late presenters? Why we are talking about it? Can we defeat the myocardial pathological clock, which has already taken place? We cannot do that. The second important point is that are we trying to catch a late opportunity to salvage the myocardium? Can we do that? We have to think 10 times about it. At what cost and at what risk? This all needs to be answered before recommending routine PCI for STEMI late presenters. Any data to support this? Of course, whenever we talk of in favor or in against of any theory, we have to show some data what is supporting or against it. Now, we all believed for a number of years in open artery hypothesis. We believe that if we open the artery, probably the patient will improve or recover. Now, it was shown that intermittent patency of infarct-related artery on coronary angiogram up to 30%, less than 12 hours, and about 50%, 12 to 40 hours. The infarcted myocardium is highly dynamic tissue, which is not simply dead, nor it is inert. Patient may have a stent or hibernated myocardium. There is stuttering force of AMI. The presence of collateral circulation is very, very important, and there may be ischemic preconditioning. The gradual recovery of myocardial blood flow in ischemic region and 96 hours as per experimental coronary occlusion, which is of course is experimental. So what about reperfusion PCI in latecomers? Now the occluded artery trial was the first trial and one of the largest trial to show whether it is beneficial or not. Now in this, the PCI with the stenting was performed 3 days to 6 weeks after anterior myocardial acute myocardial infarction. Most of the patients have greater LV dilatation with late reperfusion, 44% increase in adverse risk, but they have shown there was a improved exercise tolerance and quality of life. The major critics of this trial were many. What were the critics? Number one, there was a long exclusion list, not representative of real life ACS population. The enrollment was extremely low, and the trial was prematurely terminated. And the long-term results, which is up to 4 years, have not shown any mortality benefit by PCI versus the optimum medical therapy. Now, when there is no mortality benefit, then why should we do a PCI? Why not continue with a patient on optimum medical treatment when the outcome is same in both the groups? So, on the basis of the occluded artery trial study, routine PCI 3 days to weeks after AMI is not recommended. Now, please see here, they are clearly saying that it is not recommended for persistently occluded infarct-related artery in asymptomatic high-risk patients, since higher infarction rates were seen in the PCI group, and yet no difference was seen between the PCI and the conservative groups in terms of event-free survival after a median follow-up of 3.2 years or LV systolic function at 1 year. So they have not found any benefit in late PCI. Another trial, coronary intervention for persistent occlusion after myocardial infarction in 2006, published in New England Journal of Medicine. Now, this also very clearly shows there was no difference in the death. There was no difference in the heart failure in PCI group or optimum medical management group. In fact, the fatal and non-fatal infarct was more in PCI group as compared to the medical therapy. And therefore, there was no significant benefit in the PCI group. Now, this is the summary of all the data. And you can see here the dots. All the dots are almost except 2. They all are favoring that medical therapy is better as compared to the PCI in all these patients. So, late PCI is not recommended. So, the conclusion of the trial was that PCI did not reduce the occurrence of death, the reinfarction, or heart failure, and there was a trend towards the excess reinfarction during 4 weeks of follow-up in stable patients with occlusion of the infarct-related artery 3 to 28 days after myocardial infarction. So this trial also does not favor that we should do a late PCI. So open artery hypothesis still remains a hypothesis only. Now these are some of the randomized clinical studies of late perfusion, more than 24 hours, the various trials, the number of patients, the method, time to reperfusion, and the sustained patency and overall outcome. Now you can see here, all are showing mostly the negative outcome except the one study. Brave 2 trial in 2005, about 365 patients without symptoms, 12 to 48 hours after the onset of Stemi. 50% have some integrate flow of infarct-related artery, 44% had collateral among no integrate flow, only 27% had TIMI zero flow and no collaterals. There was significant reduction in the infarct size, but please remember that there was no significant difference in clinical endpoint, that is death, MI, or stroke, but favorable 33% relative risk reduction at 30 days. Now, better initial TIMI grade or patency of infarct-related artery was a significant predictor of a small infarct size and a better efficacy of PCI in early latecomers. Early latecomers is also. So the only meaningful study in favor of late PCI, but it failed to clear the confusion. So where are we going? What are the recent advances in this late PCI? Let us have a look. Another trial which was conducted in 2009, the impact of primary coronary angioplasty delay on myocardial salvage, the infarct size, microvascular damage in patients with Stemi. And this is a very sensible trial, and you can see the various factors which are mentioned in this trial. Myocardial salvage, what is our ultimate aim? The infarct size, another important read, and then microvascular damage. Let us have a look at it. Now,
ma'am, maybe I request you to, ma'am, since we are running short on time, if we could.
Okay, fine. If you can see, this is the infarct size. This goes on increasing as the time passes, and the myocardial oxygen obstruction increases as the time increases, and the myocardial salvage becomes less and less as the time passes. Now, these are the images of MRI. You can see here inferior and anterior infarct, which increases with time, and myocardial salvage decreases with time. Another important trial, which has been published in 2021, immediate compared delayed percutaneous intervention for patients with ST elevation MI more than 12 hours after the symptom onset, not associated with improved clinical output. Now here you can see in late presenters, there was no significant difference in MACE, whether they are subjected to PCI within 90 minutes or beyond 90 minutes. So far, late presenters, we have enough time to think perfusion in some tests, decide, and then only go for PCI. This is a group where you can decide about this rather than routine for all. So this is, of course, the ECG, the echo, the stress test, and further risk stratification for myocardial viability. And this is a group of patients where, despite of total occlusion, you go and do the PCI, particularly when patient present with severe angina, cardiogenic shock, high-risk feature, intermediate or high-risk positive, and viability shown on the reperfusion imaging or MRI. So what guidelines say? It used to be class 3 by ACC and CSC class 2B. Again, it remains class 2B and class 2, 3, class 3 indications. So even after doing all this, you are clear in your mind or still you are confused? There's no simple specific guidelines to manage patients when they present late. So you have to use a practical approach in unstable patient. When the hemodynamics are unstable, you have to take the patient irrespective of the time. And even in stable patient presenting 12 to 24 hours, I don't think they require any angioplasty. So in latecomers, routine PCI after 24 to 48 hours is not recommended. Thank you very much.
So, Lord, sir.
Thank you so
Dr.
much.
Talwar, you just conclude.
Yeah, thank you so much, Dr. Lekha. I think you rightly put it that what the benefit of a late angioplasty, but the issue is, you see, all these say asymptomatic. When a patient comes to you after 24 hours or 48 hours, I mean, when they have some kind of a discomfort, which sometimes you are not able to be sure, I think what you rightly said, the viability testing in those situations may be useful, but it's very difficult because sometimes patients complain of some discomfort in the chest, and to say it's angina or not angina may be very difficult. So I think these are the areas where I think sometimes you have to take a call. That's what I feel, but I agree with you, asymptomatic. I think doing a further evaluation might be helpful to find the right patient.
Dr. Lord, I agree that I said that there is a separate subgroup. Even in total occlusion, there is a separate subgroup. If the patient complains of chest pain, there is ongoing angina or not. If it is ongoing angina or failure or some arrhythmia, then you have to take the patient. Otherwise, asymptomatic patients, I think we should avoid doing it.
Well, I think time being limited, Dr. Nitish, you have any other questions somebody wants to ask?
No, so I think so we can go ahead to the next talk since we're really short
next
on
topic.
time.
So thank you, Dr. Lekha. I think we don't see Dr. J.C. Mohan till yet. Maybe I think so. We can move to the next session. Is a very, very interesting session, and particularly the ICD post ST elevation MI ejection fraction less than 35%. Go ahead per ICD state or risk stratification. And I am sure we know all the guidelines about this, how to go for in these cases. But let us look at two eminent speakers on this. I think Dr. Claire and then Dr. Jayaprakash. Dr. Claire, please, are you? Dr. Claire is there? Yes, we see Dr. Claire. Dr. Claire, can you unmute yourself?
Yeah, am I audible?
Oh, yes, sir. You are very much audible. So,
Namaste,
Dr.
Sat Sri
Claire,
Akal.
I think.
Good evening,
Sat Sri Akal ji, Sat Sri Akal. So, I think, Claire, I think let us, because the possibility, let us go ahead with your sort of deliberation. Let us hear what you say that go for ICD. I think, are you meaning all cases or are you meaning just as for the guideline? Please go ahead.
Okay, just give me a second. सोने तो वाजा नहीं था नहीं पता है पूरी ढीली लग रही है शेयर स्क्रीन पर मेरी तो टाग ही नहीं इसमें
Yes, if we can just stick to the time because of late session going on, then we can have Jayaprakash also a little after that. So that will be only a humble request to you.
Okay, I will try to.
Technical team, please assist Dr. Claire.
Can you please click on the share screen button? The green button. Yeah.
Can you see my slides?
Yes, sir.
Yes,
Just as you put it on presenter mode, sir.
Can you see the slides now?
Right, sir.
Yeah, we can see that.
Okay, first of all, thank you, Nitish and Rakesh, for organizing such a wonderful meeting. And I'm happy that Dr. Talwar is on the screen, and subject is very close to his heart and my heart. Well, this is what happens, in sudden cardiac death. I think this was from a patient who was unfortunately died suddenly, but he was on a Holter. Starts with VT, fast VT, and the whole story started at 6:02 and 6:11 he's gone. And if a patient is on a defibrillator, look at the sinister ventricular tachycardia, and the device shocks him, and this patient is back to life. We also know that it is highly time-dependent phenomena. If you shock within 2 minutes, the survival is 80%. If you shock the same patient after 10 minutes or 8 minutes, they almost you have a zero survival rate. So that means something like implantable ICD is the only way to prevent sudden cardiac death. Otherwise, nothing can be done about it. These are the landmark secondary prevention trials. Everybody knows. I think its presentation is just for the youngest young crowd. ABET, SIDS, and the CASH trial. The bubble size means the number of patients. And it was ICD therapy versus so-called the best drug available, amiodarone. And we know that ICD in all these trials fared much better as compared to the drug therapy alone. Overall mortality was not changed by amiodarone. Even historically, if you see the Canadian and the AMIAT and CAMIAT trial of antiarrhythmic therapy, in those trials also, the drugs, particularly amiodarone, was able to prevent VT or arrhythmias, but their overall mortality didn't change with the antiarrhythmic therapy in these patients. So now come to the primary prevention trials, MERIT, MUST, MERIT-2, and sudden cardiac death, heart failure trial. All these trials again showed a very, very favorable result in terms of the overall mortality reduction with ICD. The criteria in MERIT was 35%, less than 35%. The criteria in MERIT-2 was less than 30%. Well, there were other criteria in MERIT trial, but later on in MERIT-2, there was nothing, no other criteria except ejection fraction. And if you see the results in these trials, overall death and arrhythmic death, the overall death reduction was excellent with patients in MERIT-2 who were on ICD and even in heart failure trial. So drugs have a limited role in reduction of death due to sudden cardiac arrest in heart failure patient and post-MI low ejection fraction patient. This was a study in New England Journal of Medicine, a landmark trial, and mortality benefits with ICD therapy. So I think we are very clear that in primary as well in secondary prevention trials, ICD, they prevent mortality, and the benefit is much more in primary trials than in secondary trials. Obviously, because I think in secondary trials, the patients are much more sicker as compared to primary trials. Now, if you go to number needed to treat, save lives, in the MUST trial, 3, MERIT-4, MERIT-2, only 11, as compared to many other, landmark trials of benefit in mortality reduction like SAVE trial or MERIT heart failure trial. Number needed to treat one life was much more as compared to these trials. So ICD works in real world. I think we are convinced that over so many years and years, MERIT-2 ICD being MERIT-2 like ICD, this is the registry, and MERIT-2 medical therapy, there was a clear difference between the mortality in these two trials. So people die in heart failure, for example, ejection fraction less than 35%, practically 50% will die in 5 years, and at least 50% mortality in these patients is because of arrhythmias, where ICD can save those lives. At least 45 to 50% of those patients can be saved because of the ICD. So let's go, what are the recommendations finally? Whatever we talk, we go according to recommendation. The recommendations up to now are class 1, primary MI, prior MI, ejection fraction less than 35%, NYH class 2 and 3, more than 40 days post-MI without revascularization, 90 days more post-revascularization. Number 2, prior MI, ejection fraction less than 30%, even if the patient is in class 1, and more than 40 days post-MI. So this is level of evidence is A in both these recommendations. If you have a MI but ejection fraction less than 40%, you have a VT, which is non-sustained, or VT is inducible. Again, ICD is recommended, but the level of evidence is B. We are not talking about the cardiomyopathy today. So guidelines do not require any further assessment. That's, I think, very clear. So further risk stratification. There have been many methodologies applied: QRS duration, QT interval, average signal ECG, QT dispersion, heart rate variability, and ventricular atrophy, non-sustained BT, and exercise test, functional class, T-wave alternance. Well, a lot have been actually ventured into, but none of these criteria became part of the recommendations. I wish they should have been, but none of them really came close to that. So risk factors for arrhythmogenic substrate are, extent of myocardial damage and scar. Slowed conduction. If there is areas of slow conduction, which is documented by surface CCG, the slowed conduction, heterogeneity in the ventricular depolarization, QT interval, QT dispersion, T-wave alternance, imbalance in the autonomic tone, heart rate variability, heart rate turbulence, baroreceptor sensitivity, and ventricular atrophy, long-term ambulatory monitoring, EP study are the things which we can go into these details. So low ejection fraction remain the single most important risk factor for estimation of overall mortality and sudden cardiac death. Then come the frequent PVCs and non-sustained BT and EP inducibility in context with the low ejection fraction. So ultimately, this is another data to show that patients with reduced ejection fraction, they have more sudden cardiac death, lesser survival, and worse prognosis than those with preserved ejection fraction. This is overall survival probability. EF more than 45%, 6%, less than 45, 14%. This is survival probability. Length of follow-up. Again, ejection fraction remain the most important single criteria. MEDED 2, I think you people know that it was more than 30 days MI ejection fraction, less than 30%. Study was terminated after 20 months prematurely because ICD reduced all-cause mortality 14.2 versus 19.8%. It showed clearly that patients with ischemic cardiomyopathy, evidence of a myocardial infarction and ejection fraction 30% will benefit from ICD. So again, recommendations remain: patient with ejection fraction of 35% or less, that is due to ischemic heart disease, who are at least 40 days post-MI and at least 90 days post-revascularization, and with NYHA class 2 or 3, despite guideline medical therapy and ICD is recommended, if meaningful survival greater than 5 years is expected, and patient with ejection fraction less than 30%, even if they are in class 1, the same criteria hold true, and level of evidence is class A in those patients. Well, then there are other things. For example, in the shortage of time, I will not go into the details, but there was a concept of 1.5 prevention with the study which came from China, India, and some other countries, where they took ejection fraction less than 25%, QRS more than 120 millisecond, history of syncope, and the duration of myocardial infarction. But this study did show perhaps more appropriate use of ICD. But then again, even after this study, they never became part of any guidelines. It seems sensible, particularly in the third world, where economic factors are very important, that we have to be more and more sensible in implanting the ICD. But science is one thing, the economic conditions are totally a separate issue. So conclusion is ICD save lives. Secondary prevention trials, class 1 indication, primary prevention trials in ischemic cardiomyopathy, ejection fraction less than 35%, it remains a class 1 indication. So I think with these remarks, I will rather close. I think I have taken short time. So my recommendation is that if we go strictly by guidelines, I think only thing which matters is ejection fraction, nothing else. Thank you very much for your kind attention.
Thanks so much, Dr. Clare. I think for so nicely sort of putting up the evidences for this and finishing even before time like a stalwart. So now I think we can have question later on. I'll request Dr. Jayaprakash. Jayaprakash, are you there? Please?
Yes, I am here. Can you hear me?
We are looking forward to hear you, Jayaprakash, because
Thank you so much. At the outset, I hope you can see me sharing the screen. Are you able to see my screen?
Yes, please.
At the outset, I would like to thank the organizers, especially Nitish and Dr. Yadav for inviting me for this, because I am a sort of a cat amongst the pigeons. I have never listened to so many coronary talks for past 25 years now. Now, nevertheless, I listened with great interest of Dr. Clare's lecture. I was not sure whether he was giving part of my lecture or whether he was, using his lecture. If you see, the second half of his lecture was a part of my lecture, which I'll probably present. Now, having said that, I will agree on one thing, that ICD saves lives. So there is no second, thoughts about ICD saving life. Now, having said that, the guidelines also say that, look, you should implant an ICD in patients with ejection fraction less than 35%. So I agree with that. But I beg to diverge from this view, considering what we have in our country. And I'll present some data where we can look at how to risk stratify these patients much better. Because in fact, if we put an ICD in every patient, probably the patient might die or not of ventricular fibrillation. He might die of starvation because he will have no money left to survive. It's an expensive device. So we should probably, in our country, be very careful in selecting whom to implant an ICD or when to suggest an ICD. I have nothing to disclose. We all know that sudden cardiac death is the most common cause of death, which probably is much higher than all cancers put together. And the most common cause is coronary artery disease. And coronary artery disease is very common in our country. It accounts for approximately 80% of all sudden cardiac deaths. And this is the only study. Unfortunately, we don't have many studies. This is from my friend Haigreve Rao, who presented this study in International Journal of Cardiology, where he looked at the sudden cardiac death, and it said that about 10.3, it was a verbal autopsy where which was done in patients' relatives. And then they found that ACD contributes to about 10.3% of overall recallable mortality. Having said that, we know the ICD is indicated. We are not concerned about secondary prevention nor in non-ischemic heart disease, but the data has been presented by Dr. Clare that it is more than 40 days post-MI with a low EF and an NYHA class 2 or 3, and ICD is recommended. So now let us look at a little more closely as to how this sort of thing has come about. Now, if we look at it, I'm not going to talk about secondary prevention. I'm going to talk about two of these primary prevention trials which have shaped this sort of concept of primary prevention. One is the MADIT trial, which is published in 1996. The second is the MADIT-2 trial. MADIT-1 trial was a very small trial, post-MI 1 month, mean age 67 years, very low EF, documented NSVT, and it required patients to undergo a VT study where you could induce a VT, which was not suppressible with IV procainamide, and the follow-up was for about 27 months, and it showed a reduction of 54% reduction in mortality. While as MADIT-2 was a much larger multi-center study, mean age of 67 years, mean EF of 23%, and they were randomized to 3:2 to ICD versus conventional therapy. As Dr. Clare already mentioned, it was prematurely terminated. However, it reduced the all-cause mortality. It also reduced the sudden death. However, the number needed to treat, please note this very carefully. You had to put an ICD in 18 patients to prevent one sudden cardiac arrest. So this is from MADIT. So having said that, we have to be very careful. Now let us look at it very carefully. Now there are millions of patients with MADIT criteria. If you look at it, if you look at just low ejection fraction, if you see about 12 million people have coronary artery disease in the US, while if you apply the same thing in India, probably it will be much more. And there is approximately 1.1 million per year who have an MI in the US. And approximately 18% of these patients, 18% of these patients have an LVEF less than 40%. And 5.4% of these patients have an EF of less than 30%. And if you look at the NSVT criteria, 32% have NSVT. And of these patients who have NSVT, if you take them up for an EP study, 35% of them will have inducible VT. That is about 0.3 to 1.1% of patients who will fit into the MADIT criteria, the original MADIT criteria, which looked at inducible VT. Now, as I have mentioned earlier, there is 10% total mortality in these patients. And in India, we have a very large prevalence of sudden cardiac death, which we have to take. But however, what is very important is we need to prevent sudden cardiac death, which I truly agree. Primary prevention is extremely important because less than 8% of patients survive the out-of-hospital cardiac arrest, and probably in our country, it is much less. And taking LVEF alone is very simplistic because pathophysiological substrate of sudden cardiac arrest has multiple causes, which has been mentioned by Dr. Claire, which includes the myocardial substrate lesions, impaired autonomic nervous system function, abnormal repolarization indices, and the inducible AF VT. And there are some provocative study which also indicates that doing a PCI also increases the inducibility of VT because there are strands of myocardium which are there in the scar, which increases the risk of VT. What are the limitations of LVEF? LVEF has been used and probably has been used for implanting the ICD. But we have to know that these measurements have intra and interobservable variability, has also temporal variability depending on whether the patient undergoes revascularization, pharmacological therapy, or natural progression of disease. It is probably more correlated with total mortality rather than arrhythmic death. And it has a low sensitivity. We have to realize that approximately 2/3 of patients with SCD, it occurs in patients with ejection fraction of more than 35%. So having said that, we also have to look whether it is cost effective. This is the data from the US. I can't give anything from India. Anything which is less than $1,000 to $20,000 per life year saved is considered highly cost effective. $20,000 to $40,000 is considered cost effective, and anything beyond that is probably not cost effective. Now let us look at the incremental cost effectiveness of ICD therapy and other cardiovascular interventions. PTCA, severe angina, one vessel disease, $17,000 cost effective. But if you look at the ICD MADIT, it is probably cost effective because it is around between 20 to 40,000. But if you look at the ICD MADIT estimate, it goes up to 50,000. And if you look at the ICD AVID group, it goes to $66,000. So this obviously is not very cost-effective way of looking at implanting a device. Now, again, if you look at the ICD therapy, if you look at MADIT, you require to treat 4 patients to prevent 1 sudden death, while as MADIT 2, you require approximately 18 patients you have to implant devices, which is a very expensive way of treating it. These have already been mentioned by Dr. Claire, but what I would like to tell you is looking at these VPCs and NSVTs, I'll draw your attention here. In studies, it has been shown that in patients who have stable CHF, NSVT is an independent risk factor for overall mortality, and repetitive beats in 24-hour Holter probably portends a sudden cardiac death. And even in patients in SCUD-HEF, if you had patients with NSVT episodes, this would indicate this was a predictor of sudden cardiac death. And also, when you look at the prevalence of arrhythmias, if you have a patient with low EF and a very complex arrhythmia, it again portends a sudden cardiac arrest. And here I'm presenting you the GC2 trial, where if you do not have any sort of complex VPCs, then your survival is much better compared to those patients who have a very complex ectopy, multifocal ectopy, very frequent ectopy. So having said that, the other thing which we need to realize is there is an evidence that if a patient with low EF has a syncope, it portends sudden cardiac arrest, provided, I'm mentioning it provided you have ruled out other causes like the neurocardiogenic syncope, which we have already published that even in patients with structural heart disease, it has been published. Our group has published 60% of them have some sort of, reflex syncope in this group. But provided you rule that out, arrhythmic syncope portends a very bad prognosis. Having said that, Dr. Claire has already mentioned it. Please look at these patients with ejection fraction less than 35% and initiate and titrate medication. Now, there are two things which have occurred after 2002, which is the introduction of ARNI.
Sorry, can you quickly, you have only 1 minute more, please.
I'll finish it. I'm just 2 slides away.
Thank you. Sorry.
I'm just 2 slides away.
Okay.
So we are looking at two things. One is the ARNI, and the second is the SGLT2 inhibitors, which have made changes in sudden cardiac arrest. So we need to assess them. And I would suggest that we look at low EF, NSVT by ECGs, complex PVCs, or presence of syncope after ruling out reversible cause of syncope, and then considering an ICD implant. So as I said, I'm going to finish on time. The conclusion is sudden cardiac arrest is the most common cause of preventable cause of death, and ICDs are very effective in preventing it. And let me tell you, sudden cardiac arrest is an electrical phenomena, and it needs ICD to prevent it. LVEF is rather a poor marker, and it is not very cost effective if you implant it in everybody. Everybody cannot afford it. And we need to use additional markers along with LVEF, and probably the best is to look at NSVT and syncope as other markers for implanting an ICD. Thank you all for a patient hearing.
Thank you so much, Dr. Jayaprakash. Sorry, you finished even before time. So grateful to you because of but I think before I pass on to Dr. Das, I have one little question to both of the distinguished speakers. You see, and Jayaprakash, you're right. I think we have some kind of a criteria, even merit have a modifiable criteria. We can, of course, we need to have the data available. But my query is that when we look at the guidelines for post-MI low ejection fraction below 35, class 1A indication, and after 40 days, whereas when you look at low ejection fraction below 35 after optimum treatment and revascularization 90 days. But why doesn't this apply to post-MI people also? I mean, this is what I understand from the guidelines, unless I'm understanding differently, because I think we must give today optimum medical therapy, revascularization, 3 months for remodeling before we look at the ejection fraction. So I will like both of you to, because why not 90 days rather than 40 days after MI? Not clear?
Well, I think, Dr. Ward, you have raised a very pertinent and very kind of thought-provoking situation. I agree with you. See, there are a few comments which I want to make. Dr. Jayaprakash is a dear friend and a very thoughtful person. See, first of all, I want to say that in India, many times we talk about money. We can't afford it. We can't afford it. First of all, that is not a science. Number two, even if we think it is important issue, in this country, crores and crores are spent on political rallies, and when it comes to the healthcare, then everybody starts crying. When patients have to pay to the doctor, then they don't want to pay, but they are willing to make houses. They are giving to dowry to their daughters, 20, 30, 40 lakhs. They don't care. So I think there's a lot of mindset, wrong mindset in our country. And even doctors, we assume patient can't afford. I tell you that our assumptions are also wrong many times. Number one. Number two, money is a separate, guidelines are separate. I think the 1.5 prevention trial like studies, perhaps more needs to be done. And when the numbers are more, then maybe then we can even go to the extent of making the American Heart Association or European Heart Association accept those criteria. And let me tell you that I I may be called ICD man, and but I am very, very particular not to give ICD in every patient below ejection fraction 35%. Patients just can't afford it. But patients, I certainly believe that if I was a health minister, I will not give ICD out of the public money to anybody. You know, if somebody can afford himself, let him have it. But government giving money ICD to for primary prevention, I think just not justified, because lakhs and lakhs of children die in this country because of just diarrhea, which can be prevented. So those are other things.
I think we can quickly, because the organizers are putting the other show already on the screen.
Right, but I think, Dr. Nawad, I agree with you that this criteria of 40 days perhaps needs to be rethought. Rethinking is required in that sense. Actually, you know, not only that, many patients come from outside, ejection fraction like 32%, and we say ICD. Jayaprakash also brought a good point that all those patients who come for ICD or they come to you and you think it's a primary prevention, in them, ARNI, dapagliflozin, those things have not been tried. Maybe we should try those drugs 3 months and then reassess the ejection fraction. Similarly, after a myocardial infarction, we should give time to remodeling. But again, I think we should do some prospective study rather than just, imagination.
Thank you, Dr.
I would add one thing in the end. Just I'm glad that Dr. Claire agreed with me on all the points, and I'm very thankful for him. And I would thank the organizers for having given me this opportunity to present. And I will close because he has answered all my questions.
Dr. Das, can you give the concluding remarks, please, before we pass on to the organizer? Dr. Das, is he there?
I think both the speakers have done an excellent job by talking about science and mediconomics. Whenever we talk about science and mediconomics, there is always a chance of diverse opinion, but with the present government's approach in the healthcare delivery system, definitely more and more ICDs are being implanted. As I am seeing even in Bengal, the number of cases of ICDs and CRTs, they have gone to a very high level. And this is because of the governmental support and also the other supporting system. So I think both the speakers really have highlighted the things in a great perspective, and we are really educated with those informations. Thank you very much.
Thank you, sir, and thank you for that. Was a really wonderful session. I would all agree to that. And up ahead, we have an even more interesting session coming up. We have 5 very, very renowned and very noted cardiologists coming up on this screen. And for that, I would like to first invite our esteemed chairperson panel, Dr. H.L. Kher, Dr. P.K. Dev, Dr. P.S. Banerjee, Dr. Suman Bhandari, and Professor V.K. Bahl to conduct this session. And I would request Professor V.K. Bahl to start the show by first introducing Dr. Samin Sharma, someone who's taught me as well, and I'm very proud to be part of the session.
Good evening and welcome to this very important session. I have with me my co-chairperson, Dr. Kher, Dr. Dev, Dr. Banerjee, Dr. Suman Bhandari, and I'll introduce you to a man who needs no introduction, especially in India, maybe world over, Dr. Samin Sharma. For his title, it is Senior Vice President, Mount Sinai, New York, USA. His academic achievements, if I have to enumerate, whole session will go on that, so I don't want to keep you between him and the session. So he has done highest number of complex coronary interventions, invention of kissing stenting, master of rotablator, but I will leave that aside. For me, the most important point is his nature. His helping nature is known to everyone in India. And literally, he is a phone call away for any help you want. I'm really, really thankful to him that he has trained highest number of Indian cardiologists. Everyone wants to go to his lab and learn something. If you have not attended, I have been fortunate enough to attend his one-day course. In that one-day course, you can see 25 cases, live cases performed by him, and you can learn the whole year's curriculum in interventional cardiology. I've been fortunate enough to be even faculty in that courses. And really, I've seen him, and I won't stand between him and his talk, which is always eagerly looked forward to 10 important interventional trials in myocardial infarction. The stage is yours, Dr. Samin.
Okay, can you hear me well?
Yes, sir.
Okay, great. Dr. Bal for a great introduction, great friend. And of course, Nitish Naik is the one who started this process. And I give thanks to our CSI, Stemi Council to give this opportunity. And actually, I give my top 10 topics, which have become a sine qua non, like every lecture, even Fuster wants me to give 10 lectures, 10 topics in the structural this December is symposium. So I, Stemi, haven't given in a while, so I prepared myself for this. And let's see, I want to share with the, want to make sure we can share it. Okay, you see my slide now, right?
Yes.
Okay, good. So I got my 15 minutes. I know we are a few minutes off today, but that's okay. So that, you know, it's our usual timing. So basically what I'll do is, a lot has been, I saw the agenda very enriched. A lot already have been said. And what I tried to do in last 2-3 years, what has been a new in STEMI outcome. We know the door to balloon time, decreased pain to balloon time, all these things have worked. Pre-hospital administration of antiplatelet agent, avoidance of morphine, radial access, culprit versus non-culprit, statin, DES, and cardiac rehab actually is coming quite a bit. It has become from the CMS, which is like a Medicare, the important landmark that how many patients after MI have been referred for rehab, because that has been shown to improve symptoms, readmission, and well-being. And STEMI management, as I said, that I just put it together. So basically, idea would be that present some data which have in last 2+ years have come and changed our practice. I start with the first is the Colcott trial of the low dose colchicine in acute myocardial infarction. We know the colchicine is anti-inflammatory, being tested in stable CAD, LODOC 1, LODOC 2, and this is for the STEMI patients. About 4,000+ patients were randomized to receive colchicine 0.5 milligram per day, and then continued, as you can see here, that by giving for over the 4+ years, there was the benefit of colchicine compared to placebo on top of standard medical therapy. So everybody got what they're supposed to get. Primary endpoint shown here. Basically, urgent hospitalization for angina leading to revascularization was the most important benefit of colchicine, and that is, I think, mediated through the anti-inflammatory. There was no difference in death. The second is the Safari STEMI, radial versus femoral. We all know that radial has shown by multiple trials in the past has become a class 1 indication, particularly matrix, large study showing benefit of radial intervention. And anytime we know something is well set, we try to really look into maybe is there some different option that controversial. So this basically Safari STEMI from Canada was done to, again, by the expert people who are expert in both radial and femoral, randomize them to radial versus femoral access, and primary endpoint for 30-day mortality was no different in about 2,000+ patients. And these are the individual endpoint of the reinfarction, stroke, stent thrombosis, and bark bleeding. No longer different bleeding in the good femoral operator. Now see this here, stroke. Multiple trials of the radial have shown slight tendency to have slightly higher stroke rate with the radial versus femoral, which is consistent. So, but overall showing that the radial maybe it's a class 1 indication. After Safari STEMI, will it remain class 1 or become 2A? We need to see. Then the whole concept of the door to unloading time in STEMI, concept of preloading pre-PCI. What was that? Basically, the concept was that by unloading the ventricle before you do a primary perfusion is associated with lower microvascular obstruction, and that actually has lower infarct size. Based on the translational work, they did overall in the first in human, trying to see pilot whether you do 15 minutes or 30 minutes of unloading, and was associated with a lower infarct size compared to you do unloading after reperfusion. So clearly means that if you're doing an impella or balloon pump, Do you wait 15, 30 minutes or you do it right away? Seems to be that 30 minutes is a better time. And that did a small trial, D2U Stemi, pilot trial of 50 patients. Although there was no difference in infarct size, there was slight in the delayed lower microvascular obstruction, not much difference in the myocardial salvage, but seems to be showing that there was no harm. And that led to a major trial ongoing in the United States called D2U Stemi. Trial concept is you do immediate PCI perfusion, no LV unloading. If you need to be, you can put a balloon pump or Impala later. But other group is that you put an Impala, CP, wait for 30 minutes before reperfusion. Again, this is a totally different concept of our primary PCI that open the artery soon. But in this case, all patients with the anterior STEMI are being randomized in this trial of 668 patients is on its way. We are part of the trial also. Then the National Cardiology Shock Initiative, Enhancing Cardiology Shock Care. This is started by Dr. Bill O'Neill from Detroit, and they came up with a various nicely algorithm that what you should be doing for the cardiogenic shock patient. Everybody wants to take care of the cardiogenic shock. We know that 4-5% of MI patients, STEMI, are in cardiogenic shock, but you need to have a process to treat them easily, better communication, and better results. So this basically showing early use of mechanical support, pre-PCI, particularly using Impala CP, not regular Impala, Impala CP, right heart cath, use various hemodynamic parameters, and of course, quite a bit vascular assessment, early escalation, and of course, weaning. And this actually right now has gone to about 80 plus centers, and they publish the data of 350 patients enrolled with the discharge survival of 72%. And this is a very remarkable, as you see, all the trials which have done so far have a 50-60% survival, first time 72%, but this process is ongoing. And now there are a cardiac shock center with a dedicated level of shock care and the care pathway that is required to get those extra better these outcomes. Now, at the same time, Impala, which is used commonly, I know it's available in India also, the cost is a factor, that patients with Impala, and this was the registry data, that using Impala versus balloon pump in cardiogenic shock, and this taken from the large registry of Medicare, and showed that using Impala, which is the microaxial LVAD, is associated with higher mortality and higher bleeding. You say, well, it really negate all what you are trying to do with the cardiogenic shock initiative. So basically, this was the registry data. And of course, there was more higher bleeding. Everything was bad in this registry study. But do I believe it? I personally don't, because that is where we use Impala for these cardiogenic shock patients. And now there is a randomized trial going on called Recover 4. There have been a few recovers before. And this is Impala supported PCI versus the routine care. You can use an IABP and so, and this trial is ongoing with the 400 patients. At the same time, Impala with or without supersaturated oxygen, which have been shown to be beneficial, is also ongoing by name of ISO Shock. So this still need to be seen. Fast MI, I know there was a little controversy a few minutes ago about the delayed revascularization after STEMI. We all know 12 hours is good. But what about after 12 to 48 hours? Because guidelines are 12 hours. So between 12 to 48 hours, what they did is from the fast MI, that patients about 1,000 plus 729 got the PCI between 12 to 48 hours versus 348 did not. And what did they find? At 30 days, this is the revascularization to death of 2.1. If you did not revascularize, latecomer 7.2. And these are the other individual endpoints shown here with the lower bleeding and 1 year data. So long term, again, showing this actually number is 44 per 1,000. So just to show that even late revascularization from 12 to 48 hours, latecomers, doing a revascularization is better versus non, although there is no randomized trial. And this is the central figure very nicely illustrate this concept. Then P2Y12 inhibitor choice. There are many, we all know, based on the guideline, you should be using is potent P2Y12 inhibitors of ticagrelor or prasugrel over clopidogrel and use IV cangrelor. So basically, as you remember, ISAR react, almost 40+% patients in that study were STEMI, and they compared ticagrelor versus prasugrel. We all know that prasugrel was better than ticagrelor. Now, what about giving prasugrel in the ambulance. And remember, ticagrelor in the Atlantis trial in the past 5 years ago was given in the ER and in the ambulance didn't show any benefit. But prasugrel, now they looked into this concept, giving chewable prasugrel before patient hits the come to the cath lab. And we basically showed that giving chewing the prasugrel before crushed prasugrel versus what you do regular, tested the platelet inhibition in this trial called Compare Crush, just published in Circulation, about the 400 patient, 60 milligram versus the given as a crush tablet before in the ambulance before coming versus on the table, and basically found TIMI-3 flow of the infarct-related artery, ST segment resolution at 1 hour, no difference, and also platelet reactivity. It tells you that in acute MI setting, even by giving crushed prasugrel, you still have high platelet reactivity in about 40% of cases. So it's telling you that maybe we need additional agent. Alone, the P2Y12, whether ticagrelor or prasugrel may not be good enough. Of course, crush did a little better in terms of the platelet reactivity, but overall still a lot of people have high platelet reactivity, although individual endpoints were not different and the bleeding was not different either. So clearly that giving P2Y12 inhibitors before coming to the cath lab has shown not to be beneficial in 2 trials. Then what about the Stemi, that randomized trial of ticagrelor monotherapy after 3 months versus aspirin plus ticagrelor? This is basically a trial of Tyco original, which has the acute coronary syndrome STEMI, about 1,000 patients, basically showed that after 3 months, stoppage of the DAP, continued ticagrelor monotherapy was beneficial, and of course there was no difference, and bleeding was significantly lower. So clearly that we learned that now you don't need to continue potent P2Y12 longer, and after with the combination alone are good enough, and this has been shown by Twilight in acute coronary syndrome, stable CAD, complex CAD, and now in Tyco STEMI, that after 3 months you can stop the aspirin. Then STEMI Cath Aid, improve STEMI communication. Basically, Mission Lifeline, as we know, is a system of STEMI care, risk time sensitive, and of course, Dr. Samir Mehta will talk about global, how he has done the tremendous work of getting this, the algorithm of the Mission Lifeline, that how can you initially triage the patient, an appropriate patient gets to the cath lab, and how everybody can be part of the whole process, because everyone is different. There is a ER, there is a nurses, there is a technician, there is a attendings, and so STEMI Cath Aid, developed by Dr. Keeney, my associate, aim to develop a secure app to streamline real-time communication and coordinate between STEMI care team members to reduce ischemia time and improve patients' outcome. And this actually has been a very successful STEMI early log into. Everybody can log, and there are a lot of people. You can have a video call between the doctors, the patients, and so. And this had been tested at Sinai system and now ready, is published in European Heart Journal developed a novel mobile app to optimize care of STEMI patients and facilitate electronic extraction or relevant performance metrics to improve allocation of resources and reduction of cost. And more important, get to the guideline with the STEMI app. It has been a very successful. Then Flower MI, FFR versus angio-guided PCI. So this actually is the major trial, showed that patients who have multi-vessel disease, after you've done a culprit vessel, more than 50% stenosis, should you do just PCI based on the angiogram, or you do FFR guided PCI? This was the major trial to answer that question. We know that FFR is very useful in stable CAD, but what about in patients with acute coronary syndrome, more so for the STEMI? This was about 1,000 patient trial, angio-guided PCI 581, FFR guided 590. And you see that FFR guided, the angio-guided PCI 97% had more than one PCI, compared to 66.2 had only one. And overall, as you can see, there was no difference in angio-guided PCI versus FFR guided, but better outcome with the angio-guided with individual endpoints as here. So you actually have a little lower revascularization, slightly lower myocardial infarction in the angio-guided PCI with overall MACE, and the decreased hospitalization. And why that happened? Because in the FFR arm, the patients who got a PCI, they did good, just like angio-guided PCI. But who were deferred, no PCI, they had a 8% event rate. So it seems to be that FFR is not needed or does not work in STEMI setting. You based on the angiogram, And that is where the major trial, complete trial, did show that they did not use the FFR. So this actually may need requirement some change of the guideline, where they have put that in even with a STEMI patient, FFR less than 0.8 should be used, but it looks like angiography is good enough. Then culprit shock. There are two concepts, complete versus culprit vessel PCI and the culprit or patient with a STEMI. We know the culprit shock trial, the patients, whether you have we were told many years ago, do all the vessels in shock. But culprit shock basically showed that by doing the culprit versus full revascularization. So if we can see immediate multi-vessel versus a culprit vessel, there was a difference in favor of culprit vessel only, or as well as the all-cause mortality or renal replacement at 1 year. Favored only culprit vessel PCI, not the full. And of course, the benefit only, the difference was only at first month. After that was identical curves. And these are the individual endpoints basically showing that doing the culprit vessel was harmful compared to the, multi-vessel PCI was harmful compared to culprit vessel. And this is the data from the trial. But if we go with the Cardiology Shock initiative, when they have a multi-vessel PCI versus culprit vessel PCI, in that group, there was no difference. So this field still remains, which leads to the important, I would say, development in last 2 years, clear establishment of the complete versus culprit vessel PCI in STEMI with the PREMI, culprit, PRIMLUTI, and they changed the guideline from 3 to 2B. And now with a major trial of complete 4,000 patients, complete revascularization versus culprit done from Canada and multiple centers, and also in the complete, whether you do it at time or you do it about 3 weeks later, overall showed that culprit revascularization was achieved in majority of the patient and it was beneficial. You see culprit vessel, event rate 2.7, this is a death or MI versus 3.7 in ischemia, of course, additional benefit of the complete revascularization. So seems to be in STEMI patient, complete revascularization better. In cardiogenic shock, only culprit vessel revascularization better. Now then question comes, should you do it same time or you wait 3 weeks? And it turns out to be that whether you do same time or 3 weeks, benefit remains of the complete revascularization over culprit. So there are few trials ongoing in this field. One is the iModern trial, that is the IFR guided versus CMR guided. Second one is full Revask trial in Sweden. There will be FFR guided versus angiography guided, same flower MI trial. So many will hear more about this complete revascularization concept. And this has led to the guideline point of view that for complete revascularization STEMI 1A and in the non-STEM, in the cardiogenic shock, complete revascularization is 3B. So putting together, these are the top 10 advances in my opinion in the last 2 years. And of course, this will lead to change of the guidelines, which are very waiting. American guidelines are still not there. So I'll complete here basically my central illustration, put things together. Non-culprit PCI, cardiogenic shock, no good. Pre-PCI, P2Y12 inhibitors, radial STEMI, FFR guided PCI, no good. Impala in cardiogenic shock, and National Cardiogenic Shock Initiative, door to unload time, plus minus. This still data need to be seen. Low dose colchicine, National Cardiogenic Shock Initiative, delayed STEMI PCI, thumbs up. STEMI catheter app communication, 2 thumbs up. And biggest is the complete revascularization STEMI, initial or stage is multiple thumbs up. We will change it to a class 1 guideline to become a better interventionist. And last slide, I just want to put it together. This is data from United States that where we are, CABG versus PCI. You can see here, this is on the top is the STEMI. STEMI mortality has gone from 4.9 to 5.3, which is a trend a little worse. Question comes is why? I think it is an evolution. These are data from 2016. We have learned quite a bit since then. In my opinion, in that new data may say that STEMI mortality is going down, STEMI PCI mortality going down rather than going up. And with that note, I'll stop here and thank you very much.
Thank you, Dr. Samin Sharma, for giving us an excellent overview of the recent literature on STEMI. Before I open up for discussion, I have one question for you. That is said that except for cardiogenic shock, if you have to reduce the mortality in STEMI now, you have to look at the reperfusion injury, because 40% of the reperfusion injury is contributing to the myocardial damage. And we have conquered almost all 60% which could be conquered. And there are little tricks and tips like radial versus femoral. So are there anything being worked on that area, reperfusion injury, which will really make a difference now to the STEMI care?
Yeah, very good point. So question comes, you know that many of the trials have been done, anti-inflammatory, cyclosporin. So far, nothing has worked for the reperfusion injury. This is a very important topic. So question comes, the supersaturated oxygen, probably working on basis of decreasing reperfusion injury is the only one which have made finish the time to the finish line. Everything else we have tried at least a dozen agents for the reperfusion injury, all have failed. So I think it just comes down to the better optimal interventional technique, whether this unloading will help because of decreasing microvascular obstruction, which is also kind of a the modified, I would say, reperfusion will be beneficial, need to be seen. But these guys who are doing it, they're very, I would say, strong about that this is going to work. That before doing your anterior wall large MI, you unload the ventricle before you open it. So that again translates to a lower into reperfusion. But as such, the devices or drugs which have been tried for reperfusion, we have 12 of them, all have failed so far.
Thank you.
Unfortunately.
Thank you. I think anyone has a question from...
Can I ask a question?
Sure. Yes.
Suman, a wonderful presentation as usual. I just want to ask you, apart from the door to balloon time and the TIMI-3 flow achieved in acute myocardial infarction revascularization, are there any other predictors of LV recovery? Because I see a lot of variability in the recovery of the left ventricular myocardium. Even if you achieve some patients TIMI-3, they don't recover versus some people recover. So are there any other criteria?
Beautiful. That's a very good point. And actually, there are 4 papers now in the last 5 years which have come, is the pain to balloon time. So basically, door is the patient came in. So patient may waited 1 hour, patient may have waited 3 hours before coming in. So if we take it to the pain to balloon time as a very consistently improvement in the ejection fraction. So I think it's a and that goes where same, putting the system together. So making the education, educating the society and our caregivers to decrease that, and particularly the patients that don't wait at home while it's a gas pain and get your family member to bring you to the emergency room, call for the ambulance and come quickly. So once we decrease the pain to balloon time, that I would say will be more consistent benefit of that door to balloon time. Because it is in the door to balloon time variability is how long the patient had a pain before coming in. And that is a very important factor which has come up now. And that actually associated with improvement in ejection fraction consistently. So if you waited 1 hour, better ejection fraction versus you waited 3 hours.
Rightly said, because ESC now has taken away the door to balloon time from their guidelines. I think they no more talk about door to balloon time.
Now, Dr. Bahal, can I ask one question?
Yes, sure, sir.
Okay, now, Dr. Sharma, one question to you, that during this pandemic time, we all know there is a very difficult process to perform primary PCI at every center. So how do you compare the pharmacoinvasive therapy with the primary PCI?
Yeah, so I think the very good point, and I would say that during early pandemic, everybody was concerned, so that the guidelines came because everybody was concerned to bring the patient to the cath lab, and at the same time, then trouble happened. Now it's a viable patient. You give, we know that thrombolytic works in 60, 70%, 30% still got to your, still you have to deal with it. So that based on the guideline, I would say that best treatment, even in the pandemic time, is that you do the PCI, primary PCI with a proper precautions, proper PPE and team taking care, and try to do everything at one point. So, and try to avoid try to avoid putting a balloon pump and other things which are left outside the lab. So key is that still do the primary PCI with the adequate care is the one final guideline came last May, June from the Society of Coronary Angiography, because that turns out to be, we actually were criticized when March, April, we didn't bring few patients and they detuned, and then we had to now bring them back because they're a viable patient and in this time period. Now, if somebody has true COVID and develop MI, that's where the question comes. I think then whether you should bring that patient to the cath lab or not, it depends on what is the overall prognosis of that patient is. If we think that prognosis is bad because PO2 is a 60 patient is a bad lung thing, maybe that patient can be managed medically in the ICU with a thrombolytic and not bring to the cath lab and expose more people and more healthcare givers to the COVID. So COVID, little different, but non-COVID, but in the COVID time, it still should be done as a regular, the PP, our primary PCI with the adequate precaution.
Thank you, Dr. Sharma. Now I think we'll go on to the next stop, and I'll introduce you to Dr. Sameer Mehta. He's called a Stemi cardiologist, and rightly so. And he's chairperson of Lumen Foundation and Lumen Global. I think his achievements are unique. No one in the world has done as much as he has done for the STEMI care in all over the place. You go to any remote country in the world and he has established the STEMI programs there. So he has a unique achievement, and I think he's going to talk on those global STEMI guidelines or STEMI care, which he's advocated all over for many years. So Dr. Sameer Mehta, the stage is yours. Dr. Sameer Mehta, you are muted, sir. Sir, you are muted. Please unmute yourself. Yes.
Dr. Bell, thank you so much for your most kind introduction. Do you see my slides?
Yes, we can.
All right. It's always a pleasure speaking to a meeting in New Delhi, that being my home in Punjabi Bagh. And of course, this particular meeting, being so many of you from the All India Institute, that is where I had started my journey. And that was creating the Delhi protocol with Dr. Balram Bhargav. And that was, I just remember today, 20 years ago. And the journey has continued for me. And I would like to also congratulate Dr. Bhandari, Dr. Yadav, and Dr. Naik for creating a wonderful meeting with outstanding speakers and a most relevant agenda. So my introduction here of the topic is straightforward. You are already practicing telemedicine. You know, whether it is the use of sending EKGs on a WhatsApp or using very sophisticated Internet of Things protocols, telemedicine is already there. Now, of course, my purpose of sharing the work which I have been doing over the last 10 years in telemedicine will be to make it relevant to India. Because if that is, I fail to do that, then no matter whatever has been done outside would not truly be relevant. So everything I'll be talking to you, I'll try my best and relate it to what could be done in India as you make your system optimal. And this has been my consistent message. Dr. Bell so kindly mentioned about my work in many poor countries. I have always maintained that the real critical determinant of STEMI systems of care is having system-wide ambulance care, and a lot of progress has been made in India. Still much needs to be done, and I think till that is achieved, you may be able to use telemedicine in numerous ways. So here is the, from 2 weeks ago, editorial Dr. Cindy Grimes and I wrote about, which basically is what Dr. Sharma just talked about. You know, so much has been done, so much further needs to be done. And what exactly needs to be done? I'll give you a straightforward analysis of that. The focus needs to be changed from door to balloon to symptom to balloon time. And that is the essence. And of course, that's where I think artificial intelligence and telemedicine will help you. This is also another publication from a few weeks ago. This is our work on providing a telemedicine umbrella in 5 countries to 100 million lives. Why do I emphasize this particular paper? Because that is precisely what you have to do for 1 billion people in India. And let's try to show you how telemedicine may be able to provide some answers here. This has been a privilege to work and create STEMI network in so many countries. And once again, let us see if you can understand and we can benefit from these disparities. So this is a work which I had done several years ago. We mapped out the entire world and we realized that STEMI care works in various levels. And if you pan out this whole across the world, you realize disparities are clear. Disparities are clear in whatever resources are available. Disparities are clear in what is being achieved. And if you take a look at it, all the countries, they need to be moving to a level 4. Some are moving fast, some are moving slow. All I can tell you is, including from the experience in China, where I helped create the nationwide STEMI program there, it is at the heart of it, ambulance care, which will take you there fastest. Now, this was another very remarkable paper we wrote. And as I mentioned to you, I'll try to relate everything to India. And we realized there were numerous barriers in India, barriers related to the patient, insurance and the payment, transportation, hospital, physician, and technology related. And some of these can be overcome by telemedicine. Now, these are the disparity. This is not a Photoshop. This is from Sao Paulo, where the program which I'm going to talk about started. And watch the disparities, what you have, the amazing development on the right side and the tragic situation with the poor people on the left. How do you reduce these barriers? This is one of our formative papers on this, A Tale of Two Cities, STEMI Interventions in Developed and Developing Countries and the Potential of Telemedicine to Reduce Disparities in Care. So this is the essence of our systems of care help with telemedicine, which has been my consistent recommendation for various parts of India. This is basically, there are two purposes. You make an immediate diagnosis of STEMI with almost 100% accuracy by remote experts, and then you guide the patient with teleconsultation along the way. There is a hub and spoke structure. You can make it all sorts of different morphologies. These are the methodologies which the patients are being guided through telemedicine, whether there should be thrombolysis, pharmacoinvasive management, primary PCI. Just now the question was asked, I think, by Dr. Banerjee, how exactly is this being occurring in the pandemic? Once again, all this can be guided by telemedicine. This is the specific methodology, how we created a very effective telemedicine program, which I will share with you in my next two slides. This is the publication recently from the Sky Journal, 100 million patients covered in Colombia, Brazil, Mexico, Argentina, and Chile. And all of this being created and helped with telemedicine, more than 1 million patients treated. And this is the way how it is done. Exactly the same thing done in the last 5 countries. This is what I call a navigational path. Every hub, every spoke, there are 275 centers. We know exactly what it is able to do. Is it able to perform PCI with 24/7 door-to-balloon capability? How much is the distance from the spoke? What are the thrombolytics available? What are the personnel available? Is there availability of telemedicine structure? And what can be the ambulance pathways which they are being following? Ambulance pathways being either unidirectional, in which from the spoke the patient goes, or there is a bidirectional, which is actually worse, because which means the ambulance is sent from the hub to the spoke and spoke back to the hub, which is sadly happening in several centers in India also. And of course, the last part is a centralized, which of course needs to be the goal. This is also the economic forecasting which we did of the Latin program over the last 10 years. So we realize here, not only are you saving lives, when it's this case turns out to be almost 26,000 lives which can be saved at a saving of $287 million. So the methodology is clear. This is also some of the messages which I have been relating to the healthcare providers, even politicians, the healthcare economists in various developing countries, who are always worried that it costs more to create cath labs. No, it doesn't. You provide this infrastructure, and in the long term, you save both lives and money. So, as I mentioned before, this is telemedicine, all the lessons gained from the Latin telemedicine program with its 100 million program. and now created as the Rahat program, now being initiated. It's in fact ongoing for the last 4 years in Rajasthan with the command center located at Samin's hospital, at Eternal Hospital. They've been making tons of progress. I'm sure you have been kept abreast of it, and several people will be referring to it. Precisely the lessons which I learned with the Latin program, in fact, made even more cost effective. And again, you have to realize that not every aspect of it. In the Latin program, we are dealing primarily with primary PCI, with almost 76% of the patients referred for primary PCI, whereas the model with the Rahat, I think there is a far greater penetration, as of course it is required in India with pharmaco-invasive management, but it is even a more effective program than the Latin telemedicine. With this information on telemedicine, I think it's time to move to the last frontier, which was talked about by Dr. Sharma ahead of my lecture, where he mentioned the pain to balloon. This is exactly the same thing, symptom to balloon time. And also just picking up on one of the questions which had been asked by Dr. Claire, in the clinical parameters, I have stopped worrying about TIMI-3 flow over the last many years, and we look at the myocardial perfusion grade, which I think is a far bigger determinant of short and long-term mortality. So what about the final STEMI frontier, the symptom to balloon time? What exactly could you be done? And whenever I talk about the biggest challenges in STEMI interventions, this is the hardest, because this requires not only improving your systems of care, it involves improving and educating the patient, which is by far the hardest job. And particularly, you have to realize that the elderly patient have confusing symptoms. Women have very atypical symptoms. Diabetics will probably have no symptoms. So to educate the patient is the hardest, yet this is precisely where technology may come in, and it may provide you work, and the answer may be coming through artificial intelligence. Now, this is an area I have been working over the last at least 5 years, and this is a recent book which I have written on it. Some of you may find it useful, and it has particular relevance of applying artificial intelligence-based parameters. So through artificial intelligence and having a database of almost 27 million classified EKGs, we've been able to create a single lead EKG device, which single lead? Here is the answer for that. V2 is the one with the highest accuracy, and this can be converted into one of the various devices. You could have a patch which could be put on the chest. You could have a ring which can be brought to the chest in the V2 area. You could even use the Apple Watch, which we have been experimenting. At the moment, we have a class 1A classification in Europe, and we are looking at doing further work and getting the approval from the FDA. The purpose here is straightforward. You're giving a tool now to the patient for a self-administered, self-diagnosed, using all the power of artificial intelligence, so that you can make a difference in what I term as the final parameter, which is, of course, being the symptom to balloon time, and having a possibility of making a difference in that. So, Mr. Chairman, in conclusion, I think when you look at the global care, you have to understand that there are massive disparities globally. There are disparities mainly in having an availability of a systems of care. There are disparities in the ambulance structure, which, as I have emphasized before, remains the most cardinal feature of STEMI care. I think telemedicine, as we have shown both in the Latin telemedicine program, providing an umbrella of protection to 100 million patients, and the Rahat STEMI telemedicine program in Rajasthan, this may be one of the ways for you to look at it and explore some of the ways how you can create a cost-effective methodology to eliminate the disparities of care. I continue to believe, as of course the guidelines are showing, we need to move to a symptom to balloon management, and there may be tools, as I have tried to demonstrate to you, using artificial intelligence to create a single lead strategy using multiple modalities, how that can be used for a patient's self-administered STEMI detection, making a final dent in symptom to balloon time. I stop here, and I am, of course, delighted to answer any questions, Dr. Bell.
Thank you, Dr. Samir Mehta. Your work is exceptional, which comes out well in your excellent presentations. I don't have a question, but I query based on pathophysiology. When we talk of myocardial salvage, it is the first 3 hours from the symptoms. We can stretch it maybe to 4 or maybe to 6 hours from the symptoms, when you can salvage the myocardium by giving either thrombolysis or primary angioplasty. After 6 hours or after 3 hours, even if you open the arteries, you may not be able to salvage. There will be other benefits. And that's why after 6 hours or 3 hours, it is recommended pathophysiologically that you should do a primary PCI. You have talked much about thrombolysis or so-called pharmacoinvasive, which is in fact is, if you are not doing rescue angioplasty, is a delayed angioplasty in everyone after he receives the thrombolysis. In India and other, I don't know about the other poor countries, but India hardly patient presents in a hospital to receive even a thrombolysis within 3 hours of his symptoms. In that situation, or suppose he presents after 6 hours, in that situation, will you still recommend a thrombolysis, or will you recommend him to be transferred to a center where primary angioplasty can be done, and which can be done in many parts of the India now? In many small towns also, the cath labs are available. This is just a query, not a question.
Yeah, look, I'll tell you, philosophically, I have completely believed in 21 years of doing STEMI only practice. If it is possible, move the patient to the cardiac cath lab, even at 6 hours. Now, there are some other very important lessons which you need to understand about from the telemedicine program, the Latin telemedicine. When we started this program in the first city of Barranquilla in Colombia, 78% of the patients were transporting themselves to the hospital. Following this, 82% of the patients were coming by ambulance. Why am I mentioning that, and how exactly does it relate to your question? You have to have a fundamental belief and work consistently, and that's precisely where the CSI comes in having an absolute belief that you will try to create primary PCI structure within India wherever it is possible. And therein I continue to firmly believe, and that is what I keep endorsing, the more you are able to build the infrastructure based on ambulance care, that is how you're able to move the patient faster. That is where the 6 hour will get converted into 5, into 4, into 3. And that is what I would recommend. I think you need to stay away from the feeling of having an ambiguous management. I think a very clear determination has to be made, a clear strategy that you will try to convert as many of these into primary PCI possibilities. And that probably is the best underlying message I can give you.
I think thank you for the answer, because most of the time when we are talking of so-called poor countries or developing countries, we are started talking of so-called pharmaco-invasive therapy, which I believe in the same countries, because the patient present late, usually will not work, and the primary angioplasty, as you yourself said from your experience, is the answer to most of the things. I think we'll open your session to any questions which any of the chairman or any audience have. Any questions?
Well, if I
yes,
can I ask a question?
Sure, definitely. Go ahead.
First of all, great talk, Samir. Excellent talk. You see, showing individual expertise in the lab is one thing, but extending benefits of medicine to millions of people is, I think, very, very remarkable. That is something very, very impressive in your thinking about the STEMI therapy. I don't know whether somehow the other, the CSI or somebody else can involve you with our Prime Minister, and some kind of a STEMI program can be established for the India. If not India, at least I would like your help to start some kind of this program in Punjab. We'll name it Sada Dil Bachao Samir Mehta, something like that. Am I right, Samir?
Look, Dr. Clare, I'll that wonderful recognition aside, let us, because you raise a very important point. I look both at some of my best work was done actually in Puerto Rico, a program known as PRINCE, Puerto Rico Infarct Nationwide Collaborative Experience, where we networked the whole island of 4.4 million. And immediately after that, I came and wrote the Delhi protocol with the Balram Bhargav, as I had mentioned. And you are absolutely right. This can be done in every, STEMI is basically a local issue. It's not, you cannot generalize it. Each city, each region, each state has its own challenges, but it can be done. The pathway is exactly the same. You are basically moving the patient as fast as you can into a primary PCI institution. Now, Punjab, as an example, my rough estimate would be there would be at least 50 PCI centers. I mean, look, I've been in touch with Dr. Wonder for the last 2 decades. I know of some of. So you've got this infrastructure there. You simply need to create a highly effective structure how patients can be moved reliably, predictably, and 24/7. And that is precisely where you can use all the various aspects of telemedicine to guide you as you're developing this the system of the ambulances.
I think now there are, Samir, in Punjab, I can tell you there are at least 250 cath labs.
Right.
And the cath labs have reached not only a district level, but at a smaller towns. But challenges are kind of different, patient education, people education. In India, one of the biggest enemy of STEMI program is the concept that Indian think everything, when they get chest pain, it is because of the gas. Gas has gone into the head of Indians, and that is causing a lot of issues. Patients don't come in time, they go on to popping antacid, and I've seen many doctors doing the same thing, with myocardial infarction, and they don't understand that it is the time which matters, the time is the muscle, so they don't take help in time. Actually, many patients go on, doing daily diary. I think
so. Yeah, I think we because the time is short. I think if there are any questions, we'll either we have to move on to the next session because we are already running late. So I think you rightly said that we have to educate the patient. Government is doing its bit as is evident from Ayushman Bharat, and even in AIMS, every STEMI is done free of cost, and that is true in many states. So I think patient education is the key, as you rightly said. So we move on to our next topic. Whenever we are using antiplatelets and antithrombotics, we have to balance between a bleeding and ischemia. And we have with us Dr. Farah Bruno, who is co-director of Interventional Cardiovascular Group at Clinique Pasteur, Toulouse, France. He is a very highly motivated clinical researcher and has many active involvement in the research work in this area, and he'll be speaking an update on ACS in high bleeding risk patients. Stage is yours, Dr. Farah.
Okay, I hope that you can hear me clearly. Yes, it's okay?
Yes.
Yeah. So
your slides are not still there.
Okay, perfect. So I hope that you have my slide.
No,
okay.
We don't have your slides
okay.
still.
Sorry, I have to
share it.
Okay, sorry for that. I come back to the, sorry. I don't know why it stopped, so, okay,
yes,
sorry. So first of all, I want to thank the organization committee for their kind invitation. I'm very pleased and honored to be part of this session. Let me try now to, okay, let's see where you are. Okay, sorry. Okay, this is me. Sorry, I prepare everything, but I don't know why it's closed. Now I'm ready. Okay, do you have the slide for the moment?
All set, make it.
Okay, all set. Thank you very much, and sorry for the delay. So the topic today is quite large, is the art of balancing ischemic and bleeding risk and in ACS patient. I will mainly focus on pharmacotherapy. Regarding DRPT treatment, post-acute coronary syndromes, when we have to define this DRPT, we have to consider first, what is the bleeding risk of the patient? Second, what is the patient risk, clinical presentation? And finally, what is the type of complexity of the PCI? And obviously, DRPT treatment requires an individual approach that can be also modified during follow-up. So the next step is now to define what is a high bleeding risk patient. Since 2019, a consensus document published in the European Journal has defined major and minor criteria that are listed on the slide. These criteria help us to define in clinical practice what is the better characteristic of the patient risk profile regarding the bleeding risk. And it's very important for the stratification of the patient. In our clinical practice, we can easily define two characteristics of patient. The patient at high bleeding risk that will require a lighter DRPT strategy using aspirin or clopidogrel for a shorter duration, 3 to 6 months in high bleeding risk patient, and even only 1 month in very high bleeding risk patient. On the opposite, you have patients with high ischemic risk, like diabetic patient, Stemi patient, multivessel disease, complex PCI, that will require a guideline strategy that is aspirin combined with a new P2Y blockers for 1 year. This is an example, 84 years old female, diabetic patient treated for AFib with vitamin K antagonist, who was referred for inferolateral Stemi, and he has a complex 3-vessel calcified disease with critical lesion on the right CA and on the left circumflex. These patients have been treated with multiple DS on the left circumflex first and then on the RC. So for this specific patient, what could be the DRPT strategy? When we look at this DRPT strategy, for sure, the discharge strategy will require a triple therapy, but with only aspirin and clopidogrel for only 1 month. And at 1 month, we will stop the aspirin, so the patient will remain only under clopidogrel and oral anticoagulant. This is clearly related to the very high bleeding risk patient profile and also high ischemic risk profile. So clearly we know when we have to, in clinical practice, we know what to do for a high bleeding risk patient. Is first to use clopidogrel instead of the new P2Y12 blockers, and second, to use a shorter duration of DRPT, 3 to 6 months in high bleeding risk patient, and only 1 month in very high bleeding risk patient. So considering the different clinical profile of the patient, we have 2 options: to do less, as for patients with high bleeding risk, using aspirin and clopidogrel for a shorter duration, and we can do the standard post-ACS treatment using aspirin and the new P2Y blockers, ticagrelor or protogrelor. But maybe there is a possibility to use an intermediate strategy in order to limit the side effects or to reduce bleeding complications. So what's the concept of de-escalation? We know with the new P2Y12 blocker that we have some ischemic benefits, mainly in the early phase, that is during the first months. However, we may face some bleeding complications during the chronic phase, especially after the 3 first months. Different trials have explored the de-escalation strategy, and I will, with different design, and I will try to summarize them. What are the evidence of this de-escalation strategy? So, first of all, you have the TOPIC and the TALOS study. It was single and multi-standard study. There was a systematic switch at 30 days in all the patients to aspirin and clopidogrel versus aspirin or prasugrel and ticagrelor. These 2 trials have demonstrated a reduction of bleeding with no difference in terms of MACE. Tropical ACS, it's different design. It was a switch at only 7 days, and the switch to clopidogrel was guided by the platelet factor function. So it was performed only in 61% of the patients. This trial showed no reduction in terms of bleeding and no difference in terms of MACE. Popular age, also quite rapid, quick switch at 3 days after the recurrent acute coronary syndromes. The de-escalation strategy was systematic for all the people with old age. And as you can see, in this trial, there was a reduction in terms of bleeding but no direct difference in terms of MACE. And finally, popular genetics, also a quite quick switch. It was related to the genetic configuration of the patient. This switch was performed in only 61% of the patient, and there was reduction of the bleeding with no difference for MACE. So how we can summarize all this trial? We can say that there is quite a safety of de-escalation strategy. In all of this trial, there was no indication that this de-escalation strategy induce an augmentation, an elevation of the ischemic complication. There can be some potential benefit in terms of reduction of bleeding. Should it be performed routinely or selectively, and how to guide the escalation? I will say that I will prefer patient characteristics than genotyping or platelet testing, because for me, it's quite easier and cheaper, and it's more clinically relevant. So why this is important? This supports the context of a new DRPT strategy for selected ACS patients. Starting with a powerful DRPT strategy, we can be switched after a certain time, 1 month, 2 months, or 3 months, for a lighter DRPT strategy using only aspirin and clopidogrel. And also, this strategy could integrate some dynamic risks post-ACS. That means if the patient develops at any moment any side effects or bleeding complication, we can switch after 1 month safely the DRPT using aspirin and potent P2 regulator to a strategy using aspirin and clopidogrel. So regarding the de-escalation strategy, we say that there was 2 options. How to integrate that in daily practice? This could be a de-escalation induced during follow-up due to the side effect. The patient has some dyspnea and bleeding. That means that from the beginning, we decide a potent DRPT strategy, but due to side effect, we move to a lighter DRPT strategy. Or it could be de-escalation plan a priori. The decision is performed at discharge, and this is done in prevention of side effects. What are the potential advantages of DRPT de-escalation? It could reduce cost, it could prevent bleeding complication, it could reduce side effects, especially dyspnea with ticagrelor. It could allow some invasive procedure earlier, and it could also improve adherence due to the reduction of side effects. Sorry, I don't know why it will not advance. Sorry, I have a... Okay.
No, you should take it.
So let's see now an example. 71 years old male, prior gastrointestinal bleeding. He was referred from non-Stemi. It's a diabetic with multiple stents. So it's a high bleeding risk, and normally this patient should be treated by clopidogrel. But however, it's also an high ischemic risk patient, and for sure, the indication is to use prasugrel and ticagrelor. So for this patient, we can anticipate that we can use a de-escalation strategy, a compromise, with an early potent DRPT using aspirin and ticagrelor or prasugrel, and after 1 month to switch ticagrelor or prasugrel for clopidogrel. So for this patient, you see that using the same diagram than the previous patient, the discharge strategy a priori is quite different. It's a high bleeding risk patient, but not very high bleeding risk. Yeah, ischemic profile. So we will use a standard DRPT, but very short for 1 month. And then after 1 month, we will switch to clopidogrel. So coming back to our possible strategy after DRPT, we still have the high bleeding risk, which will require a lighter DRPT strategy using aspirin or clopidogrel for a duration of less than 1 year, 3 to 6 months in high bleeding risk and 1 month in very high bleeding risk, especially the patient with oral anticoagulation therapy. We have the patient with high ischemic risk that will use a guideline strategy with prasugrel and ticagrelor and no switch at 1 month. And we have the patient that combine high risk for bleeding and high risk for ischemia that we can consider de-escalation, that to switch P2Y12 blocker at 1 month or even a little bit later on. And also we have the patient who develop side effects, who are very high ischemic risk, but develop some side effect during follow-up, and we can switch them quite safely to a de-escalation strategy at any time after the first month. So in conclusion, when we consider the art of balancing ischemic and bleeding risk in acute coronary syndromes, we need to use an individualized approach based on patient profile and PCI profile. We know that there is a standard approach using aspirin and the new P2Y12 blocker, but there could be some variation. We know from a long time that there is a strong impact of oral anticoagulant therapy background. And we now know that we can consider the escalation of DAPT post-ACS in number of patients. Thank you for your attention.
Thank you, Dr. Bruno, for giving us an excellent overview on the topic. I think we are able to afford a shorter duration of DAPT because of the availability of newer generation stents with the thinner stents. We would not have talked about this topic maybe 2 decades ago when the thrombosis was the flavor of the day and we were thinking how to prevent the thrombosis. So a line of caution, or where in the countries where we are not using the so-called latest generation of stents with the thinner stents, these strategies should be carefully reevaluated, whether you should stop DAPT at 1 month or maybe 1 week, but they are advocating before you indulge into these type of risk scoring systems. Because what we don't talk is the availability and use of a newer generation stent with the thinner stents if we have to use it in high bleeding risk patients. Any comments, Dr. Bruno?
No, I fully agree. Yeah, we know that the newer stents have a better profile. You are talking about the thinner struts. There is also the free polymer stents with maybe less, anti-thrombotic reaction. So effectively, there is some advancement in the new generation of stent in terms of prevention of stent thrombosis. There is also the improvement of the apposition of the stent, the systematic post-dilatation strategy with using non-compliant balloon. So we have learned a lot from the first experience with the first generation of the DES, and we are moving to safer stent, safer strategy, and we have also safer, drugs that we can adapt sometimes. That's the concept of de-escalation strategy. We know that probably we need to use very potent agent for the first month, but thereafter, maybe we can move to a lighter strategy.
Great. I think if there are any questions from
Dr. Bahel, I have one question.
Yes, sure. Go ahead, Dr.
Bruno, as he has nicely said about the high bleeding risk, where after 1 month of the high potent P2Y2 inhibitor and aspirin, he has advised to combine aspirin and clopidogrel. The point is, we don't know how many patients are clopidogrel resistant in that period of the time. So how is going to address that issue of clopidogrel resistance after 1 month of therapy of the P2Y2 inhibitor and aspirin?
Well, in our country, in our institution, we are not addressing the clopidogrel resistance, and we don't feel that we have so much case of stent thrombosis. So effectively, this is always the case. We have always the fear of clopidogrel resistance. I think that in my clinical practice, what I think is very important is first to explain and to have the adherence of the patient to the treatment, because most of the time, clopidogrel resistance is in fact a problem of adherence to the treatment. The patient is not perfectly complying to the treatment. And second, I think that, it could happen. The different trial that test the platelet function reactivity and the modification of the platelet treatment regarding of the results were not fully convincing for me.
I think as you rightly said, the answer came from popular genetic trial that you can do it at the point of care test for the clopidogrel and then switch over to clopidogrel, and the other group was a ticagrelor, as you mentioned in one of your trials. I think thanks a lot, Dr. Bruno, for giving us an overview. So we move on to our next topic, and our speaker is Dr. Nick West. He has done a lot of research work on vascular biology at University of Oxford and Duke University, which led to him being awarded with Sir Leon Whitby Medal and Sir Walter Brown Prize at University of Cambridge, has published many peer-reviewed articles on the same subject. He co-founded and was a chief medical officer of Cambridge-based biotechnology startup company called PlaqueTech. And presently, he is the chief medical officer and divisional president of global medical affairs at Abbott Vascular. And he is, I think, the most apt person to tell us about the emerging landscape of interventional cardiology. The stage is yours, Dr. Nick West.
Thank you very much indeed. And thank you very much indeed for inviting me to talk at this meeting. I hope you can see my slides.
Yes, we can.
Thank you very much indeed. And thank you for that introduction. It's great to be in such august company, and I've listened to the previous presentations with a lot of interest. And I think there'll be some resonances with Dr. Samir Mehta and Dr. Bruno Farah's presentations that I'll touch on. Now, I feel like I should be saying like Monty Python, and now for something completely different, because this is going to be a presentation without lots of clinical trial data, but I'm going to give you maybe a peek into the future of what interventional cardiology might look like, and reference indeed some of the things that we have been working on and are working on and why we're doing that. So first of all, obviously my disclosures are that I'm the Chief Medical Officer of Abbott's Vascular Division, although I was previously an interventional cardiologist, as you pointed out, at the Royal Papworth Hospital at the University of Cambridge. So if I can just start with a fairly bold statement, which is within 20 years, I think physicians and patients will trust data, algorithms, and machines to determine their treatments. Patient follow-up will be 90% remote, driven by telemedicine, wearables, and external partners, and possibly even the changes since COVID. And overall, the healthcare ecosystem will be hardly recognizable from what we're seeing today. And I think the very fact that we are talking about personalizing healthcare, as we've heard with high bleeding risk, and talking about machine learning, these are things that wouldn't have had any podium space on interventional cardiology meetings maybe 5 years ago. So why do I and why do Abbott believe that information and technology are so important? Well, some of our viewpoint on this has been informed by a large global survey we undertook before the COVID pandemic started. And we interviewed nearly 1,500 physicians, administrators, and patients with vascular disease and asked them how did they think cardiovascular treatments in general could be improved via novel technologies and improved data visibility. Now, I'm not going to go through all of the details, but I do want to hit on some of the major resonant points in that survey. As you can see, it was a truly global survey and it covered lots and lots of different geographies and healthcare systems. But in actual fact, the interesting thing is there were many consistencies in the answers. And if I sum up all of the data from 1,500 interviews, I'll boil it down to 3 important points. Now, some of these you will know already, but it's good to have them restated. First of all, patients are frustrated by the care they're receiving. Patients understand, I mean, and this may be a surprise, the concept of personalized and individualized healthcare. They understand whether or not they call it precision medicine, but they understand that they want something that is tailored to their particular situation. So they don't want to be treated just like, I've got a myocardial infarction, this is the pathway, these are the drugs I get. They want their treatment to be tailored to perhaps their particular risk factors, what time it is they arrive. We talked a bit about that in the earlier presentation. What is the right therapy for them? Was the result appropriate for their narrowings? What's the post-treatment care going to be? It needs to be truly individualized right the way across the care continuum, from diagnosis, treatment, and beyond. Physicians similarly lament the lack of time they have to spend with patients, and also critically, they lack visibility into the critical factors of patient adherence to treatment and lifestyle changes and other things that influence not only the quality of care, but also the success of interventions. Thinking about primary angioplasty for Stemi, if we can't be sure patients don't take their drugs, there's no way of knowing that that intervention, no matter how good it was, is going to be durable. And thirdly, diagnostic and data-driven technology potentially holds the promise to move the kind of care which is focused solely on doing a great job at the intervention to thinking much more about the whole patient. So thinking about improving the accuracy of a timely diagnosis, using the right treatment as required, and then evidence-based tailored post-procedural care. So personalized healthcare seen by patients doesn't necessarily mean quite what we believe. They do want more face-to-face interaction with their doctors. They want to be involved in the decision-making. They do want an individualized treatment plan, and they want something that is generally lacking worldwide, which is seamless information sharing. As you will know, many patients have very staccato, intermittent interactions with healthcare professionals without anyone really joining up the dots over individual patients' care. And interestingly, and this survey was done before COVID, they want the ability for their doctor to be able to monitor them remotely. Now, in terms of technologies, what do patients think? And again, this may be a surprise. Most of them feel that technology can help their doctor either understand when intervention is required, to supplement their physician's experience, or understand better their condition. And you can see the majority also wanted active involvement in their decision-making about the kind of treatments they receive. So what kind of technologies are we talking about here? So when we spoke to administrators and physicians, and physician responses are shown in the teal bubbles at the top of this graphic, and administrator responses at the bottom. And as you can see, as we go from left to right, these are the various stages, going from prior diagnosis, at diagnosis, when determining the treatment, during the intervention, and then at follow-up. And you can see that physicians and administrators really believe that technology has less of an impact during the follow-up period. Now that may be different now we're in the peri and post-COVID era, but the major impact is at diagnosis and when determining treatment. So that's where technology can be really, really helpful. So what are those tools? Well, more than half of physicians felt that imaging tools to enable more accurate interventions and appropriate interventions were important. And you can see that monitoring tools, importantly, AI technologies, and again, the 35% ranking by physicians here probably reflects the lack of penetration into general cardiological community consciousness at this stage of machine learning, deep learning, and AI methodologies, and also home care telemedicine at the bottom. So given that imaging plays a major role, I do want to talk a little bit about our OCT platform and the new software platform, Ultron 1.0, that has already launched in Europe, Japan, and the USA. And the reason I want to talk about it is that we use some of these novel data-driven technologies. Now, some of you will use OCT, some of you won't. I think there is little doubt that if most of us went for an angioplasty performed by a physician you didn't know, you would want them to use some form of imaging. Ask any physician whether they want imaging used on them, they'll say yes, but do they use it in practice on patients? Not so much. One of the barriers to adoption of imaging, and there are many, and we can go into those in due course, but is understanding how to use the equipment and then interpreting the results you're seeing and how that affects your treatment. So what we've tried to do is automate that. Many of you will be aware we've already launched this algorithm called MLD Max, trying to distill down the essential 6 things that you need to have in your brain to do a quality coronary intervention. So MLD is what's the morphology of the lesion, what's the length and diameter for balloon and stent selection, then you implant the stent, then optimizing it, are there medial dissections, how is it opposed, and how is it expanded? Now, we factored that into our new Ultron 1.0 software. So it is seamless and there is a workflow. And I'll just show you some of these things. So the first thing we're very proud of is this artificial intelligence, deep learning enabled automated calcium detection. So you don't need to know what calcium looks like anymore. The machine will tell you. And as you can see, it's zipping rather quickly there. I'll just play that again. You can see the orange parts at the bottom of the graphic are where the calcium is, and they're displayed on the longitudinal mode. They're also displayed going very quickly as a total angle and a maximum thickness, which when it pauses at the end, you will see indicated by a small white arrow on the screen. You can see here at about the 8 o'clock point, that's the maximum depth of calcium on this particular slice. And then if I run it one more time, you'll see that actually the calcification is also shown on the co-registered angiogram. If you look at the angiogram on the left, you can see the orange bars showing the physician where the calcification is. Now, we're not telling people what to do, but we are then giving them the information that there is calcification, where it is, how much there is, and that will enable people to make a decision as to whether atherectomy may or may not be necessary. Similarly, one of the big problems in sizing stents is detecting the true vessel diameter. Can you see the EEL? Well, if you can't, the good news is we've now got a deep learning enabled algorithm that will detect it for you. You see the small dashed white lines. You can see them at the proximal and distal landing zones shown at top left and top right. But also as we scroll through the area of interest, and you can see that happening at the bottom, you can see the EEL is shown by this white dashed line where it can be detected. So that takes the guesswork out of sizing the stent. So we're able to show you what the predominant morphology is, and calcification is the one that makes people change their treatment strategy, but also we can show you the correct size, and length measurement has never been easier with OCT software. We also have the features on the post-PCI pullback. The apposition and expansion, again, is automated as before, but it's shown in a much more intuitive fashion. So we hope that these features are going to just generally raise the bar for intervention. The idea is we can enable people who are not perhaps completely experienced with intracoronary imaging to do the same job as someone who is an expert. And it's a matter of raising the bar and ensuring that every patient can have a tailored and quality outcome. But of course, it's not just about AI-enabled software. We are aware that other things are needed. You'll be aware of the Illumian 4 trial, which is the largest single trial of angiographic against imaging-guided PCI, has completed, and we are looking forward to results in the last quarter of next year. We have a new catheter, which is far more deliverable than the previous Dragonfly Optis. It gets brighter images, so it's easier to see it as well. So that's a meaningful way forwards. We believe the biggest benefit for imaging-guided intervention, of course, is in complex cases. So you need a tool that's going to do the job. Finally, we've also been working on an algorithm to derive a VFR, a virtual flow reserve, from the OCT run. So similar to other forms of non-invasive imaging like CT-FFR and angio-FFR, which I know people will be aware of as tools that are, if you like, threatening wire-based physiology, we are working on an imaging-guided physiology, which will come as part of the OCT pullback. And we're currently engaging in a study called Fusion to validate the algorithm we've already developed. I'll talk a bit more about physiology and why it's important for the future of intervention and personalized care in just a moment. But going back perhaps to one of the points raised earlier on about machine learning. Machine learning is something that is really seeping into cardiology now. And we've just been talking about imaging, but of course, imaging is there what? To guide stent implantation. So why have people not used machine learning techniques to predict target lesion failure? Well, the answer is they have. This was presented by Professor Mamas at EuroPCR earlier this year. This is a machine learning enabled algorithm to predict target lesion failure at 1 year in a large cohort of patients receiving the Terumo Ultimaster stent. So a very interesting application using a variety of patient level demographics, some of them perhaps ones that you wouldn't expect, not clinician selected ones, but to really drill down and work out who are the patients at risk of target lesion failure. We actually have developed our own model, and this is the ROC curve. We'll be presenting this at TCT in a couple of months' time, so more details then. But this is actually, it's a 4-year target lesion failure model based on the Science v USA. And you can see the model results are excellent in terms of TLF prediction. We get to an area under the curve of 0.92. So these kinds of patient-level analytics are examples of data-driven methodologies that can meaningfully produce an individualized and personalized patient journey and experience. And just to touch on some of the things that Dr. Farrar was just mentioning, someone has also done machine learning-based prediction of adverse events following an ACS, and they've modeled a variety of pooled data sets to show whether patients are at risk of either bleeding or indeed a recurrent acute myocardial infarction. And then this ends to synthesize those risks in a way that you wouldn't necessarily do it from a clinical viewpoint to try and triage patients based on their ischemic and or their bleeding risk. And this is an area I think, again, would be very, very interesting as we use these data-driven technologies to truly personalize patient care. I'm just going to say a couple of words about the Xience stent. I know that I've just mentioned we've produced a TLF model, and there's been a lot of talk about new generation drug-eluting stents and thinner struts. As you know, the Xience stent is now in its 6th iteration. We've kept the design exactly the same throughout the 6th iteration with some very minor tweaks, and some things haven't changed. The drug hasn't changed. The deliverability is improved, and we believe the safety is improved. We are the only stent currently, the current generation stent, that has over 10 years of data in high-risk cohorts like ST elevation myocardial infarction, for example. And one thing I think that is contributing to that safety is the fluorinated copolymer. Again, we hear a lot of things about polymer-free, bioresorbable polymer, but I'm afraid the truth of it is that bioresorbable polymer and polymer-free stents have singularly not achieved yet superiority over polymer-based drug-eluting stents. Now, not all polymers are created equal. The fluorinated copolymer, as you probably know, its unique selling point is the fact that it allows unparalleled adsorption of albumin. So on the left-hand side, these are data from Alok Fin and Reni Vermani from CV Path. You can see in this porcine shunt model, the green staining indicates the adsorption of albumin. And you can see that after implantation, Xience has a lot of albumin. The fluorinated copolymer attracts albumin. And the benefit of doing that is that the albumin acts as a barrier against fibrinogen and platelet adhesion. And we can see that on the right-hand side, again in a shunt model, the red staining of the stents here shows the platelet adhesion. And you can see that Xience really has almost no platelet adhesion. And that is mirrored in the clinical arena by a variety of studies, and the time prevents me from going into them. But this is a synthesis of the Xience 28 and Xience 90 studies presented by Marco Valgimilia, ACC 2021, earlier this year. And you'll be familiar with these results that both Xience 28 and Xience 90, with either a 28-day or 90 curtailment of due antiplatelet therapy down to single antiplatelet therapy with aspirin alone at either 28 days or 90 days in high bleeding risk patients, you'll know that the ischemic risk was no worse and there was far less bleeding. So in a high bleeding risk cohort, we know that the Xience stent is safe, and it is the only stent currently that offers the ability to triage patients to 28 days or 90 days or longer based on evidence. No one has such a short DAPT duration as the 28-day indication that we have FDA approved. And it's also probably also worth pointing out that if we combine the Xience 28 and 90 along with our STOP-DAP series of trials, Professor Kimura has already reported STOP-DAP, STOP-DAP2, STOP-DAP2 ACS was presented just recently. And we have STOP-DAP3 in progress. We have the most patients in HBR trials from any current stent platform. So I think when we think about DES and we think about some of the tools that we're developing, yes, we've got good data on high bleeding risk. We potentially have the ability to personalize that high bleeding risk duration with either 28 days or 90 days with no ischemic hazard and less bleeding. So it really is a very safe choice. And again, we have a lot of data out to 10 years, as I've already mentioned. Studies like the examination study in Stemi show that long-term durability. And as we develop these analytics based on our data, we can not only give you a stent that's very, very safe with the options to terminate DAPT early, but also we can provide some sort of meaningful prediction of what the target lesion failure rate might be for that patient before they have the stent implanted. I said I wanted to come back to physiology, and I'll be brief about this. I think we all are aware that wire-based physiology is under threat from non-invasive techniques like CT-FFR and angio-based FFR. Of course, non-hyperemic pressure ratios kind of reinvigorated this field. And that's been very, very meaningful. But one thing I think that, again, speaks to the future of interventional cardiology, and I know this is a slightly dirty word to use this, but if we consider strategies that don't involve putting stents in, we believe that the diagnosis and management of coronary microvascular dysfunction is going to be very, very important. Now, we've heard about microvascular obstruction after STEMI, and of course, some of that causes microvascular dysfunction. But how do you diagnose it? You can diagnose it after the fact. You can use TIMI blush grades, which is a very crude way of doing it. You can use an MRI scan to look for microvascular obstruction. But of course, you can measure it in real time in the lab using our pressure wire. And our pressure wire has always had a temperature sensor that enables bolus thermodilution measurement of the IMR and CFR that can't be achieved with other technologies. So why is that important? Well, there are three large areas that are, if you like, they're unmet needs in intervention. And we forget about this because they're not stentable. The first is INOCA, inducible ischemia with no evidence of obstructive coronary disease. And this affects, certainly in the US populations, up to half of the patients coming to the cath lab. Now, some of those patients don't have coronary disease and don't have angina as such, but a significant proportion have microvascular dysfunction, which of course you cannot see on the angiogram. So the question is, what do you do about those? This is an evolving space. As you know, this is now in the European guidelines for measurement of microvascular dysfunction for IMR, CFR, etc., in patients with a good story for angina and non-obstructive coronaries. And we have early data from the CORMICA study out of Glasgow suggesting that stratified personalized care can be the way forwards to improve things for patients. The other two areas, of course, to move into are those patients with post-PCI angina. And as you'll be aware, nearly a third of patients after most interventional studies, despite successful stenting, have residual angina not related to restenosis at 12 months. Some of that may well be due to microvascular dysfunction and may require a different approach. And of course, the whole area of microvascular obstruction and microvascular dysfunction in acute coronary syndromes, including STEMI, is intimately linked to infarct size and prognosis. And there's not time to go into that further at this stage, but this is an area we are very, very excited in because it really talks about tailoring therapy to the patient. And because you can't stent it, it's much more qualitative. And talking of qualitative, I think going back to some of the sort of future directions, these are, I'm grateful to Rasha Al-Lami from Imperial College for sharing these with me. These are examples of the symptom-based app that they've developed for some of the Orbiter 2, Orbiter Cosmic studies that they've been doing. And the idea here is really to measure patient satisfaction in terms of anginal status on a daily basis. We lose a lot by only measuring at 6 months or 12 months. There's this so-called memory paradox, so people only really recall maybe 3 or 4 weeks or sometimes only a week before they're interviewed. So the Seattle Angina Questionnaire can be very limited. By capturing data on a day-to-day basis, we will be examining what matters to patients. I think we forget sometimes as clinicians that patients don't understand hard endpoints. I know we rely on hard endpoints and we think they're the be-all and end-all. They certainly get approvals, but of course, what matters to patients, if they don't have a stroke or a heart attack, they won't notice they haven't had one, but they will notice if their angina is no better, or peripheral arterial disease patients, if their claudication is no better. So this kind of granular feedback enabled by novel technology and data sharing is desperately important. We also have a variety of other apps that include patient engagement. And of course, this requires active patient input. This is an example of an application for cardiac rehab follow-up to really engage with patients. And there's been recent data from the States about a novel application that has reduced readmission after acute myocardial infarction via a digital health initiative. And of course, there are many, many data points you can take these from. You don't need active engagement these days. You can do it passively. You can get information from people's televisions, from their watches, from their cars, from their refrigerators. So passive monitoring may be as important in the future as active monitoring. And passive monitoring, for example, like continuous glucose monitoring, which is now really very well established in the diabetes care world. So just to conclude, I think it's very important that providers, and by when I say providers, I mean healthcare organizations, physicians, medtech, we need to deliver better experiences for both physicians and patients and improve the value to patients with the increasing consumerization of healthcare by using technology to think beyond the intervention. We've got to think away from just the best stent. We've got to think about what is the appropriate pharmacology for this patient? What is their risk? Have we done a good job with the intervention? What are the tools we can do to enable that, like OCT, like physiology? What are the ways we're going to measure their follow-up? How are we going to interpret those things? We've spent a lot of time thinking about the patient journey map. And of course, the red box here indicates the intervention, which is where most medtech companies live and breathe. But we are trying to understand what goes on outside that, because of course, the point of intervention is like a twinkle in the eye of the patient. It's such a small part of their overall disease journey. And we've got to impact the whole of this in a meaningful fashion. The final thing I'll leave you with is this, and this is the only concern. The majority of patients agree that anonymous data collection is important for future generations, and they can benefit from other people's data. But still, we hear that a quarter of patients do not want their information shared, even if it's anonymized. So there is a barrier here that we are going to holistically have to address if we want to use these techniques that I've discussed in terms of predictive and personalized analytics. If you're interested in any of the things I've spoken about, we published a white paper online last year called Personalized Vascular Care Through Technological Innovation. It focuses on the issues I've spoken about. You can find it at cardiovascular.abbott/beyond intervention. And a second white paper focused on the initial part of the patient journey will be coming out later this year. Thank you very much indeed for your attention.
Thank you, Dr. Nyquist, for giving us a fascinating peek into the future. I have a comment or query, because more from the point of view of getting the point of view of industry, because you are the best person to answer that question. We at developing countries, of course, have a cost considerations. I'm not going to talk about cost. Suppose you talked about the Ultron software, which will tell you about the calcium, which is a microcalcium. As a clinician or as an interventionist, I'm not bothered whether there is a microcalcium or not, because I've been treating those lesions, and I think with the usual tools, I'll be able to treat that patients. Now, you very rightly said that I have told you that there is a calcium. I have not told you that what device to use. But what happens in interventional cardiology is the devices are used before the evidence comes. So in those microcalciums, how we know that we will not land up into IVL and rota use, because they'll say that, okay, because there is a calcium, we have to use some device which will give you a better results. So the cost will further escalate without having an evidence. And there are numerous examples of failed technologies also. It's not a fault of it, it's a science, which is a developing science. But sometimes the devices are not that vigorously tested as the drugs are. Any comments on that?
Yeah, thank you for that question. Just to clarify, we don't detect microcalcification. Not even OCT can detect microcalcification. That's subcellular. This is measuring macrocalcification, and it does tell you the full arc and the depth.
Okay.
So I hear exactly what you say, but as you know, I mean, if you go back to the days of IVUS,
that's only a semantics. I understand. It is, yes, you are picking up the calcium, which is not seen on angio, and you are picking absolutely up on that OCT.
Yeah. So
rephrase that question.
Yeah. So I mean, the reason we think that calcification is so important is it's one of the major causes, as you know, of stent regret. And I'm sure that at least once in your career, you must have had stent regret, where you think you've done a good job in prepping the lesion. No matter how good an interventionist you are, it always happens once in a blue moon, and you really wish you hadn't done that. But this is the idea of this is not so much to teach you how to suck eggs. You know, if you've managed calcification for a long, long time, but of course, some of the more junior cardiologists may not have done that. People not experienced may not have done that so much. So how do they get to the stage where they're experts? The answer is, and I was taught this when I was in training, is that good clinical judgment comes from experience, and experience comes from bad clinical judgment. You have to make the mistakes in order to learn how not to make them. So if we can help people not make the mistakes, we can teach them better without compromising patient care. This is a means of just trying to increase the standard of intervention. If it was one of your relatives and they were admitted to a hospital somewhere else in the world that you had no idea who the interventionist was, what his training was like, wouldn't you be reassured if there was a tool that they could use that would assure a basic standard of PCI and an enablement to detect those things that need detecting to give that patient the best treatment? And that's the ethos behind this approach.
So you missed the point. I said that in developed countries where insurance is paying, it's okay. Where the developing countries or like India, where 80% are paid by out of pocket, you are teaching at the cost of patients. So you are using the technologies to tell him that future generation will learn about the calcium use and so-called device use at the cost which he is paying. Whether he is benefited from it is not known. What that OCT calcium will tell. I'm taking that example just to provoke you. I'm not, I know that this is, I also use that. I'm just provoking you on behalf of people who are cost sensitive, that in India, the cost is an important factor. So this technology is helpful, but they are not tested that much before they are put into the practice. And we have numerous examples, including the so-called BVS, which is famous story that will happen.
No, and I was a big fan of BVS back in the day as well, I have to say. But you raise a very good point. And I think the onus is on us to show not only the clinical value, but indeed the financial value in due course. It's not only healthcare systems without insurance that have problems with reimbursement for these devices. So you're absolutely right. We need to show, that's why I mentioned studies like Illumian 4. Illumian 4 is the thing that's going to show that there is a benefit, a clinical benefit. But then we've got to drill down further to show that there is a cost benefit associated with that clinical benefit. And then it's when the sums begin to add up. But you raise a great point, and that's the same for any novel technology, whether it's an imaging technology, whether it's other treatment technologies. And as you say, the interventional cardiology field is littered with the fact that we like to run before we can walk. We like to use these toys as soon as they come into our hands rather than waiting for the evidence to follow. And some stick and some don't.
Okay, great. I think, I hope Illumin 4 is not followed by 5, as happens sometimes when we Illumin 2 5 we do. I'll leave it at that. It was just a provocating questions. I know this is very fascinating stuff, and I'm a believer of using the imaging, so that way it's okay. Any more questions? Any questions from the chairpersons, or if not, that I think we'll thank you for your excellent lecture or presentation, giving us a peek into the future. And we go on to our last lecture of this session. Then this is a trial which I think has been most discussed trial, the ischemia trial. And we have with us Dr. Amir Ali Ahmadi. He is Director of Cardiovascular CT and MRI Research and director of Wall Clinic and director of Lipid Clinic at Mount Sinai St. Luke's Hospital, New York, USA. Now, he has done extensive research in the field of multimodality imaging. I think the topic he has chosen is because CT angio was done in all patients of ischemia, I think. So he is going to, I think, dwell on failure of stress testing or failure of revascularization. Interesting to have his viewpoint on ischemia trial. Dr. M, the stage is yours.
Thank you very much. Can everybody hear me?
Yes, we can.
And can you see my slides?
Yes, we can.
Perfect. Thank you so much for the introduction. It's an absolute honor to be part of this amazing meeting and amongst these absolute leaders of the field. So you kind of mentioned it. The reason that I'm interested in this topic is not only because of the value of CT in this, but because I try to learn all these multimodalities to understand heart disease and in particular coronary artery disease, and approach it from the point of view of plaque understanding as well as understanding of ischemia and interventions in general. So when the result of ischemia trial was published, I was very much interested in knowing the details, and I have maybe a different look than most people on this trial, and I wanted to share those and obviously get your feedback and your thinking about these observations of the trial. So the topic that I was given was that why was ischemia a negative trial, a failure of stress testing or a failure of revascularization? And in order to answer that question, I actually wanted to modify the topic a bit and ask a question: was ischemia a negative trial? Because I think we need to look a little bit more detail into the reason that people think that this is a negative trial, and maybe actually is not as negative as people think. So the study design, as everybody knows, is that they looked at, and it's a very well conducted study, by the way, by Dr. Hockman and the group, and they looked at people with moderate to severe ischemia as determined by a core lab of at the site by various ischemia testing, and they did a CT to make sure that the patients have more than 50% of disease and don't have left main disease, and then they randomized them to invasive strategy versus conservative strategy, which was an initial strategy of OMT alone, and cath was reserved for OMT failure. And as you know, the overall endpoints of CV death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest was negative after the overall of 5 years, the median of 3.2 years. And many people talk about these curves and talk about the selection of the primary outcome hard endpoints. And one of the things that is mentioned is this point of inflection after about 2 years, that the overall endpoints are more positive in the revascularization arm in the first 2 years, and then it flips. And many people say that, well, if you continue it for a little bit longer, there might be a win for revascularization. What I would like to do is to go and concentrate on why the overall curve was actually negative and why the MI curve pretty much replicated the overall curve and it's negative. And as you can see here, the inflection point around the 2 years is there as well. So first, we need to see if the result of the ischemia trial was comparable to the previous trials or not. And Dr. Shripla Bangalore did an amazing job in putting 14 different trials that was done in the last 20 years or so, including the Barry to the Courage trial, the FAME trial, and whatnot, and pretty much concluded that, from the CV death, mortality, non-procedural MI, and all-cause myocardial infarction, the trial is showing the very similar message to what was done previously. And as you can see, the procedural MIs are more in the revascularization and favors the medical therapy. And in terms of freedom from angina, even though ischemia showed that there is benefit in revascularization, other trials were kind of like all over the place. Some of them shown that and the other ones didn't. So the overall conclusion and verdict of this very important trial that most likely will affect the guidelines was that amongst people with stable coronary disease, moderate or severe ischemia, they didn't find the evidence that initial invasive strategy as compared to initial conservative strategy reduces the risk of ischemic cardiovascular events or death from any cause over the median of 3.2 years. And they mentioned this interesting statement at the end, that the trial findings were sensitive to the definition of myocardial infarction that was used. And this is not that much expanded in the trial itself. And this led to a major blockbuster review of the trial results in various different mainstream media, including major newspapers and major magazines such as Time Magazine, the New York Post, the New York Times, and others, that overall the blockbuster message was that surgery for blocked arteries is often unwarranted. Or, you know, the overall message in the field of cardiology is that invasive strategy failed or revascularization failed or whatnot. And many people are looking into reason why, or what can we do differently so that there is a role for PCI, or if there is a role for PCI or revascularization at the end. So the question that I want to bring at this point is that, was it actually a valid conclusion? So is there really no role for PCI other than symptom improvement as been shown or demonstrated by this trial? And in order to answer that, what I like to do is to talk about a little bit of the caveats of this trial. So first was a definition of MI that I want to touch about. The second is, was OMT really an OMT alone in this trial? And the third is a pathophysiology of MI and ischemia testing, and that I'm not going to go to too much detail today because it requires much more than 15 minutes, but I will touch upon it. So the first thing is a definition of MI, and I will try to emphasis on the point that I want to make using two real-life clinical cases that I was involved in over the last 6 months or so. So the first case was a case of a 58-year-old female with atypical chest pain that presented to my clinic, and I did a CT scan for them at first, and it shows a very significant LAD stenosis of about 90%. What happened is that I asked them to go to emergency room. They went to emergency room. They had a angiography on an urgent basis. Even though they didn't really have unstable symptoms, they had barely atypical symptoms, and they could walk around or run around, you know, with minor shortness of breath. And it's not something that I would have evaluated based on the symptom, or was not something that the patient would have thought that the symptom improvement would be something that she's needed with revascularization. So in any case, she got revascularized, as you can see from a very tight lesion here to the post-procedure pictures here. And then she went home. She got a little bit more chest pain the night of discharge. She got readmitted to hospital. They did a high sensitivity troponin that was about 4,000, pardon me. And it was definitely 5 times upper limit of normal. The second high sensitivity troponin was about the same. So the delta troponin was negative, and she did not get hospitalized for that, but it was a peri-procedural MI. So according to the ischemia trial, this was an example of an intervention on a person with basically ischemic heart disease with a 90% LAD lesion that ended up causing a post-procedural MI. About 2 weeks later, we repeated the echocardiogram. Echo was normal, patient is doing well. But from the endpoint standpoint of ischemia trial, this is a hard endpoint of peri-procedural myocardial infarction. The second case that I wanted to mention is basically a similar presentation, well, not similar presentation, but similar original story of somebody that has atypical symptoms, but unfortunately was not evaluated in time by any CT or stress testing at that point, did not really receive any care, and did not have an angio, but was on statin and aspirin and at a good LDL target. What happened is that unfortunately this person presented with a very severe heart attack with chest pain and initial VT presentation that was successfully cardioverted, brought into lab, and as you can see here, there is a total occlusion of the proximal AD. Later on, he was stented, and his EF was dropped to 20%. His troponin I went up to 250, and after a very long course of hospitalization because of some complications with his heart failure, after about a week he was discharged. He's been followed up with a heart failure patient clinic as outpatient, and it's a according to ischemia trial, this would be endpoint of a spontaneous MI leading to an EF, and it would be as something that would be counting against the optimal medical therapy in a patient with a ischemic heart disease at the beginning. So I showed you two cases, an example of a periprocedural MI in the setting of a bad disease, and a spontaneous MI in the setting of a bad disease, one with optimal medical therapy as a strategy, the other one with an initial invasive strategy. And as you can see here, the overall combination of MI in the ischemia trial is a combination of the two. And the construct is made up of the difference between the periprocedural MI, as you can see on the left-hand side, which is very different. Obviously, the conservative therapy does not have that much of a periprocedural MI, and adjusted hazard ratio is about 3 times more. And spontaneous MI, which is significantly reduced in the invasive arm by about 33% with a hazard ratio of 0.67 and a p-value that is less than 0.01. So the question is, even though if you put all these MIs together, the overall MI would not be reduced with invasive strategy, is this a fair clinical thing to do, to add these two types of MI? One type that is a mere increase in troponin 5 times upper limit of normal, and the other one that could lead to a significant clinical compromise for the patient. Because there were, I think, a lot of discussion about these endpoints, then the group that published the ischemia trial with Dr. Hockman and Dr. Maran and others published this paper in Circulation in 2021, and they looked into more details of the types of MI. And as you can see here, the type 1, which is the spontaneous MI, is about 35% in the invasive arm and 63% with a very significant p-value that I will show you. So there is a difference in MI reduction in ischemia trial, but type 4A, which is periprocedural, obviously is more in the invasive arm as compared to the conservative arm. And if you put it into graphs, you can see that the p-value of the spontaneous MI reduction, which is pretty much what we are trying to do in cardiology, is significantly better with the invasive PCI than others. And when they put all the types of MI, and the blue being the spontaneous MI, you can see the major difference between conservative arm and invasive arm. I put together the numbers that they are presenting, and the conservative arm had 5.8% spontaneous MI, invasive arm had 2.8%, and the absolute risk reduction is about 3%, and the relative risk reduction is about 52% of spontaneous MI reduction. So if you don't put these definitions of MI together in ischemia trial, the trial that is advertised to be a negative trial for PCI, and PCI is failing, it actually is showing 52% relative risk reduction of spontaneous MI. That is probably more than much of the other trials that we've seen, either about the invasive strategies or various trials that are looking into different medications, such as the PCSK9 trials and whatnot. Relative risk reduction of 52% could be significant. Now, some people say that, these days we have to move away from relative risk reduction and go to absolute risk reduction, but nonetheless, it's an important finding, and it's important to mention that it's not all about reduction of angina, but there is significant difference in the reduction of spontaneous MI as well. So the refined conclusion, after showing that there is significant difference also in all-cause death based on type 1 MI, as you can see here, type 1 MI is the one that causes death, and type 4A is not in either of the all-cause death or CV death. was that ischemia trial, type 1 MI event using primary and secondary definition during a 5-year follow-up were more frequent with an initial conservative strategy and associated with subsequent cardiovascular death. To me, that's way more than just a symptom relief for PCI. And I think that's something that needs to be bolded in conclusions and in the overall conclusion that the field, the cardiology field in the whole world is receiving with regards to the ischemia trial. The second point was that with regards to any role for revascularization, because that's what mainly people are talking after ischemia trial, is that was OMT in this trial a real OMT? And as you can see here, there is about 30% cardiac catheterization rate in the conservative arm, as compared to obviously more than 90% in the invasive arm. But it's not like that OMT was only medication and there was no role for PCI in this group. About 30% of them received cardiac catheterization, but about more than 20% ended up being revascularized. And some of them were in context of unstable angina, and some of them were in context of basically just ongoing angina that was not treated. So all of the numbers in terms of the primary and secondary endpoints should be considered with having in mind that about 20% of conservative arm at the end receive PCI. And therefore, there is definitely a role for PCI in this population of stable ischemic heart disease. And if you are saying anything about the conservative arm, is that we are evaluating it in ischemia trial with regards to initial strategy, not the overall strategy. So the third point that is, I'm going to touch upon it here is the point of pathophysiology of MI. And, there are two potential ways to evaluate ischemia. One is the traditional way of evaluating ischemia as based on myocardial information, such as in various nuclear tests or stress echo or PET or other things. And the other one is a lesion-specific ischemia, as Dr. West mentioned in his brilliant talk with regards to FFR or IFR, or even the non-invasive tools that are focusing on the lesion and the vessel as opposed to the myocardium. And in order to figure out which one is probably a better one to guide us through revascularization, I think we need to reevaluate the pathophysiology of MI, which starts with a stable plaque that goes through a plaque progression with the expansion of the necrotic core and get to a point that has vulnerability. And the vulnerability comes from the expansion of the necrotic core, which causes a positive remodeling, but also causes a very thin fibroatheroma at a point that is exposed to a high shear stress. And the shear stress here against a thin fibroatheroma could cause a plaque rupture, and a plaque rupture leads to thrombus formation and leads to a myocardial infarction. So in this scenario, in this pathophysiology, it's important to realize that there is not really necessarily a myocardial ischemia, meaning that not every patient go through a process of getting to a plaque to a point that is causing ischemia first, having a stable angina first, having an unstable angina next, and then get to an MI. And therefore, more than a stable ischemic symptoms or defining of ischemia at a myocardial level, maybe it's important to define a plaque that is undergoing a certain changes that is causing an infarction and causing an event. And that's one of the differences between evaluating ischemia from the myocardial standpoint as been done traditionally and as a part of ischemia trial, as well in comparison with the lesion-specific ischemia by FFR or IFR. Now, the couple of points about that and why is there a difference in the two, with lesion-specific ischemia being probably a better way of measuring and guiding treatment, is that the real-life implications of FFR trials were that FFR lesions that are negative are safe to defer to OMT, and FFR positive lesions require revascularization. And the question is that necessarily true or not, based on the FAME1 and FAME2 trial? And when we look at the details of the FAME1 trial, what we really see, the difference between the two arms of FFR guided and angiography guided in terms of MI, which is about 33% reduction in MI, doesn't come from revascularizing significantly the FFR positives, which, as you can see here, have a similar MI rate as to angiography guided, but it comes from detecting the FFR negatives and safely deferring them with a 0.2% MI rate. So these are the ones that even though they were looking obstructive on the angio, and the FFR was negative, they were deferred. They didn't cause, obviously, periprocedural MI to be counted against them, but they didn't also cause a plaque rupture in the next 2 years and had a very safe event rate. So the question is, how come an FFR, which is a change in the pressure before and after a lesion, can tell you about a future of plaque rupture, which is based on a plaque, not necessarily a pressure? And that brings us to the point that what causes FFR positivity, not necessarily a myocardial perfusion abnormality, is that there are two types of lesion that cause it: the fixed severe stenosis and a relative functional stenosis. And this is a concept that my Dr. Narula, my mentor, and myself tried to develop in the past few years, that if you have a relatively, if you have a plaque with a vulnerable features that is ready, basically that is causing rupture in many cases, these plaques, because of positive remodeling, have reached their Glasgowian limit at the type of lesion. So when you cause maximal hyperemia in these cases, the two ends of the vessel will dilate maximally, but this part of the vessel, which has the plaque, because of positive remodeling, has reached its Glasgowian limit and cannot further expand. And what happens is that in comparison between the before and after, because of lack of expansion, the lesion itself becomes relatively stenotic, even though if it's not necessarily stenotic at the beginning. And since FFR is really not measuring ischemia, but a difference in the pressure before and after, and the pressure is really related to 1 over radius to power of 4, a relative change in diameter between here, and the type and the level at the lesion, there is a significant change in the FFR. And therefore, when you look at when we looked at lesions with significant plaque morphology, with significant necrotic core volume, we've observed that that in different lesions in different QCA classification of less than 50, 50 to 70, and more than 70, the ones that are FFR negative have a smaller necrotic core across the board. So if you see the FFR negatives at various lesions have a smaller necrotic core, meaning that there are less vulnerable plaques. And therefore, we think that because FFR has sensitivity of detecting some information about plaque without anybody knowing that or anybody really aiming for that, it has some value in predicting which plaque is going to rupture and which plaque is not in future. Therefore, and knowing that, with regards to plaque, it's the absence of a high-risk plaque, as you can see here, with a very high negative predictive value, and that will give you the safety in future. Maybe one of the future directions that we can think of is that going from only FFR negative lesions and deferring them is to deferring FFR positive lesions that have safe plaque features. And expanding on what Dr. West just mentioned, maybe combination of a non-invasive or invasive physiological information on the lesion, as well as a plaque morphological information on a lesion, could be combined together to provide us a roadmap of who needs revascularization for assessment and prevention of MI. So in conclusion, I wanted to maybe redefine the conclusions of STEMI trial and that was presented so far. So OMT is a safe way to start, but benefit of PCI, in my opinion, in more than just a symptom relief. And as I show you, there's a significant reduction in spontaneous MI rate. Periprocedural MI is equal in that trial to spontaneous MI. As a clinician and somebody that deals with MI on a daily basis, I don't think that that's necessarily a fair equalization in this trial and other similar trials, because I much rather have a asymptomatic non-LVEF affecting increase in troponin periprocedurally rather than something that caused a significant damage to myocardium. More than 30% of the OMT group had cath and more than 20% had PCI. So it is not PCI if it's not needed. It is that OMT could be a safe start. And again, that's important to realize that it wasn't a failure of revascularization. They didn't talk about the role of CABG and complete revascularization in that trial. We don't talk about the left main disease or decreased EF. So again, like there are potential roles for revascularization there. And as in this talk we mentioned, it may be demonstration of failure of revascularization to reduce MI. It may be a failure of guiding revascularization by ischemia testing as opposed to a lesion testing. And maybe we should be thinking about moving from a stable ischemic heart disease concept to a stable atherosclerosis coronary disease concept. And combination of FFR and plaque data could provide a better roadmap for revascularization. With that, I thank you so much, and I open the talk to any questions.
Thank you, Dr. MD, for analyzing the ischemia trial in a different way, presenting your data. There are very strong views for and against ischemia trial, basically depending on what you believe is the post-procedural MI significances. And I think tons have been written on it, and but your views are fascinating. You have analyzed in a different way. There are any questions from anyone? If not, I think we had an interesting session and we had an excellent talk. I'd like to thank all the speakers and hand over the session to Dr. Nitish Naik for conducting it, taking it forward to a next interesting session on STEMI blind spots. Dr. Nitish, thank you.
Thank you, sir. That was a really interesting session, and I would really thank all our esteemed speakers for being there, and all our chairpersons as well. And we move on to the last session of the day, and we do recognize that we have really overstepped time, but we would request you to stay back for the last session of the day, and that is STEMI blind spots. And may I request our chairpersons, Dr. Deepak Natarajan, Dr. Sethi, Dr. Fatke, Dr. Mohan Bhargav, Dr. Nitin Deshpande, and Dr. R.K. Saran to take us through the talks in this, the 4 talks in this session. And the first talk is by Dr. Venu Gopal, and he'll be talking on STEMI in women, diagnostic and management challenges. Do we need specific guidelines?
Thank you. Thank you, Dr. Nitish, for giving me this chance to talk. Is my slides visible?
You can see your slides.
Okay, thank you. STEMI in women, the diagnostic and management challenges. Do we need guidelines? The coronary heart disease remains understudied, underdiagnosed, and undertreated in women, and the annual CVD mortality is higher for women. If you look at the time scale from 1979 to 2011, the mortality for men has steadily declined. But if you look at the mortality patterns in women, there has been a peaking around 2000, and then it is starting to come down. But even now in 2011, where the data was collected, still women had a much higher mortality when compared to men. What are the issues in women? The diagnostic challenges, the coronary artery differences, clinical trials with very few women participation, whether there should be specific therapeutic strategies in women. What about MINOCA and stress cardiomyopathies? The diagnostic challenges that we have in women are the atypical pain patterns, presence of non-obstructive coronary artery disease, vasospasm, spontaneous coronary artery dissection, and stress cardiomyopathy. What are the reasons for delayed presentation in women? Women present later to treatment for AMI than men. The median delay time was about 53.7 hours for women and 15.6 hours for men. The reasons given were women, most of them, this is a Western data, living alone, they interpreting the symptoms as non-urgent and temporary, and consulting a physician or a family member, fear and embarrassment of disclosing the symptoms. All this led to treatment seeking delays. The other reasons that were highlighted was a lack of awareness of the risk, passivity, inaccurate symptom attribution, and barriers to self-care. Some other additional factors are also associated, including old age, race, especially Black and Hispanic race, and lower educational and socio-economic status. If you look at the gender differences, the women present at an older age, and they have much more comorbidities, they have a higher burden of cardiovascular risk factors. The sex hormones are active and cause problems in the lipid metabolism and vascular endothelium. And the cardiovascular anatomy is specific that they have much smaller vessels when compared to the males, and they have more tortuous vessels. And the pathology that is commonly seen is plaque erosion rather than plaque rupture. So again, as I said, women present with atypical symptoms, microvascular dysfunction, vasospasm are much more common. And response to pharmacotherapy is also different. They have a drug volume of distribution. The drug metabolism sometimes can be different in females, and they have a higher platelet reactivity. The post-PCI outcomes, surprisingly, have been, as far as intra-stent restenosis and stent thrombosis, most of them are almost similar. But the one thing that has been highlighted is more persistent chest pain in women following procedures. Why are women not included in the trials? This is basically because of selection bias, enrollment bias and referral bias, diagnostic account bias, performance bias, and various other factors like perception bias and compliance bias. So this is some of the reasons why females tend to be much less in the clinical trials that we come across. There are multiple factors responsible for the observed worse outcomes of women suffering from acute myocardial infarction. Atypical and delayed presentation, more comorbidities and older age, assessment bias, less access to intervention and more delays in referrals, biological bias of different response to antiplatelet agents and smaller vessels, treatment bias, less invasive procedures and revascularization therapies, and inferior secondary prevention strategies. The histopathological differences, as I said, plaque erosion is more common in women, especially premenopausal. They have smaller epicardial coronary arteries. Baseline and hyperemic myocardial blood flow is higher. They have much higher shear stress, leading to more plaque formation. Coronary calcium has also been highlighted as a risk marker in younger women. Microvascular angina is twice as common in women. What are the data from India? India is no different from other countries. If you look at the registries that we have, the CREATE registry, the Kerala ACS registry, the DMAT registry, and the JDAVA data, nearly 80% of all the patients participating were men. Only 20%, 20 to 25% were actually belong to the female sex. One trial which compared outcomes in India regarding men and women is the DMAT trial. There were about 1,500 patients, and there was 1,231 men and 334 women. And the clinical presentation of Stemi was about 55 in men and 38.3 in women. Now, if you look at the DMAT data, the use of aspirin, clopidogrel, beta blocker, statins, the unfractioned HEP and the optimal care, all this were favoring men much more than the females. Even PC and CABG also favored men. But the 30-day outcomes in the DMAT registry, death at 30 days or the death and rehospitalization cardiac arrest, there was no significant difference. So no significant difference in the in-hospital management and discharge management or 30-day outcomes are seen between the genders after adjusting for confounding variables. Post-PCI, what are the differences? 20% of higher risk for women for short term compared to men after PCI. More in younger patients below 55 years, they have a higher bleeding risk and higher rates of dissection. This is one study which has come from Brazil in 2020. A total of 878 volunteers are confirmed diagnosis of Stemi, of which 33% were women, almost 1/3. It's a much higher number compared to the usual number. And only 53% 2.3% of the patients underwent a myocardial reperfusion. Fibrinolysis was performed in 2.3% of all patients. And the rate of primary PCI is also lower, 44 in women, 44% versus 54. And the conclusion was that women have significantly lower rates of primary PCI and higher hospital mortality. And the reperfusion rates are low in both sexes. There's a clear underutilization of thrombolytic agents. Again, coming to the management issues in women, fewer interventional treatment strategies, as has been highlighted, fewer guideline-directed medical therapy, less stringent follow-up, and less adherence to treatment. Plaque characteristics differ in men. Women paradoxically have less severe obstructive disease of the epicardial coronary artery selective angiography than men. Women with acute coronary syndromes are less likely to be treated with guideline-directed medical therapies, less likely to undergo cardiac catheterization, and less likely to receive timely reperfusion. Regardless of age, within a year of a first MI, more women than men will die. 26% of women compared to 19% men, and within 5 years of MI, more women than men will die, 47 versus 36%, and more will have heart failure or suffer from a stroke. Studies report a higher prevalence of diabetes mellitus, hypertension, heart failure, depression, and renal dysfunction in women compared to men. And depression is again one major factor which is now being highlighted more and more in women with coronary artery disease. Higher incidence of minor coronary artery disease, Stemi, SCAR, and coronary artery spasm has already been highlighted. Women require longer hospitalization, higher in-hospital mortality. They manifest more bleeding complications and endure up to 30% more readmissions within 30 days after the index hospitalization. Women are often older when they present with their first AMI. The average age 71.8 years compared to 65 years for men. What are the key messages? Women may present late with atypical symptoms, which may delay investigations and treatment for coronary artery disease. There is a referral bias where women are less intensively investigated and treated than their male counterparts. Women have worse outcomes from both chronic stable angina and acute coronary syndromes, which may be related to a worse comorbid profile as well as undertreatment when compared with men. Women with coronary artery disease benefit as much from coronary interventions and drug-eluting stents and should be treated as intensively as men. This is extremely important. There are special factors that are gender-related, such as pregnancy, the menopause, response to platelets, as well as psychological factors that need to be considered when assessing and treating women with suspected coronary artery disease. More gender-based diagnostic criteria and gender-specific treatment protocols, which may be developed, which may help in future management of women presenting with coronary heart disease to close the gender gap in the outcomes. What are the future actions to tackle the gender gap? Public awareness campaigns addressing the late presentation in women, focus on women's specific risk factors, physician education presentation of coronary artery disease in women, especially the atypical presentations, gender-tailored management, different biomarkers, drugs, and optimized interventions, and research initiatives focusing on gender-specific study design will go a long way in tackling this disparity in the treatment between men and women. Thank you for your patient listening.
Very nice presentation, Dr. Venugopal.
Thank you.
There are differences you have rightly mentioned, but as far as the drug therapy is concerned, a similar extent of disease, and we give drug therapy, different drugs, aspirin, statin, beta blockers, ACE inhibitors, and interventions. So are there differences in that also?
No, in drugs, I think there is one difference is the platelet reactivity. Women have a much different platelet reactivity compared to males. So that is why I said that probably assessing platelet reactivity may be a more important aspect of treatment in women, especially with drug treatment. These are reasons which are unexplained, but this platelet reactivity has been highlighted in women.
That is why perhaps aspirin for prevention of coronary artery disease in women has a very limited role, although it's less role in males also at present for primary prevention, but for females it has been from long time. So thank you, Dr. Any other question from?
Yeah, Dr. Venugopal.
Yes.
Like any word about connective tissue disorder, like patients who have even rheumatoid arthritis,
Yeah.
they tend to have more coronary artery disease. So we want to
Certainly. See, that is a patient profile. That is what I said, that the patients, the female patients have much more comorbidities. One of the, as you rightly pointed out, one of the comorbidities which I should have highlighted is the connective tissue disorders, especially SLE, then rheumatoid arthritis. These are group of patients who are prone to get myocardial infarction. So I think, yes, we'll have to include that also. When you're assessing the risk profile, probably that also should be included in the risk profile. That's a valid point.
Thank you.
There are no more questions. We can switch over to the next talk by Dr. Rishi Sethi, anti-inflammatory therapy post-MI. We know the plaques which rupture have inflammation, and there may be many inflammatory plaques in other arteries. So let us hear from Dr. Rishi Sethi on this important talk and some recent trials, what they have told us. Dr. Rishi Sethi, please.
Very good evening, sir.
Yes.
Well, eminent members in the panel of chairpersons, colleagues, ladies and gentlemen. The role of inflammation in the pathophysiology and pathogenesis of atherosclerosis, and more specifically, the complications of atherosclerosis, the acute coronary syndrome, is nothing new. In 1856, Rudolf Virchow said that atherosclerosis is a combination of inflammatory and proliferative responses that happen because of injury to the arterial wall. And more than 100 years later, Ross' hypothesis was published, in which he also mentioned that atherosclerosis happens in response to injury to the vessel wall. And inflammation per se may be responsible for that injury, but more importantly, inflammation is the endpoint from that injury, which leads to various pathophysiological changes, and thereby leading to atherosclerosis and the complications of atherosclerosis. So in the late 20th century, all the studies started to come up which tried to link inflammation to cardiovascular diseases, and the widespread acceptance of Ross' hypothesis occurred, which firmly established that atherosclerosis, more than anything else, is also a chronic inflammatory disease. There were many studies that came out linking inflammatory biomarkers, which studied the inflammatory biomarkers in correlation and predictive capabilities of these inflammatory biomarkers in many aspects of cardiovascular medicines, both in stable coronary artery disease as well as acute coronary syndrome. However, effort to influence the outcomes of the clinical outcomes of the cardiovascular disease by manipulating the inflammatory pathways based upon the inflammatory markers or without being based upon inflammatory markers did not enjoy great success in years to come. So current pharmacological interventions are designed to slow the process of atherosclerosis, and they aim exclusively on reducing plasma levels of cholesterol. There is clinical and experimental data which is evolving that involves the critical role of inflammation and atherosclerosis, and biomarkers informations like HSCRPs and interleukin-6 are associated with increased risk of cardiovascular events, which is independent of cholesterol levels. In the landmark paper, which studied the inflammation and atherosclerosis and coronary artery disease published in NEJM, there were 3 phases of inflammatory response to myocardial infarctions in terms of inflammatory pathways. The first was the alarm phase mediated by interleukin-1 alpha and various components of the complement system. Then there was the leukocyte mobilization phase, which involved mobilization of various leukocytes, and it involved interleukin-1 beta, MMP, selectins, and integralin. And finally, the resolution phase, which was mediated by interleukin-10 and tumor growth factors. So the rationale for targeting inflammation after MI and all the therapies is that it may result in a decreased leukocyte-mediated cardiomyocyte injury for the surviving myocytes in the border zone. It may inhibit the inappropriate late activation of pro-inflammatory signaling. They may lead to reduced incidence of chronic apoptosis. It may restrain protease activities and thereby increasing the tensile strength of a healing scar, preventing cardiac rupture. It may promote angiogenesis. It may have direct antiarrhythmic action. And most importantly, targeting inflammation may actually result in prevention of plaque rupture in a residual plaques, as Professor Saran was saying, and thereby reducing the incidence of recurrent coronary events. So the first drugs to be studied in myocardial infarction in terms of anti-inflammatory therapy were glucocorticoids, and there were many clinical trials that were done between 1960s and 1985 and 86. Essentially, the data was quite mixed. Very few of the clinical trials said that there was a reduction in the infarct size and mortality. Most of the clinical data said that there was actually no effect of administering steroids to these patients. And there were few clinical trials, which also clinical trials and studies and retrospective analyses, which showed that actually giving glucocorticoids increased the risk of cardiac rupture. So with no prospective or retrospective data in favor of steroids and a risk that it may be causing cardiac rupture, glucocorticoids were not, it fell from repute and were not tried any further in relation to anti-inflammatory therapy and myocardial infarction. We at the Department of Cardiology at King George's Medical University started studying the role of inflammation and acute coronary syndromes way back in 2007, 2008, and multiple series of papers were published in this regard. This was the most important of those papers when we tried to study that patient population who was presenting with acute coronary syndrome but did not have classical risk factors. They were younger in age, lower in socioeconomic classes. They were not the exact kind of patients that would fit the profile of CAD as we all are seeing in our everyday practice. And we found that in those patients who were younger in age group, lower in socioeconomic class, and had lesser incidence of risk factors, we saw the higher levels of hsCRP levels, thereby implicating that maybe chronic inflammation was responsible for the occurrence of acute coronary syndrome in these patients. Paul Ridker has also done extensive studies on this data, and this study published in 2016-17 also showed that for incremental increase in hsCRP level by the point of 0.5 to 1 milligram per liter, you had higher incidence of future cardiovascular events, both in the blue bar shown in the absolute risk of having future cardiovascular events, and then the red bar showing the relative risk adjusted to the Framingham risk scores of these patients. So inflammation per se is definitely an important contributor to atherosclerosis, and more importantly, the complication of atherosclerosis, that is the acute coronary syndromes and MI. And we have also seen studies with aspirin use, and it showed that those people who have higher inflammatory state projected by higher level of hsCRP levels of more than 3 to 4, these are the patients who benefit most from the use of low-dose aspirin, preferably because they are at higher risk, maybe a little bit because of the anti-inflammatory effect. So notable clinical studies have been done in anti-inflammatory therapy in relation to atherosclerosis. I would go from atherosclerosis and proceed towards MI. There are ARISE, Jupiter, Stability, and CANTOS. I think Jupiter and CANTOS deserve a special mention. In Jupiter trial, patients with LDL levels of less than 120 and hsCRP of more than 2 were included. And those patients who achieved the dual target levels with the use of 20 milligram of rosuvastatin, that is LDL levels of less than 70 and hsCRP levels of less than 2, they fared best. And then were the patients who were given rosuvastatin, but who did not achieve the dual targets. And of course, the placebo group fared worse. So giving statins to those patients who are at a baseline high levels of inflammatory markers was beneficial irrespective of the lipid loading levels. And there came the concept of the reduced inflammatory risk, in which those patients, while after giving statin, in which the LDL levels have come down to less than 70, but the hsCRP levels remains more than 2, these are the patients who have residual inflammatory risk, and Improve It trials, the scheduled risk patients comprise 29% to 33% of these patients. Low-dose methotrexate was tried in atherosclerosis, but then it was shown that there was no benefit of lower-dose methotrexate in a trial that was published in 2018 and 19. And then came colchicine, a good anti-inflammatory agent, but at the same point of time having some GI side effects and side effects related to infection. First, it was tried in the low-dose trial in chronic stable angina, in which chronic stable angina patients who received 0.5 milligram of colchicine once daily or matching placebo. And it was saying that the risk of cardiovascular events was significantly lower in those patients who received 0.5 milligram colchicine as compared to placebo group. The CANTOS trial was the largest trial. It cannot be said as a post-MI trial, but then it involved all the patients who had previous myocardial infarction and highest level of C-reactive protein, in which an antibody targeting interleukin-1 beta, that is canakinumab, was tried in various doses, and it was seen that canakinumab in the doses of 150 milligram every 3 months led to significant lower rates of recurrent cardiovascular events. Now, this specific trial targeting myocardial infarction evolved from the LOCOMO trial of colchicine, in which colchicine was tried early after myocardial infarction. This is the latest and the most important of the trial in myocardial infarction, in which those patients who were 30 days within myocardial infarction were started with low dose colchicine 0.5 milligram once daily or placebo. And it was again seen that colchicine was beneficial in those patients who had recent myocardial infarction in terms of all the major outcome events. Although there was a little bit higher instance, statistically significant higher instance of GI disturbances and non-statistically significant higher instance of infection and pneumonia, but generally it was considered, safe. There are many other clinical trials that have been done in anti-inflammatory therapy. COX-2 inhibitors have been tried as an individual in the trials. They have showed some promise, but meta-analysis of COX inhibitors have shown that significantly increases the risk of myocardial infarction, and so has been abandoned. I would like to summarize by saying that extensive experiment evidences suggest that targeting specific inflammatory signals may hold promise in the treatment of atherosclerosis and especially acute coronary syndromes. Identification of therapeutic window for specific interventions and stratifications of MI using inflammatory biomarkers are critical for planning optimal therapeutic therapies. And there is evidence already is there that such strategies are of benefit in cardiovascular medicine, although the extent of the benefit needs to be studied in larger studies, and these therapies need to be brought in focus in a little more way than they are at presently being brought out. I thank you for your attention.
May I request Dr. Suman Bhandari to start his deliberation? Dr. Bhandari, sir.
Rishi, anything about cyclosporin? Meanwhile, before Dr. Bhandari starts off?
I've not been able to study the data about cyclosporin therapies. I've not been able.
It will come in this. Cyclosporin will come in my talk.
Yeah.
Okay. So the topic is reducing myocardial infarct size. Essentially, what are the future opportunities and the current challenges? So I think it's been a very extensive 2 days on ST elevation MI, and we know that's one of the important causes of death. We have been able to achieve what we call epicardial opening up very quickly with either primary PCI or thrombolysis, but the infarct size is actually dependent on also reperfusion injury. And in fact, that's about 50% of the total or final infarct size is attributed to reperfusion injury. And it's the full screen, yeah. And the one, sorry, am I visible or is it?
Sir, you are visible.
Yeah, sorry.
You can see your slides, sir. Just go to the presentation mode.
It's on the presentation mode.
Enable it. No, you have to put enable editing and then go to presentation mode. Upar hai, sir. Enable editing.
No, you can't see the slides?
We can see your slides, but it says it's showing enable editing.
You cannot make it forward, sir. So just click enable editing.
No, it is
Dr. Bhandari, your slides are not moving at all. So you are static on first slide. So to move it, you have to say
Enable
Click
editing.
on enable editing and then you can.
Where is enable editing?
Upper, sir, the upper bar, yellow bar.
There.
Top bar, sir, yellow bar.
Yeah, here. I kept the arrow there.
Where? I can't see your arrow.
Sir,
Can you
above the slide
share
show, you have a protected view, a yellow marker. After that, there's an enable editing option. Just click it.
Sir, your screen got freeze. Just stop share and start resharing, sir. Just
So I
click
should
on
stop share.
Start sharing again, sir.
Can you see it now?
Yes, sir. Now click it on the presenter view, sir. Near your cursor. Near your cursor.
Slideshow. Click on slideshow on the top bar.
Pause. It doesn't show any.
Yes, it is there on the top.
On the top.
After that red, you just come and
more.
Yeah, here there is a slideshow. There is home.
Yeah, I don't see anything.
Sir, you have to enable editing. Sir, you first go to your PowerPoint window. In the PowerPoint window, please press enable editing.
I'm going back again.
Yes, you go back to your PowerPoint. You just enable editing.
I've approved the remote thing.
Enable editing, then share it.
Then once you do enable editing, then you share, sir.
Then share and click on slideshow.
Then click on slideshow.
No, I don't know.
I think in the meantime, can a technical team help him?
Please open your presentation, sir.
Yeah.
Now it's coming. Now it's coming, sir.
Now it's coming. Okay.
Yeah.
Sorry. Okay, so I'll just start again. It's my talk is on reducing myocardial infarct size, future opportunities and current challenges. I was just discussing that currently we are able to do a good epicardial opening up of the vessel with either thrombolysis or primary PCI, but 50% of the final infarct size is dependent on the reperfusion injury we are generating as a cause of thrombolysis or primary PCI. And though we are able to bring down the 1 year, the 30-day mortality of due to primary PCI to about 5%, but the 1 year hospitalization due to heart failure is quite significant. So essentially, one of the last frontiers of ST elevation MI is to reduce the infarct size and to look after or conquer the coronary microvascular dysfunction or MVO or mitral vascular obstruction. So there are 4 elements actually where we can target. Either there is thrombus which goes down and then gets problem with sort of endothelial injury causing platelet neutrophil aggregates and swelling of the myocardial cells. And this can be ischemia related because we are opening up the artery or reperfusion injury, distal embolization, and having earlier problems. So how can we detect microvascular obstruction? Invasive indices, as was shown by Dr. Nick as well. And that's essentially doing IMR or CFR. But we now also have good non-invasive indices, especially the MRI, which can detect reperfusion injuries. And one of the ways where it has helped to reduce the infarct size is by doing post-conditioning or conditioning with, which is essentially going to act on some of the signal transducer cascades, which could be nitric oxide or reperfusion injury salvage kinase system. And the post myocardial infarct, you can have the balloon inflated for 1 minute every 4 minutes to have a sort of post infarct conditioning, or you can have BP cuff around the arm or the leg, and that can also act as a potent ischemic conditioning way to condition the patient. And it's been tried in various forms pre-hospital while the patient is being transported to the cath lab from the by the ambulance during the ambulance time. Aspiration hasn't worked, so also delayed stenting so that maybe the thrombus gets reduced has also not been shown to be beneficial. Intra-aortic balloon pump also, we have heard in various settings, has not been very helpful because of the low cardiac output it can improve. Endovascular cooling has been tried as well. There are trials like the chill MI or even having peritoneal hypothermia. And recently there's a cool AMI pilot trial which came out in Eurointervention where 1 liter of cool saline was injected, and the temperature was brought down to about 33 degrees, but wasn't shown to be very beneficial in terms of reducing the LV infarct size, though it's one of the ways where it could have worked, especially in the animal model. This is what Dr. Samin Sharma also pointed out, supersaturated oxygen therapy. I think this is one way where it can really work. The Zoll company is able to manufacture this device, and you have a cartridge where supersaturated oxygen mixes, and through the catheter, after the primary PCI is done, you can have a catheter inserted from the femoral. It's a 5 French catheter which sits in the left main, and it takes an hour of the supersaturated oxygen to perfuse the infarcted, especially LAD infarct. Large infarcts have been tried, and recently there were some data which was shared on the CRF video on Radcliffe, and very few patients have been done, maybe 5 or 6 in Script Clinic and few in Germany as well. But they showed a beneficial effect in some of the patients. The EF from 30-35% became 60%. So this is one area, especially has also been shown in AMI-HOT trial to be beneficial. GIK has been tried, so also some anti-diabetics, many other drugs have been tried with negative results. Adenosine as infusion has been tried, even nicorandil, nitrates, and many other drugs targeting different sites, like even intravenous cyclosporin in many trials, but all of these have been not beneficial, and even intravenous metoprolol has been tried, and a large early BAMI trial which came out in recently was also not able to translate this into real effects. So we can target before the cath lab, in the cath lab, and after the cath lab, and the green is where it may be beneficial, and so why we are not able to translate the experimental data into clinical trials is something of a challenge, and maybe it's also the patients may have other risk comorbidities like diabetes, hypertension, etc. Also, as we know, we have to be able to target between 1 and 3 hours, because at less than 1 hour, you may not find enough benefit, because you'll get a lot of myocardial salvage, and beyond 3 hours, also the curve flattens out. So, and also any drug which has to be beneficial has to be given within the first 6 hours, and probably before you open up the artery, so that it can affect the reperfusion. So at this time, we can select only patients who have a large MI, those presenting early, less to 2-3 hours, and have a occluded artery without much collateralization, etc., which may be fulfilling the animal model. And of course, the study endpoints of myocardial infarct size, or other hard endpoints like heart failure, etc., need to be focused on. So maybe remote ischemic conditioning is something which can be studied more in larger trials, or supersaturated oxygen. These are the two large areas which are being talked of and may be useful. And some drugs which may also benefit are the atrial natriuretic peptide, and some like cyclosporin, which work on mitochondria. All these are still, a lot of trials have gone on, but nothing has come in the positive sense. So despite the last frontier being reperfusion injury, and we have a lot of data from animal models, but it hasn't really translated into great benefit for the human population. So it's been a really long and bumpy road with not much end in sight, and hopefully better targeted large studies like unloading plus supersaturated oxygen, as Dr. Samin Sharma was pointing out, has started. Maybe one way where we can reduce the last sort of challenge of having a less myocardial infarction and less reperfusion injury. Thank you for your kind attention.
Can you see my slides?
Yes,
Yes, sir. We can see your slides, sir. We can see your slides, sir.
Good, good, thank you. Good evening, everybody. And STEMI is all about salvaging myocardium and improving cardiovascular outcome in patients of STEMI. The first STEMI was performed by Herzler in a very awkward situation of SVG graft MI. And that is how the whole STEMI care has started in terms of, yeah, I'll make it. Okay. So that is how the STEMI care has started. The major problem with these STEMI cases is the guideline-based therapy is PAMI. So while doing a PAMI, we have a major challenge while manipulating equipment into the STEMI area, we have a distal embolization. Either it is a macro distal embolization like we can see it here, or it can be microvascular distal embolization that can lead to significant issues in terms of slow flow or no flow. And that impacts the cardiovascular outcome by impacting the reduction, not reducing ST resolution, not causing ST resolution, increasing infarct size and increasing mortality. So large thrombus burden, as I said, if you see the 24 months cumulative MACE rate is in small thrombus burden, it is 15.3 and way higher in large thrombus burden. Even stent thrombosis rate is also way higher. So large thrombus burden is no very important subset of the STEMI, and majority of these patients are very difficult to manage. At the moment, there is no specialized treatment available for us. Various treatment strategies have been tried, and depending on the thrombus grade, we define them at grade 4 and grade 5 are high thrombus burden or large thrombus burden. Now, angiographic indicators for large thrombus burden is a cutoff, what we say a flush occlusion. That is what we say. And accumulated thrombus proximal to the occlusion, reference vessel diameter more than 4 millimeter, and incomplete obstruction with an angiographic thrombus with the greatest linear dimension more than 3 times of reference lumen diameter. That is the length of the thrombus. Then presence of floating thrombus proximal to lesion and persistent diastasis distal to occlusion. Now, in India, we have a pharmacoinvasive approach. Only 5% patients go for STEMI in the golden period. And that imposes a lot of burden on the working in the cath lab because patient is already received the thrombolysis, giving DAPT, and what dose to be given, and that has to be deciphered very carefully and to be decided accordingly, according to the patient subset, whether he is in a high bleeding risk subset or low bleeding risk subset. Now coming to the pharmacological agents which are various available are DAPT, heparin, bilirubin, bivilirudin, and GP2B and 3A inhibitors, vasodilator, and intra-coronary thrombolysis. Various these drugs have been tried in various ways, and I will cover one by one how they, and then came the manual thromboaspiration devices and thrombosuction devices. The first trial was thromboaspiration was done by TAPAS, is the TAPAS trial published in NEGM, which revealed on 1,000 patients, which revealed positive data, but there was no reduction in infarct size. So it's all about reducing infarct size. Then came the test trial, which showed that thromboaspiration, PCI, PAMI without thromboaspiration or with thromboaspiration. The difference numerical is seen, but statistically not significant. Similarly, total trials suggested that 10,000 patients and 2 trials together, total and test, almost 18,000 patients. And second trial suggested that there is no reduction in MACE rate. On the contrary, there is increase in the stroke rate in first 30 days. And therefore, the recommendation was class 3, routine thromboaspiration in primary PCI with large thrombus burden, especially not to be done. And usefulness of only for a bailout strategy while doing PCI if there is a thrombus injected through the guiding catheter or some thrombus occurred at that time, maybe at that time. The after thromboaspiration, OCT sub-study has revealed that there is significant thrombus burden existing after doing thromboaspiration. So thromboaspiration is supposed to be not so beneficial, though conceptually it looks intuitive and feels right, but data suggests that thromboaspiration is not beneficial. It's associated with increased risk of stroke and routine aspiration should not be performed. So now then comes the mechanical thrombectomy devices. Various devices have been introduced to try, and Penumbra, to name Penumbra, it's a kind of machine which extracts the thrombus, and it's a suction machine which extracts the thrombus, but not useful in reducing the MACE rate in 1 year, 6 months, and 12 months. Same is angiojet, but angiojet, when compared with the jet stent in the jet stent trial, it is compared with half of the cases in a RCT, compared with half of cases direct stenting, half cases angiojet. And there it found that the 1 and 6 month and 1 year results were, as in terms of MACE rate, were better with angiojet. So angiojet at the moment in large thrombus burden is one way to look at the treatment. Angiojet is now available in India, but expensive device and has to be handled very carefully because it causes rheolysis and increases hemolysis. So you cannot do it for more than 10 minutes. If you're doing it RCA, you have to have a pacer or temporary pacemaker put. Then came the exciser thrombectomy device, which is also very user-friendly. It has double lumen, and it also has a great suction pressure vacuum at the side. It creates and extracts the thrombus by suction, by vacuum. And that also revealed that there is no long-term benefit in terms of MACE rate. Then excimer laser particularly found to be useful in large thrombus burden, particularly in patients with ectatic coronary artery or aneurysm, or even in patients with SVG graft. And those patients, excimer laser is supposed to be a promise, but at the moment requires greater studies. Then came the M-Guard stent, which was also not very useful. So we landed up only with the direct stenting that's supposed to be give better result. No reflow, no slow flow phenomenon occurred. Distal embolization was very little. Then came the deferred stenting in a situation where we see a lot of thrombus still existing. If you stent, a lot of distal embolization will occur, and that situation also very difficult. Then in SVG graft, the distal protection device is envelope protection device is also one of the technical device which can be used for. So now there is a fresh algorithm developed for management of large thrombus burden. Between if the thrombus grade is 0 to 2 or even up to 3, direct stenting is fine. But if it is grade 3 to 5 or mainly 4 to 5, antegrade flow achieved or no ongoing ischemia after putting a wire, then consider GP2B and 3A for 48 hours and deferred stenting. If no antegrade flow achieved, ongoing ischemia is there, then thromboaspiration, angiojet is preferred, or excimer laser is preferred in large thrombus burden. We are talking of situation of large thrombus burden, which is thrombus grade 3 to 5. Here, direct stenting or balloon with stenting and covered stent may be considered. So this is a new algorithm that has been devised for large thrombus burden. Mind you that the incidence of large thrombus burden is almost 16% in all STEMI patients. Of the 100 patients, 16% patient or 16 patient will have large thrombus burden. The large thrombus burden in STEMI complicate the primary PCI due to distal embolization leading to no flows, no slow flow. Even non-complete vessel embolization occurs while manipulating the device. At the moment, there is no ideal management strategy devised for this subset. And judicious use of DAPT, intra-coronary lytics, GPI, angiojet, excimer laser, direct and deferred stenting, and excimer laser may be useful. Now, these are various things which we can talk, but in India, we have to remember that the economy is very important. The most of our patients can't afford these expensive devices. So we have to deal in a situation which is large thrombus burden and at the same time reduce the chance of having a distal embolization in this patient. And most these patients in India present late. So they have red plus white thrombus. So intracoronary intrathrombic half-dose TNK, we have tried in 40 cases, a pilot study, and we found it very useful. There was no slow flow, there was no reflow, and distal embolization was not observed. How to do it? It's a very simple technique. Use a routine balloon, monorail balloon, split the membrane of the balloon, and after putting the wire in the through the thrombus, put the intrathrombic, that balloon in the thrombus, and deliver the TNK about 20 milligram in that slowly, and you will have very effective 20 minutes, half an hour, you will see artery flowing very well without any thrombus there. And then if still the residual stenosis is very high, then you can stent it. Quite a few number of patients did not require stent also after doing the thrombectomy with the TNK, and require proper large RCT to impact future guideline. Of course, there are several centers who have tried this intracoronary intrathrombic thrombolysis, and that seems to be giving a positive result with minimum of problem, but we require a large study. So one case that I have shown here is total occlusion, large thrombus burden in proximal artery. And this is a sham balloon, and we delivered a TNK 20 milligram into that. And you can see the complete resolution in thrombus. And no stent was required. So LTB cases are very challenging, very difficult to treat. Pharmacological intervention, thromboaspiration, thrombectomy are not favorable. Trying intracoronary intrathrombic half-dose TNK in thrombus grade 4 and 5 is useful. And in my practice, I do this, and I found it very, very, very smooth and nice. And we can try that in case we have that problem. Thank you very much for your kind attention.
Thank you, Dr. Ban, sir. A very interesting talk. Sir, fortunately, we have Dr. J.C. Mohan here, and we have missed his talk. So may I request Dr. J.C. Mohan to deliver his talk?
Yeah, of course, of course.
Unfortunately, we have missed his talk, sir.
Thank you. The issue was Stemi presenting between 24 to 48 hours. Routine PCI still has a role, but selection is a challenge. Dr. Bhandari did show you this therapeutic window concept of myocardial salvage, and it suggests that window of opportunity is based upon wavefront theory. And the issue which we need to keep in mind is this all data has been derived from animals, and human beings are not animals, although some animals can behave like human beings. Minimum delay to reperfusion is the order of the day, but time to onset of ischemia is not everything. We need to understand that relationship between myonecrosis and onset of ischemia is non-linear. So long as you keep that word in mind, the red line shows a linear relationship. This is what you would expect: onset of ischemia and degree of myonecrosis. However, this relationship is non-linear, and you need to keep that thing in mind. And as I said, animal models of ischemia and reperfusion are not valid for human beings. Why is that? There is a reason for there are reasons for non-linearity between myonecrosis and onset of ischemia. Some of the common denominators are intermittent or partial coronary occlusion, extent of coronary circulation, degree of ischemic preconditioning, which Suman talked about, metabolic status within the ischemic myocardium. Data also suggests that up to 41% of late presenters between 12 and 72 hours have more than 50% salvageable myocardium. And more than 50% salvageable myocardium was present in nearly 57% those individuals who had TIMI flow more than 0. So if you have a subtotal occlusion, chances are you are dealing with a large amount of salvageable myocardium. So finally, the area at risk one could find out from a perfusion study or maybe from another imaging. Final infarct site is the red part, but the loss of late presentation is there in the green form. And finally, you still are able to salvage that portion of the yellow, which you see on the right side, simply by doing late reperfusion in selected patients. The data from this came from the BRAVE study. BRAVE 2 study showed that the 4 years follow-up, those who actually had revascularization late between 12 to 48 hours by PCI still had a 45% reduction in mortality at 4 years. Number needed to treat being 13. Now, this is the reason why in ESC this became a class 2A indication. Why not class 1A indication? But because the study was underpowered. The OAT study, which actually opened up the artery 3 to 28 days after acute myocardial infarction, with a mean of 8 days, did not find any benefit of opening the arteries at a mean of 8 days. So it appears from the BRAVE 2 and OAT that the sweet spot for doing PCI possibly is between 12 to 48 hours. And this recent meta-analysis of late PCI versus conservative treatment shows the same thing. If you do it after 12 hours, there is definite benefit. However, the benefit is all lost in case intervention is done between 2 to 60 days. Based upon this, the ESC has given the guidelines that class 1 up to 12 hours, class 2A up to 12 to 48 hours, and beyond 48 hours is class 3 indication. Obviously, patients who actually have hemodynamic electrical instability, it continues to be class 1 indication up to and even beyond 48 hours. The Americans have slightly different take, and they believe that after 24 hours, it is a class 2B indication after fibrinolysis, but if there is no fibrinolysis and artery is occluded, it is a class 3 indication. However, delayed PCI can be deployed in selected cases within 24 to 48 hours. Let me show you quick 2 examples. 50 years male, non-diabetic, non-hypertensive, develops chest discomfort on Sunday morning of July 19th. Visit government hospital, ECG taken, reassured. Comes back and consults me when he's asymptomatic on 21st. That is nearly 48 hours after presentation. Asymptomatic and hemodynamically stable. Electrocardiogram shows some ST elevation in L2, L3, AVF, V4, V5, V6, some TV inversion. Question is, should I perform a catheter-based intervention? So I decided to do an angiogram. You would find right coronary artery having a 99% subtotal occlusion with a TIMI2 flow, and this was, of course, opened up. And a stent was put. Finally, what you saw was that there was a tissue myocardial perfusion grade between grade 1 and 2, more like grade 2. And of course, we know that this kind of thing probably has some benefit. Electrocardiogram showed stabilization of STT changes after PCI. The next day, now try to look at the 4-chamber view on left side and the 2-chamber view on the right side. There is absolutely no wall motion abnormality. And the overall ejection fraction is something like 65%. This is delayed, and you are seeing the contrast appearing now in the myocardium. Here is the contrast in the myocardium in a 2-chamber view. You can see the entire inferior wall getting enough perfusion. Perfusion in the anterior wall and inferior wall is pretty much similar. So this is point 1 of good perfusion of contrast. And you can now see it better in short axis view. So where is the infarct now? Well, you have a small sliver of non-transmural infarct in the basal infralateral part. The yellow arrow shows you a portion where you can see some darkness. So finally, from an area which could have got infarcted, you now have a very, very small infarction. Understanding that even after 48 hours, we have done a reasonably good job in myocardial salvage. The tissue grade perfusion of 2 and 3 have similar kind of excellent prognosis shown by Mike Gibson, and that was our patient was having. So the guidelines are clear that the primary PCI can be done up to 48 hours in selected case. How to select cases is the problem. Now, how to select cases, we don't know. As a matter of fact, the presumed area out of risk versus salvageable myocardium, you can use multiple imaging techniques, the specs being at the top. but it is not easily available and nobody probably is doing as a routine. Let me just show you another quick example and I finish it off. This is a 48-year policeman who presented for 24 hours after pain on November 12, 2010. Reason for intervention and imaging, and I'll show you the image. You have an osteoproximal 100% occlusion, and on the right side, you have opened up artery. You said, why do you open an artery which is after 24 hours? Well, the reason was when we looked at the echocardiogram of this patient on November 12, we found that the patient does have a transmural thickening of the apex, but the apex is the only part involved, despite this being an osteoproximal large LAD. We thought there was a big area which probably could be salvaged. This is exactly what happened 3 months or 2.5 months after angioplasty. We lost only the apex. Most of the other segments are working all right. The apex, of course, it is kinetic. So that is a small price to pay with the delayed angioplasty. So which patients can benefit 24 to 48 hours after STEMI? Ongoing chest pain or stuttering progression, intermittent ST segment elevation, STEMI ECG converted to non-STEMI ECG, still no Q waves like in our patient or tiny Q wave, our first case. Only hyperacute T wave despite 24 hours, subtotal occlusion on angiogram like the first case, and echo showing regional wall motion abnormality disproportionately less than the territory involved. And of course, patient with prior stable angina and one vessel disease where ischemic preconditioning can be presumed. So to summarize, ladies and gentlemen, time is not everything in STEMI. It is important, but it's not all that important. Where I wouldn't intervene, clearly I would need to do some imaging if I see moderate or more pericardial effusion, symptoms and signs of heart failure but no angina, a mural hematoma on echo, an entire vascular territory showing marked wall thickness, I probably would hesitate from doing an intervention. So STEMI with presentation in 24 to 40 hours, time is muscle, but muscle is a forest with a variety of trees. And time to balloon accounts for only 10% of the salvage myocardium. Rest depends upon multiple factors, and hence we need to actually find out those factors. Some of them are, of course, very clear based upon clinical parameters, some on imaging and some on angiogram. Thank you very much.
Thank you, sir. And I think we have a wonderful meeting. And now we are going to proceed for the last session, that is a validative function. And it's my moral responsibility to congratulate Dr. Nitish Naik for having a wonderful meeting. And I can say that his hard work has made this meeting a possibility. We have practically more than 1,000 attendees attending this meeting in all the national and international galaxy of cardiologists who has presented it. And I congratulate Nitish and I say that he has done a wonderful job. And in the last, because it's a moral responsibility of Dr. Suman Bhandari, he's here, he's an organizing chairman, to say the few words and make this conference closed. Sir, Dr. Suman Bhandari.
Yeah, so I think it's a very wonderfully organized conference virtually, and Nitish is 100% responsible for the good outcome. Of course, ably supported by Dr. Yadav. I can see Dr. Goswami, who was also there in one of the meetings to help us organize this. And of course, Dr. Mohan was also in that meeting. Various, of course, seniors like Dr. Manchanda, I can see, but I can't be sure he's there. So on behalf of the Delhi CSI, on behalf of everyone, I would like to congratulate Nitish for doing such a wonderful job and bringing glory to Delhi CSI. And of course, I think I'll have the comments from Dr. Venu Gopal, who's been the past president, what he felt about the meeting and how he would like to think this was done.
Thank you, Dr. Suman, for I think no words can describe the meeting, the effort taken by Dr. Nitish, Dr. Rakesh,
and all the people behind. I think it's extremely praiseworthy, I should say. And I think we should expect more from them in future also. I think a good this thing to Dr. Nitish. Thank you so much for a wonderful meeting.
So any last words, Dr. Goswami?
Thank you, Dr. Bhandari. Thank you, Nitish and Rakesh. 100 out of 100. I think Nitish is relieved today. What was the condition 3 months ago? And now, just now, Nitish?
Yes, sir.
How do you feel now?
अभी तो सर heart rate normal हो गया सर.
Normal हो गया ना? What about 3 months ago? That was 150?
Chronic tachycardia. No, sir, it is not my effort, sir. It is the effort of everybody from our organizing chairman, sir, yourself, sir, and the entire CSI Delhi branch, national CSI. I am very thankful for everybody's support. It is not my effort at all. 99% effort it is of everybody else. And I'm very grateful to all our speakers, especially JC Mohan, sir, who's come back from his engagement and given this talk. I'm very sorry for any mistakes, errors, slippages of time. Please pardon me. These were errors, inadvertent errors. But I'm very grateful for all your support.
Thank you.
Dr. Suman, sir, your last word.
I'm just asking Dr. Bhandari. You are just, where is the ice cream? You are getting the ice cream and rest of our audience is not getting. What is that?
That was the Amul Kulfi.
Why we are not getting? You are getting and you are attending, you are president. But we should also
we are organizing some post-conference.
But today you are only getting it.
Kulfi syndrome.
Anyway. Okay.
Yeah. So thank you everyone.
So goodbye, good night.
Good night everyone.
Good night, sir.
Okay.
Good night.
Thank you, Dr. Bang.
Thank you. Thank you very much.
Bang sir, anything you will want to?
No, nothing.
Thank
Everybody said everything, and Nitish, of course, praiseworthy.
Yes.
Thank you, sir.
So all the best, Nitish. You will soon get another assignment to do another conference. I'm sure. You know, Dr. Goswami will get you another one soon.
This assignment given to Nitish last year. Last year, I think in March. No, last year when he became the convener of Stemi Council.
Yes.
It's all right.
Thank you everyone for being here. So
okay. Good night.
Good night. Good night. Take care.
Nitish, ये दोनों ही तो वंडरफुल काम किया साले.